Dear colleagues, welcome to our meeting. As you know, the pathologic examination is very important in HPB surgery. According to their reports, we planned the operation, and during the operation, we need consultation from pathology department to get negative borders, and to get negative border is important to get good survival in our patients. The other important subject is to get enough and good samples from suspicious points. At this point, we need radiological and endoscopical support. And in these subjects, we are very lucky as we are working with excellent pathologists, endoscopists, and radiologists in our faculty. They always do their best to help us and share their knowledge with us. And we are very with this cooperation. And in this meeting, they will translate their experience in this field, in this meeting. Especially, I want to thank to Professor Gürkan Telcioğlu as preparing this meeting. Also, I especially thank to Mustafa Kerem as having relations of this meeting with international societies. I wish all of you a productive meeting. Thank you.
Thank you, Dr. Alper, for your speech. And after that, I want to introduce Dr. Mustafa Kerem, the president of Turkish HPB Surgery Association.
Honored colleagues, esteemed faculty, and distinguished guests. Good morning and warm welcome to Pancreatic Pathology for HPB Surgeons. As president of the Turkish HPB Surgery Association, it is an honor to stand before the leaders, esteemed professors who are dedicated to improve the lives of the patient with HPB disease. I am delighted to share that our pancreatic pathology course of HPB surgery has been awarded a silver seal endorsement by European African HPB Association, demonstrating our commitment to advancing surgical knowledge and international collaboration in this critical area. Pancreatic pathology presents significant challenges. Today, we will focus on translating the latest advancements, including fluorescence section analysis, margin management, and post-neoadjuvant pathologic evaluation into better patient outcome. The vital role fine needle aspiration and fine needle biopsy on-site cytologic evaluation in diagnostic pancreatic lesion will be also emphasized. We'll also have a multidisciplinary discussion with members from surgery, radiology, and pathology. I want to express my sincere appreciation to Mark Bezeling, President of European African HPB Association, Çötül Soredet, Chair of the Education of this association. Thank you for their support and partnership. Professor Volkan Assay and all our expert speakers, Koç University School of Medicine and Eramki Ames Center for hosting us warmly, and as special thanks to my dear friend, Professor Gürkan Telcioğlu. I encourage you to actively participate in discussions, connect with colleagues, and be inspired to share the pursuit of the excellence. Together, we can significantly impact the lives of those affected by pancreatic disease. I am confident this course will be a great success. Thank you, and let's start.
Thank you, Dr. Kerem. And now we will speak to our first session. And our first speaker is Dr. Volkan Atsay. He is the head of pathology department of Koç University, and he had two topics to speak. The first is about algorithm approach to pancreas tumors, and the other one is the controversial topics. So
thank you. Thanks for the invitation and the organization to HPB Society in Turkey, and especially Dr. Professor Gürkan Tellioğlu for his great efforts in organizing this meeting. We envisioned, I don't know if the Zoom is hearing us okay. I hear it from here. If not, then we'll do something about that. So we envisioned this to be a little bit informal in the sense that if there are any questions, if you have any comments, please raise your hand, and maybe Zoom, they can also inform us, and we can just stop and have further discussions. PowerPoint açmamız için yardımcı olabilecek misiniz? So actually, I organized a talk. So the second part of the talk, I integrated to the rest of the presentation, some of the challenging issues. And I tried to approach to the differential diagnosis in pancreas pathology in a more algorithmic way. The first part will be more radiology and gross-based classification, and how we use really radiologic appearance of tumors in classification of pancreatic neoplasia. I think this will introduce us some concepts and also help in our daily practice, hopefully. We have a dichotomy in pancreatic pathology. For tumors, there is the dichotomy of the solid versus cystic lesions. When we have a solid lesion, the vast majority of those prove to be pancreatic adenocarcinomas or some other malignant neoplasms. When there's a cystic lesion, we are a little bit more happy for the patient because there's hope that this could be more benign or low-grade neoplasm. So that's where our algorithmic approach starts from the get-go. And then the solid tumors also we evaluate in two broad categories. The first one is the more scar-like, serous, ill-defined lesions that are difficult to recognize both on gross examination and as well as radiologic examination. And the second group are the fleshy demarcated ones. They are fleshy by gross examination. They typically appear as homogeneous lesions in radiologic examination. And the differential diagnosis for these are significantly different. Their microscopic correspondence for the scar-like or serous lesions, we often have a lot of desmoplastic stroma or fibrotic participation that gives that more scar-like appearance. Whereas for the second group, there's a lot of cellularity, and that cellularity leads to more homogeneous lymphoma-like appearance of the tumor. When we come to cystic lesions, we also have dichotomy, although we don't use this as much anymore because the group that's called microcystic, meaning there are numerous tiny little cysts, hundreds, and forming this well-demarcated lesion. This is very characteristic of serous cystadenoma. So there's only one entity in this arm of this differential diagnosis, whereas the megacystic ones, meaning large cysts with multiple loculi, each locule is relatively large, then we have a wide spectrum of differential diagnosis for those. So this is the broad differential diagnostic four groups that we deal with, and then that's how our differential diagnosis starts. For the serous ill-defined lesions, for this group, the main differential is between pancreatic ductal adenocarcinoma and chronic pancreatitis. So they're vastly different. Most of them will prove to be pancreatic ductal adenocarcinoma. By the way, during this presentation, I will call PDAC referring to pancreatic ductal adenocarcinoma, the main tumor of the pancreas. For this group, we have the, and for pancreatic ductal adenocarcinomas, the most important issue, this slide is probably the most, one of the most illustrative examples, is the presence of, again, abundant stroma, collagen, desmoplastic stroma. So this picture here probably summarizes most of the problems in pancreatic pathology. If you take a needle and insert to this tumor, you can imagine we'll just see one gland that is abnormal, and the rest of it will be all fibrosis. Emre Hoca calls me down to endoscopy unit and he says, look, we are right in the middle of the tumor and you're telling me there is nothing here. I am telling you there is nothing because unfortunately, often there's a lot of fibrous stroma with minimal cells or no cells in pancreatic adenocarcinomas. Same is true also for frozen sections. If you take a frozen section of this area, we'll see just one gland and it may be atypical, and we may give you the diagnosis. There's an atypical, maybe carcinoma, I'm not sure. And the next day, when we look at the whole section, the permanence, then we realize actually that gland was also part of the adenocarcinoma process. So suddenly we realize it was an adenocarcinoma. For the fleshy, demarcated, the homogeneous tumors, the differential diagnoses are essentially on all non-ductal neoplasia of the pancreas. And we'll come back to what we mean by non-ductal, but just to list them briefly here, neuroendocrines, acinar, pseudo-papillary pancreatoblastoma, and always in the differential, of course, are secondary tumors and metastatic lesions to the pancreas. For megacystic lesions, as you know, mucinous ones, IPMNs, MCNs, IOPNs, will go through these abbreviations to explain them better. And there are a whole host of other cystic lesions that occur in this organ that present as these megacystic and multilocular cystic lesions. And as I mentioned earlier, this pattern is actually very specific in the sense that when I see this, we don't even have to take microscopic examination. It's that specific for serous cystadenoma. Just one section will do the trick, and they're often large tumors. In contrast, for these kinds of lesions, as we'll come back to, we need to do a lot of sampling and examination to rule out cancerous transformation. Now, this algorithm works really well. It's quite consistent. However, as in anything else, there are also exceptions. There are PDACs, although most of them are solid, about 3 to 5% can present as partially cystic masses. Similarly, neuroendocrine tumors, about 5 to 10% of them present as cystic lesions. Although SPNs are called solid pseudopapillary tumors, actually a significant proportion of them have cystic degeneration, such that in the past we used to call them solid and cystic epithelial neoplasm, papillary cystic epithelium. So the word cystic was in the name of this entity in the past. And yes, we discussed microcystic adenomas being very specific, that microcystic pattern being very specific for serous cystadenoma, but there are solid versions of this entity, typically misdiagnosed clinically as neuroendocrine, because as you can imagine, homogeneous is not showing the same microcystic appearance that's characteristic of the entity. So these exceptions, of course, need to be kept in mind, because when this happens, of course, it's 100%, right? That's one patient and that's it. So it's important to keep this in our differential. So when we come to the frequency, and even in great textbooks on the topic, you'll find numbers that vary greatly. But this, I think, summarizes the current reality in the best manner. The majority of the pancreatic pathologic lesions are actually cysts. But that's because cysts are very common in the pancreas, as we'll hear in the afternoon from radiology perspective. If you look hard enough, you find cysts larger than 2-3 millimeters in all elder population, almost half of the population. So they are much more common. But when you come to the resection specimens, what we are exposed to as surgeons and pathologists, of course, the indications are different and the reasons to operate are different. So about 60% of the resections are for pancreatic ductal adenocarcinomas or their mimickers, and about 30% are cystic lesions that are more pre-malignant, and about 10% of the resections occur for, of course, this changes from institution to institution, but these are the ballpark numbers that can be kept in mind. So these 4 groups that I illustrated to you, we mentioned some of the respective findings, but I would like to go over the challenges that each group presents, challenges for both pathologists and during daily practice. The serous ill-defined ones, again, the differential being PDAC versus chronic pancreatitis. As you can imagine, when a biopsy is performed, it's typically not very cellular because the collagen doesn't come into the biopsy. It yields some glands, typically, The problem is those glands can be atypical, but may not be definitive as a cancer, or we struggle whether it's reactive atypia versus true adenocarcinoma. When we come to the homogeneous demarcated group, the differential is very different, as I mentioned, non-ductal ones. These yield fairly cellular specimens because, as you can imagine, the tumor is very cellular. It doesn't have much stroma. So if you can really, if they're not small, if they're big enough, often these days, not in the past, but these days, fine needle aspiration can extract fair amount of cells. And the cells are often monotonous because all these entities are characterized by more monotonous cellularity. So we can come to the conclusion that we are dealing with this group in most examples. The problem is which one of this group becomes a issue. There was a discussion a few weeks ago in our bi-weekly meetings whether this group is really diagnosable by FNA. It really is. I mean, FNA can be extremely effective in dealing with this group. Again, with the caveat that we may not be able to be specific for neuroendocrine versus SNR versus others at times. So the challenges this solid group present, as I mentioned, especially the abundance of desmoplastic stroma, this becomes a more significant problem for bile duct lesions. We see collagen and we see few very atypical cells. One thing I can tell for the pathologists in the audience, if you see a very hyperchromatic boxcar nuclei emits collagen, that's most likely adenocarcinoma. In ulcerated regions, we ignore this kind of atypia, but in a posticellular fibrotic stroma, this is often indicative of adenocarcinoma. And target units can be really widely scattered. This is a common bile duct frozen section edge. And you see there are only few glands, and then of course it becomes challenging to make the diagnosis. And much more important for us pathologists is the adenocarcinomas can be deceptively benign appearing. They look so mature. Actually, I like showing this picture in pathology courses because this really looks a perfectly normal and benign looking gland, but it's actually from a metastasis in a lymph node. And it's really hard pressing to call this adenocarcinoma due to its maturity, but there are some subtle findings we make use of to recognize it as adenocarcinoma. Bile duct brushings, will come back and we'll present you a case later on. Bile duct brushings are really, in terms of small biopsies and FNAs, are the hardest because, you know, pancreas is hard to induce ulceration in the pancreas or just too much reaction or inflammation. But common bile duct gets inflamed even with standing and prior biopsy, and that inflammation leads to atypia, and then it becomes very difficult to distinguish from adenocarcinoma. Here is one example. Only few cells to make a determination from. And most pathologists, we did a consensus study at some point. Most pathologists did not want to call this adenocarcinoma. Some of us did, and it was indeed adenocarcinoma with a lot of neutrophils. It was not reactive atypia. But again, to illustrate to you the fact that this can be quite subjective and difficult. So we mentioned that solid serous lesions, the vast majority of them, when you have this scar-like configuration, they will prove to be pancreatic ductal adenocarcinomas. But important to keep in mind, not all of them are that. What I call pseudotumoral pancreatitis, meaning benign chronic pancreatitis or benign conditions that can closely mimic adenocarcinoma due to mass formation, ill-defined lesion, occurs and accounts for about 4 to 13% of pancreatitis in any institution you go. That's not talked about much, of course, but in any institution you go, this figure goes from, nowadays it's less, but it used to be around 5%. It's probably down to about 2% these days with improved MRI and other technology. Nevertheless, 1 in 50 patients, you will think you're operating on a adenocarcinoma, but it will prove to be this pseudotumoral pancreatitis. And the two entities that really need to be kept in mind, one of them is autoimmune pancreatitis. Let's start with that. Autoimmune pancreatitis, you see how the pancreas is entirely abnormal and replaced by fibrosing inflammation here. Actually, this is quite a nice example because it has that posticellular fibrous band in the periphery that creates a halo in radiologic examination, which allows the diagnosis of this entity. By the way, why is that halo forming? Or maybe the question should be, why isn't the halo form in PDACs? Because PDACs don't stop where they go, right? PDACs are very infiltrative, and we'll come back to that point. They do not stop at some point to create this halo-like reaction around them. So this is a good clue to the diagnosis of autoimmune pancreatitis. When you examine the lesion itself, you often find significant duct-centric lymphoplasmatic inflammation, what we call peripheral uveitis, meaning selective inflammation and obstruction of some of the veins. You see a healthy vascular structure next to it. And also important are abundant IgG4 positive plasma cells. So this, what we used to call autoimmune pancreatitis, the current name for it is actually IgG4 related sclerosing disease. It was originally described in pancreas. It's still called autoimmune pancreatitis type 1, but is in the spectrum of IgG4 related sclerosing disease. Now, one comment I would like to make of this entity, when this was first recognized, the field did not realize that it can really look like cancer. And a lot of the autoimmune pancreatitis cases got operated as cancer and could be perhaps avoided. Now I think everybody learned about this, and now we are in the other end of the pendulum. We are calling things a little bit more readily as IgG4. We see a mass. Oh, you know, there's inflammation, biopsy shows some plasma cells. Oh, maybe this is autoimmune pancreatitis. I think we are harming the patients by doing that too. So real careful workup, close and frequent follow-up is needed before jumping into the conclusion of autoimmune pancreatitis. I don't want to get into the details, but IgG4 plasma cells are actually everywhere. So don't do duodenal biopsies or ampullary biopsies. There was literature on this at some point. Why don't we do ampullary biopsies? If we see IgG4 plasma cells, we can make the diagnosis. Absolutely not. Please don't even think about it. There's no diagnostic test by mucosal biopsy to make this diagnosis. You have to have the constellation of all the radiology, IgG4 plasma levels, what the patient has, and the follow-up, and etc. But mucosal biopsies, please don't do them. IgG4 plasma cells are everywhere. Pilonidal sinus, for instance, most surgeons know, have the highest number of IgG4 plasma cells than anything else. And they are pilonidal sinus. Okay, so we need to be careful not overdiagnosing this entity. Going back to the other entity, actually, depending on the population, like where I worked in the US, this was very common, probably due to alcohol consumption, paraduodenal or group pancreatitis. They really present like periampullary cancers, often localized on the accessory ampullary component of the duodenal wall. So endoscopically checking the accessory ampullary region and focusing on some of the salient features may allow the diagnosis of this, but you see what a mass lesion they can form. This more yellow spots here are remnant pancreatic elements. All the white and hemorrhagic things are actually the pseudotumor mimicking the cancer. When we come to the, am I going too fast? I tend to go really fast. Is it okay? Followable? Yeah. Cellular monotonous group, the ones that again form more demarcated, sometimes even encapsulated lesions. For this group, again, the differential is non-ductal neoplasia. We often on cytology can tell these are non-ductal, or we put ourselves into this differential diagnosis. However, there may be challenges in distinguishing between these. We have learned, we have seen so many of these. Now I feel quite comfortable, and our team, we make the distinction and diagnosis probably more than 98, 99% of the time now. But in the learning curve, this can be really difficult for pathologists who are not as familiar or seeing these things as commonly. So depending on where you work, you need to understand how difficult this can be and be patient about that. Non-ductal tumors, I put here the most characteristic examples just for you to appreciate what they're about. This neuroendocrine tumors are characterized by isletic or nest-like configuration with prominent capillarization that gets translated to radiology. When they are well differentiated, acinar cell carcinomas do really resemble acinar cells with the acinar granules in them. Truly, zymogen granules, Unfortunately, most acinar carcinomas do not bother to do that. They are poorly differentiated. So pseudopapular neoplasms are peculiar in the sense that they have beta-catenin and E-cadherin alterations that lead to this selective discohesiveness of the cells away from the vascularity. And that's why they have a pseudopapillary formation, as you see here, almost rosette-like configuration. And pancreatoblastomas, as in any other blastic tumor, have multiple cell lineages. Pancreatoblastomas, by definition, almost always have acinar differentiation, very frequently have neuroendocrine differentiation, and occasionally even ductal elements in them, as seen in this example. So they're blastic in the sense that they can go into multiple lineages. The problem is often these are poorly differentiated and do not bother to do the mature representations of their cell lineage. So pseudopapillary neoplasm we recognize by the beta-catenin expression. Acinar carcinomas by trypsin expression. Trypsin is one of the enzymes that highlight this. This is one diagnosis that makes me very uncomfortable in pancreas pathology, because when it is really poorly differentiated, we have to rely on the immunohistochemistry, on the trypsin. And if your trypsin is not working, you are doomed, because it becomes very difficult to make that diagnosis. Immunohistochemistry is an extremely helpful tool. It's never the sole determinant. We mostly base our diagnosis on morphology, but there are cases in acinar cell carcinoma that we really need to help from trypsin. And if your trypsin is not working that day, then that becomes a big problem. Pancreatoblastomas are actually acinar carcinomas or neuroendocrine neoplasms that have distinctive, these moral formations that are beta-catenin positive. I don't want to go into the detail. One thing I can tell you, as clinicians and surgeons, pancreatoblastoma is severely underdiagnosed in the community by pathologists due to lack of recognition. Sometimes they present as retroperitoneal mass, and unless you think about it and do your proper stains, it gets diagnosed as all kinds of sarcomas, even to Ewing sarcomas and other things, unfortunately. So coming to the cell lineage-based classification of pancreatic neoplasia. Now, pancreas is composed of essentially 5 elements. The most common one, or most abundant one, being the acinar cells. Islets are scattered as independent organs almost within the pancreas. We have the ducts and we have the supportive tissue. Now, ducts, although they are not the most abundant, and although they are the simplest, those are the ones that gives us the biggest trouble. Presumably because they're exposed to the outside world. Presumably because they are more proliferative and more primitive. They are the ones that lead to cancers most often. So most of our neoplasia in the pancreas are of ductal type or ductal lineage. So by the way, we say ductal origin. You know, my concept is, I don't know when it originated. I wasn't there. I couldn't prove it. So we prefer to call it ductal lineage or ductal differentiation. So we see what it is doing rather than where it is coming from. So ductal lineage is characterized often by mucin production. Now, mucin can be intracytoplasmic, and in most cases it is. And mucin can be stromal abundant, like mucinous colon cancers, in which case we call it colloid carcinoma, and it has a much better prognosis. And mucin can be luminal, secreted to the lumen of the ducts, as in IPMNs, which can then be even extruded from the ampulla of water, creating this diagnostic mucin oozing from the papilla of water appearance. So there's a spectrum of mucin formation. Of course, the more it is, generally, the more that is good in the pancreas, but it doesn't always work that way. And along with the mucin being the hallmark or main lineage specific finding, KRAS mutation is also very common in any ductal neoplasia. Even when ducts are injured and they show metaplastic changes, KRAS mutation comes in. With that, I would like to emphasize to you, presence of KRAS mutation doesn't mean cancer. Unfortunately, there's literature kind of indicating that, but KRAS mutation can occur in very early neoplastic transformation when things are low-grade dysplastic, but not yet cancerous. And along with the mucin formation, MUX, CEA, and CA19, which are mucin-related oncoproteins, are often expressed in the cells and often secreted both to the blood. So we can detect some of these things in the serum and also in the cells as well, and also in the cyst fluids. I mentioned earlier, invasive ductal adenocarcinoma, what we call PDAC, pancreatic ductal adenocarcinoma, is in the spectrum of pancreatobiliary type adenocarcinomas, which are characterized by tubule formation, these glandular structures with some mucin in them, if you do mucin stains, desmoplastic stroma leading to the scirrhous appearance. Now, one thing about PDAC, and if we can understand why and resolve this, we'll be very successful in treating this tumor. It has very high propensity to infiltrate things and very comfortably spread through them. Perineural invasion, seen 90% we say, but probably if you look carefully enough, if you do step sections, maybe even higher than that. Vascular invasion is very common. The striking thing is, even when they infiltrate the nerves and vessels, they still line them. I jokingly say they almost want to be nice. They're like psychotic cells that are trying to do something mature, something nice. But the problem is also with this, they can spread far away from the original tumor. And that is the biggest problem for surgeons. By the way, this ability to line things and just spread through surfaces also manifested in when they metastasize to other organs. Metastatic PDAC in ovary, please keep this in mind. I'm sure during your practice this will happen. Metastatic PDAC in ovaries are often misdiagnosed as primary mucinous cyst adenoma, not even borderline, adenoma, because they are so mature, they form these nice cysts, and we have a large collection of these cases, and there are many studies on this, and they present as and actually that's more common for them to present as cyst when they metastasize to ovary than as solid tumor. Some fascinating phenomena. And they do the same thing when they metastasize to lung. They line the alveolar spaces leading to this bronchoalveolar carcinoma pattern. So let's say you resected a PDAC and the patient has lung. By the way, lung metastasizing PDACs often behave well. I don't know why, but solitary lung metastasis cases, and we've seen many of these examples, it must be some propensity biologic phenomenon that if there's a solitary lung metastasis, that's actually often good news for the patient. There was a patient, everybody knows, in American hospital, I think Oranoja had operated, alive 8 years later, unfortunately died later on. So this is, the reason I'm telling you this is, when you have a PDAC case and a lung had a solitary lesion, they resected it, and pathologist is calling it bronchoalveolar primary carcinoma, it may be good to tell them, look, you realize this patient has PDAC. Would you like to re-review your case? Because often it will prove to be metastatic PDAC. Now, pancreatobiliary type adenocarcinomas also encompass as a group gallbladder, cholangios, extrahepatic, and a subset of ampullary carcinomas because they have very similar morphology, very similar spreading patterns, desmoplastic stroma, aggressive behavior that makes us kind of collect them under one heading, although increasingly we are seeing subtle molecular and other differences between these two. But currently, that umbrella category helps us because you send us a biopsy like this somewhere in the peritoneum. I cannot tell if this is from pancreas or bile duct or intrahepatic, you know. All I can say is this looks pancreatobiliary. It may be gastric because pancreatobiliary adenocarcinomas and gastric foregut adenocarcinomas have overlapping morphology. So that's why we collect them under this heading of PB adenocarcinoma. Here are examples. This is distal common bile duct cancer. This is a non-ampullary duodenal cancer that has pancreatobiliary features and ampullary ductals that are overlapping morphology, but they have the same aggression, similar immunophenotype, etc. Having said that, depending on where they are localized, of course, they have some subtle differences and behavioral differences. In our experience, ampullary ones do much better than the pancreatic ones. And this is, most of the literature also indicates that. But that may be, you know, spreading pattern, early detection, and other factors may be playing a role in this, obviously. Now, one thing that we always have to emphasize is not all pancreatic adenocarcinomas are the pancreas cancer. So PDAC has become almost so common and is so important and is so critical that it is now common synonymous with pancreatic cancer. So, I mean, this question comes up, of course, with the iPhone guy. What's his name? Yes, Steve Jobs. Steve Jobs, when he was diagnosed and 3 years later, he was still alive, right? People were calling me and said, you say PDAC, in those days, PDAC was killing within 1 to 2 years. He was alive after 3 years. I said, like, that's because he is rich. He can get good therapy and stuff. Actually, the reality is Steve Jobs, you know, he always thinks outside the box. He had a neuroendocrine tumor, but he thinks outside the box. He refused the treatment. He wanted to have herbal treatment. If he had gotten resection at that time, he could have been even cured. So the point here is not all things are called pancreas cancer are PDACs. In fact, in many institutions, we check the database, and when you go back and look at databases, surgical databases, often things that have been advertised as PDACs, especially if they are long-term survivors, prove to be from common bile duct ampulla, neuroendocrine tumors, IPMNs that were called malignant because they had in situ carcinoma, et cetera, et cetera. So it's important to keep not all pancreas cancers are PDAC. Now, malignant neoplasms of ductal origin, even there are important subgroups evolving, developing in this ductal, if you will, ductal cancers, ductal adenocarcinomas. One of them, of course, the most common is ordinary PDAC that I illustrated to you. There are some morphologic variants. This is the foamy gland I showed earlier. Some of them form very large ducts. Some of them form these cribriform vacuolated structures. Currently, we do not know the meaning of these variants, but increasingly, these are proving to be different molecularly. So in time, these may be different targets for oncologists. Right now, they are just morphologic curiosities. We don't even report them, but we notate them for future studies. Now, when we come to this group, now this group is significant. These are PDAC-related tumors. They are almost like dedifferentiated, higher grade transforming metaplastic versions of PDACs. They are of ductal origin, ductal differentiation. They are often accompanied by ordinary PDAC. So you find the conventional tubular PDAC component somewhere, but they also have a distinct component that changes the biology of the tumor. For instance, adenosquamous carcinomas. Unfortunately, adenosquamous is defined in WHO as more than 30% having secondary component. But in our impression, even if there's focal squamous differentiation, it's probably already on its way to become a different tumor. Once you define it with 30%, these are relatively uncommon. 1 in 50 PDACs have adenosquamous. They tend to cluster together with the basal-like group. By the way, this is coming to pancreas from breast. In breast, you may know there is luminal A, luminal B, classical basal types that are treated very differently. We are going in that direction in the pancreas as well. The basal-like group is proving to be different molecularly and biologically and will probably require different treatment in time. And there are these bad actors like adenosquamous, but there are peculiar tumors that have also ductal lineage, also have conventional PDAC component, but if they are predominant, like colloid carcinomas, they actually behave quite well. Please keep in mind, these form large tumors, gelatinous, a little bit more demarcated than usual. These are intestinal lineage cancers in the pancreas. They have MAC2, CDX2, which are very good intestinal lineage markers. And we believe these need to be treated more like intestinal cancers, perhaps. Of course, there's no randomized study on this, but they're really, everything about them indicates they're intestinal type adenocarcinomas, and their 5-year survival is more than 60%. They often arise from IPMNs, so they become important in analysis of IPMN groups. A subset of PDACs that's becoming interesting and significant are those that don't show the classical sclerotic scurus pattern. We are illustrating the classical PDAC features here. Again, pseudotumor-like, scar-like appearance, ill-defined, tubule-forming desmoplastic stroma. Now, there are cancers in the pancreas that are of PDAC origin, but instead they form these demarcated tumors that have central necrosis and much more cellularity and pleomorphism. We call them centrally necrotic hyalinizing demarcated cancers. Actually, they are metaplastic in their lineage, basal-like. They have the GATA6 loss. I don't want to bore you with some of the molecular details, but the important thing for you to keep in mind in your daily practice, if you see a nasty PDAC, but it is demarcated with central necrosis, you may be dealing with this group. I think this group will be treated differently by oncologists in the future as well. This one is a very peculiar entity illustrating the plasticity of cancers. Somehow this cancer is attracting a lot of osteoclasts, which is actually a bone cell. And somehow these bone cells are abundant in this tumor. Why they come there, we don't know. But once they are there, they must be doing something because these guys behave significantly better. Not all of them, but a subset of these behave significantly better than our ordinary PDACs, although they look undifferentiated and high grade. Again, these are also more demarcated cancers. Now we come to probably a group that is more significant because there's subtle features that need to be appreciated in daily practice are what I call the tumoral intraneoplasms associated cancers or adenoma carcinoma sequence, meaning IPMN, MCN, ITPN, IOPN related. I know these abbreviations are very scary, but I'll try to clarify them for you. Let's start with the concept first. Tumoral intraepithelial neoplasm. What we mean by that? Dysplastic cells forming large masses, just like an adenoma in the colon. But unlike adenomas in the colon, they are growing in the ductal system typically, so they cause cysts. So cystic and intraductal neoplasia is this group. Again, adenoma carcinoma sequence. So the theory or the observation is whatever is leading these dysplastic cells to keep growing within the ductal system and form these large cystic papillary nodules are conferring a different biology. So they start to act different than our ordinary pannin-related PDAC pathway, our ordinary cancer pathway. And this also brings us to the cystic lesion and the classification of cystic lesions. Everything okay? Classification of the cystic lesions. This is not an official classification, but I think it's a good way to look at different lesions. It's through cyst, and there are degenerative cysts. Degenerative ones meaning pseudocysts and also solid tumors that have necrotic degenerative changes. Now, these are often malignant neoplasia with degenerative necrotic phenomenon. The true cyst mostly proved to be mucinous in nature, and we mentioned very common cysts in the pancreas. Most of them proved to be actually this mucinous group and IPMNs. We'll go into the details of the classification of these further, but the important thing to recognize is that these are pre-invasive, precancerous lesions. They may have cancer at the time of diagnosis, or they may develop into cancer in time. Now, everything okay? Anything I need to do? All right. Mucinous lesions used to be very confusing at some point. Now we classify them as based on ovarian stroma. Those with ovarian stroma are called mucinous cystic neoplasm, and if there's no ovarian stroma, then we go to the IPMN. This is the algorithm. To the IPMN, its mimickers or one of the related or their kindreds, cousins, as I call them, is what we are dealing with. Ovarian stroma is indeed ovarian stroma. So mucinous cystic neoplasms, you see, they are defined by ovarian stroma. Without ovarian stroma, we do not call it mucinous cystic neoplasm anymore. All the literature is different. So when you see a paper, for instance, that says we analyze mucinous cystic neoplasms, and 80% of them are women, they're probably including IPMNs and other cysts, because if you define the entity by ovarian stroma, 98% are females. I've seen 3 examples that were in men that had convincing ovarian stroma, but that is unusual. And most of them are also in the body and tail, forming these demarcated multilocular cysts. They are obviously of ductal lineage, ductal origin, but they do not show overt communication with the ductal system. We presume they're arising from the really very small branch duct-like things, maybe duct chews, if you will, and with the ovarian stroma, and they form these isolated multilocular cysts. Here's a beautiful example of adenoma carcinoma sequence, low grade versus high grade. If you have only this, we'll call this a low grade lesion. We just follow the patients at home. If this is carcinoma in situ, by the way, WHO does not want us to use the term carcinoma in situ in GI tract and pancreas. I think it's not good. Asians do it, and I also use it parenthetically, high-grade dysplasia carcinoma in situ, because this is carcinoma in situ. These are cancer cells that have not yet invaded. They have carry all the mutations and all the features of cancerous transformation. Some of them are really large. Even I can tell that this patient has hip dislocation by looking at this radiology here. Joking aside, they can be quite readily identifiable because of their large size, but large size may not mean that much. It's the more nodule where the cancer develops is what we need to focus on. Just like in IPMNs and MCN2, mural nodules, papillary elements, complexity actually reflects the cancerous transformation. By the way, earlier literature, MCN, the papilla formation was not emphasized, just like IPMNs. They have papilla formation. And in fact, those that have papilla formation, which I presume will translate as mural nodules in radiology, although I have not confirmed that, papillary nodules are the ones that will develop cancer in most instances. So it's unusual for just multilocular cysts without complexity and nodules to become invasive in MCN. MCNs have invasive carcinoma in about 1 in 6 cases, typically larger examples. Just like in, actually, I really think Sendai-Fukuoka criteria can be used for MCNs. Extremely unusual for a MCN that's smaller than 4 centimeters to have invasive carcinoma. But the issue is, how long are you going to follow? The same old question, right? Okay, it's 3 centimeters. Are we going to wait for this 50-year-old lady? How long are you going to wait? So taking it out still, I think, is probably more justified, because they can progress if you to give them time. Most of the invasive cancers that develop in MCNs are PDACs. So that's why, yet another reason, MCNs, yes, if they are non-invasive, perfect, send their home. But you can watching it, once they become invasive, just like branch duct IPMNs, once it's invasive, it's bad kind. So we don't see colloid carcinoma, for instance, in these guys. So invasion is really bad. In our experience, once it's invasive, 5-year survival drops to 20%. Yes, there's a study that says if they are very minimally invasive, they are cured. They have good prognosis, but minimally invasive, they are just less than 2-3 millimeters, and some of them look like maybe they are not really true invasion, but just invagination. So, but in our experience, even small invasion in MCN is not good news. Coming to the IPMNs, there's a preoperative algorithmic approach to IPMNs as branch duct versus main duct. Branch duct IPMNs often preserve the main duct, but often you also see a little bit of involvement, but minimal. It's at least not dilating. It's not dilating the main duct and showing this granularity. This is probably the answering duct by the way. And the multilocular cystic transformation with these are the papillary nodules. And again, sampling needs to catch these things because that's where often cancerous transformation also take place. Main ducts typically are much more florid, papillary, and involving both main and branch ducts in a very complex fashion. And not surprisingly, of course, that leads to obstruction and chronic pancreatitis. Whereas in branch ducts, the rest of the pancreas could be pristine, very clean. As illustrated in this example, they are multilocular cysts. Now, for cytology and diagnostic purposes, these branch duct IPMNs, we can help you in a very limited fashion because you do an aspiration, it doesn't yield cells. There won't be cells, and if they are, they won't be readable. Even the presence of mucin, sometimes we use in cytology. Oh, there is abundant mucin here. Maybe you're dealing with an IPMN. But our help to you in diagnosis of this is quite limited. Of course, chemical analysis and stuff can help a little bit, but in my opinion, most of it is high quality radiology will be the most helpful in assessing these lesions. Don't get me wrong. Of course, you can do EUS because if there is, sensitivity will be very low. But if you see convincing cancer, then you gotta really go in because our purpose in IPMN is to catch it in situ carcinoma, high-grade dysplasia, before it becomes invasive, no? So that if we catch it in that stage, that's the best help to the patient. And probably the only way to say this is really in situ carcinoma is still cytology. So I don't know if I'm explaining it properly, but sensitivity is low. We may not be able to help you in most cases, but if you do FNA and we tell you, look, there is carcinomatous transformation here, then we are doing great help because that's the time to resect for sure immediately. Adenoma carcinoma sequence illustrated nicely here in this IPMN that is intestinal type. If I show this picture to pathologists, they will say this is villus adenoma of colon. It really looks like that. And here it's intramucosal adenocarcinoma or carcinomatous transformation. You see the complexity. You know, even those of you who are not doing pathology every day, I'm sure I appreciate this carcinomatous transformation here. That's why these are adenoma carcinoma sequences that eventually lead to invasive carcinoma in substantial proportion of the cases if this is left alone. So just to go over, there are different types of these IPMNs and intraductal neoplasia that have different associations and different progression into cancer rates. The most problematic one are the gastric types. Most incidentalomas, you know, those little cysts that we find in pancreas, prove to be gastric IPMNs. Not all, but most. Now, and they're often small, as you know. And we use, this is Sandai-Fukuoka criteria as actually mostly for these guys. The problem is invasion is in long term, about 15% of these develop the invasive carcinoma. The problem is when they infiltrate, it is the bad kind, it's PDAC. So it looks innocuous, it's often quiescent, it just stays there. But when it transforms into cancer, it's too late. And it can transform into cancer, you know, there are, I'm sure some of you are following that literature. The high-risk individual early cancer diagnosis, they follow families with IPMN, they follow IPMN patients, and many, many examples. They did an MRI, they didn't see anything. 3 months later, patient comes with 2 centimeter PDAC. So that concept that PDAC starts small, goes many years, absolutely not accurate. Once PDAC develops, it very rapidly becomes a 2, 3, 4 centimeter PDAC, unfortunately. And those studies are now proving that. So yes, this is all very nice, innocuous, but once it infiltrates, it's the bad kind. So this is a very big problem. The diagnosis is also an issue. Gastric epithelial contaminants are indistinguishable from these gastric IPMNs. If I show this picture to pathologists, they will say, why are you showing me a gastric mucosa? This looks like just normal gastric mucosa. You know, all we need is put a couple of parietal cells and it will be a perfectly normal gastric mucosa. So it's indistinguishable from normal gastric mucosa. So we sometimes have to give the diagnosis, so that don't be upset about this. We have to just say, if truly from the cyst itself, then this may represent a branch duct type IPMN of gastric type. By the way, this becomes a bigger problem if the cystic lesion is in the tail, because the head lesions, usually the biopsy is taken from the duodenal perspective. But when you have the lesion in the tail, unfortunately, you have to go through the stomach. And by the way, no matter how endoscopists say, I really didn't apply pressure, you shouldn't have contamination. Unfortunately, real life is not like that. Going in and out, somehow some clusters can be obtained, and we see the gastric mucosa. There was a Japanese gastroenterologist who worked with me for about 2 years. He couldn't comprehend why there should be contamination if you're not applying pressure. And we have seen so many cases, and then he realized, yes, it does happen. So what I'm trying to say is, even if the gastroenterologists think they are not aspirating the normal gastric mucosa, it just comes to our specimen somehow. Coming to the more intestinal type IPMNs, they really look like colonic adenomas. They're often large, they're often complex, they're often main duct type. But the good news is when they infiltrate, it's often the colloid type cancer, MAC2 CDX2 positive. So actually it could be curable even when it's invasive. So that's a little bit different than the gastric entity. Then there's this rare but important new entity called intraductal tubular or tubular papillary neoplasm. Unlike IPMNs, these are more tubules that are non-mucinous. I don't want to go into the morphologic diagnostic criteria. They form more as nodules. They grow more as nodules in the ducts. rather than more cystic, if you will. And that also has needs to be appreciated because its invasion is, although it's complex, it's usually curable. We mentioned mucinous cystic neoplasms. Technically, they're also adenocarcinoma sequence or tumoral intraepithelial neoplasms. Like I said, 15% of them have invasive carcinoma. By the way, that ovarian stroma really stains like ovarian stroma with progesterone receptors and all the other markers. They even have luteal cells. So it's really ovarian cortical differentiation. Now, this one may be important to keep in mind for you because this is called intraductal oncocystic papillary neoplasms. They form multilocular cystic lesions that are very complex, and typically radiologists call this cystadenocarcinoma, very understandably. Heterogeneous, complex, large cysts, and they're also inflamed at the periphery, so they look like they are infiltrating the vessels. But when you go in, actually, you can shell it out and cure this patient. So it's important to recognize the features of this because 10-year survival approaches to 80–90% in these tumors. And they have a different molecular marker. I'm not going to go into the detail of that, but they have a specific molecular alteration. So intraductal neoplasms, the importance of this group is that they can progress into cancer, or they may have cancer at the time of diagnosis, but there are a whole group of other cystic lesions that form these multilocular cysts. They have their distinctive characteristics, like serous ones have glycogen-rich cytoplasm, acinar cystadenomas have acinar cell, squamoid cysts. The thing about this group is somehow most of them are benign. So there are very few cancers of these non-mucinous entities. So we are happy when we see a non-mucinous cystic lesion. So this is the generally algorithmic approach that I wanted to present. I don't know if there are any questions and comments, and I can move on to the more, staging issues, R0, R1, and other things. Or we can take the questions at the end, maybe. Should I continue?
I think let's finish and then discuss.
Okay.
Take questions.
Yeah. So this, we mentioned, I showed this picture earlier, PDAX, scurus, ill-defined, subtle tumors, tubular configuration, desmoplastic stroma are the characteristics, and that they have extremely high ability to very insidiously, and insidious, I will use this term, insidious means very sneaky, very deceptive, individual small cells, very difficult to see microscopically and very difficult to see radiologically or intraoperatively. And that is a major problem because you see the main tumor here and far away from the main lesion, far, far away, a renegade duct, probably an intraparenchymal metastasis through a vascular channel. We won't call it metastasis, but spread far away from the main lesion. So this is the biggest problem for PDAC. This is very common, as I will illustrate to you. Now, this brings me to the question of how big, for the surgeons in the audience, think about the Whipples you did. How big was the largest ordinary classic PDAC? Not colloids, not endoscopies, none of those, but classical PDAC. How big was the largest one you really operated on? I'll bet you that actually it was no larger than 6 centimeters because a classical, in the Whipple, in the tail it can be. A classical PDAC can only be as large as the head of the pancreas. And head of the pancreas is about 6 centimeters. Why is that? It's not because it says, okay, I'm 6 centimeters now, let me slow down or I stop. The reason of that is because once it replaces the head, it has nowhere to go and goes to the soft tissues in a very insidious fashion. Again, now it's not a part of the tumor anymore. These are individual clusters. That's why we have intra-abdominal carcinomatosis, tiny little things that happen very commonly in these tumors. So when you look at the literature, mean size of PDACs resected is about 3.67 centimeters. Most are smaller than 5. And actually, one thing that helps us is if a head tumor is larger than 6 centimeters, it's probably not a PDAC. If, especially forming a compact lesion, you should start wondering about neuroendocrine centers and others. So expansile tumors, look at the serous adenoma, 22 centimeters. Of course, cells are together and growing as an expansile fashion. But when you have an insidious carcinoma, then it just replaces the head and then spills into the neighboring tissues. So this actually becomes a problem in determining the R0, R1 issue. But I will tackle this subject with what is R1, what is a margin in the pancreas, what are your views? So looking at this, can you identify the structures in this picture as surgeons? See, of course, as surgeons, you can recognize any small tissue fragment in situ. But when it comes out, I realize it's not as easy because the hallmarks are not there. You know, if they break down the building that you take a turn when you're going home, you may miss the exit. It's that kind of thing. The way we orient the specimen is what I tell the pathologist. First, we, of course, examine the externally. And then, in order to find the three margins, I tell the pathologist to put the long arm of the duodenum and stretch it. It will be somewhere here outside. And hold the pancreas in your hands and suspend it, which will give you this view. It's very easy for us. When you put it on the table, it just naturally becomes like this. And this is what I call the trapezoid. And the trapezoid corresponds to the vascular bed. And to the right of the trapezoid, to the right of the trapezoid is going to be the uncinate retroperitoneal margin. To the left of it is going to be the neck margin. So in this picture, this is another pancreas. This is our trapezoid. This is the neck margin. This is the uncinate retroperitoneal margin. And common bile duct is going to be at the top in the plateau here, invariant. So that allows pathologists to recognize these three important structures: neck margin, uncinate, and common bile duct. Now, in the literature, both surgery and pathology, everybody straightforward agrees that common bile duct, neck, uncinate margins are margins. And we sample them, we document them. GI resections, not so much important, but just documentatively, everybody samples it. Now, the question becomes, and here's where actually surgeons both input and may be interesting to them, what about the rest of the pancreatic head? And that brings up the concept of margins versus surfaces. So this picture, again, neck and uncinate margin, but what do we do with this area? Is that a margin? So let's just take this picture. This is the vascular groove, vascular bed, neck, uncinate. This is the vascular bed. Now let's move. This is, by the way, I'm sure you now appreciate it. This view is the posterior median, right? You're looking for almost from the vertebra to the pancreas. Now let's turn and look at it from the right lateral side. What we have in our specimens is this area. It's clearly serosa covered, the transition from the duodenal surface to the pancreatic head. This is all pancreatic head here. This is the, I think this is the vena cava is facing this, right? So what do we do with this? Is this also a margin? Now we asked this question to surgeons. We did a survey by Pancreatibiliary Pathology Society. And this is, I'm sorry, this was not like this. This must be the transition. I apologize for that. Europeans and Japanese wanted to call this, 80% of them said, yes, we would like to call this margin. Americans, they said no. More than half of them did not want to call this margin. And look, this is where I open a parenthesis. As pathologists, we can do whatever you guys tell us. I can call that a margin happily. I know where it is. I know what to do with it. What you need to tell me is, yes, call this margin, but not one of you saying something, other one saying something, then we don't know what to do. So the community needs to come together and decide whether we're going to call those margins. And clearly, they are not agreeing with each other. Now, here's where I take a stance. Posterior surface, if we're going to call this a margin, I think we have to call the anterior as margin as well. So we cannot be picky about that. You shouldn't put me in the position to deny myself, because if posterior is a margin, anterior is the same thing, that should be margin too. So this is the anterior surface. This is the duodenum, again, long arm. Anterior typically has, for pathologists in the audience, when you look at it, you can readily recognize because it's much more fatty, and the fat kind of overrides into the, do I have a picture of that? Overrides into the duodenum, just kind of goes on top of it. This is how we can recognize the anterior surface. This is the neck here. So this is this a margin or not? We asked this question as well. And surprisingly, a fair amount of Europeans also want to call it but it may be the Europeans that we reached, you know, they may have that. By the way, maybe a gossip thing. So I realize actually the way to approach to these things are very cultural, in the sense that the paternal medicine, still paternal medicine in Europe compared to US. So in US, a lot of the things are shared with the patient. Patient is the decision maker, believe it or not. Those of you who did fellowships there probably know. Patient comes with the Google documentation and say, why are you going to give me chemotherapy? I don't want chemotherapy. I want this. You know, in Japan, it's the opposite. The surgeon says, go ahead and do this. This is it. This is what I'm giving to you. They don't even ask what they're taking. Seriously, I mean, I work with Japanese a lot too. Europeans are also more towards the Asian side, more paternal. So one thing about that is, you know, what you write in the papers could be different than what you practice. So in US, if you start calling margins, the patients are going to question, why are you operating on me if 80, 90% of these are margins? In Europe, Büchler will say, I have to operate on you. This is the right thing to do. Just come back tomorrow, I'll operate on you. And the patient goes and comes back the next day. In US, you tell them that, they say, no, I'll go someone else then. Did I explain it well? I mean, that drives actually some of these figures, in my opinion. I mean, not my opinion. That's what they are also saying.
There is also another issue. Surgeons would accept anything as a margin when they have anything to do with it. If they cannot change anything, they don't want to accept it as a border.
Right. But again, Europeans are accepting it as a margin. That's because they don't tell the patient R0, R1. It's just for their publications. You know, when we get, patient is going to follow what they say. In the US, you call it R1, the patient will come back and say, so you didn't do the right operation. You know, so that's the cultural difference that make a change in the approaches. So what do we do to address this? Again, these three margins are all agreed upon, no problem with this. The way we handle the uncinate margin is the following. Now, because of the way PDACs grow, often this is the area that they like to come to. This is the path of least resistance. There's a lot of adipose tissue there. So maybe I should phrase it this way. If there's a cancer going to this pre-serosal surface, often we appreciate that. There is fibrinous changes, there is granulation, and you palpate it and you know the tumor is coming there. But this area, this uncinate, is very fatty, and the cancer approaching to this area could be very patchy and hard to appreciate. So this we put entirely. So we take this uncinate area, we take it as a thick slice, 2-3 millimeter thick slice, and then we bread loaf, cut tangentially, and this is our uncinate margin. And it becomes a perpendicular margin. This is very important. I will explain this in more detail. It's a perpendicular margin, meaning cancer cells anywhere, we know there's cancer there. If the cancer cells approach to this black area I marked, which has black ink, that's when it's approaching the margin. The real margin is only this edge. Did I explain it well? Because this is a very problematic issue. We're working with the best-selling group, I don't know if they're online, about R0, R1 definitions, and this is where we actually have issues clearly in concepts. Perpendicular margin. So what do? We measure the distance from here. So we have a cancer here. In this slide, it's 1.25 millimeters. In this, 0.94 millimeters. We can measure it because only this edge and its distance with the tumor is what we will report. Here's an example again, PDAC. It's coming. Now, this illustrates another problem. So this ink here, there's a cleft here. Did this cleft happen while we were cutting it? While you guys were cutting it? Should we measure this from here? Believe me, it sounds like science, but we have problems with this. You know what I'm trying to say? I mean, these defects without it. So, but we make a judgment call in these things. And if we are not sure, we call it close. So that's the perpendicular margin. Is how we take the uncinate. Most people are nowadays have begun to do it that way. For neck margin, this is another neck margin. Again, we have our trapezoid here, uncinate margin here. Posterior surface is not visible. We have the neck margin. The duct is usually for the pathologist in the audience. You can find the duct orifice in the upper outer quadrant. If you look at it from this person, upper right quadrant. And if you cannot identify the duct orifice, you can just take a cut and squeeze the pancreas a little bit. You see the juice coming back. But that you have only one chance to do the test, because if you have already manipulated the organ, that your chance is gone. So that's one way to find the duct orifice if you want to do that. But more important for surgeons is almost always we take this neck margin as shave en face. What do we mean by that? We take a very thin slice and we'll look at that face en face, and the whole face is margin. So when I have this slide as an en face margin, this is the main duct, the pancreas, a fatty. So this probably very fistula-prone pancreas. I know you guys get very jittery when you see this much fat in the neck margin. This is the surface, and anywhere in the slide, if I see cancer cells, that's going to be positive. So this is the difference between perpendicular and shave margin. Is this clear? This is important, right? So if I see even one cancer cell right here, this is shave margin positive. So that there's another problem with this, because when we put it onto the cassette in the block, when our technician cuts this, they really need to cut as surface as possible, not go deep, because as they go deep, they're actually going towards the cancer. You know what I mean? Yeah. So that very surface they need to cut, and we look at it, and anywhere in this cancer is a margin positivity. Yes, sir.
Can I ask a quick question? During operation, while we transect pancreatic neck, we can send frozen section analysis in two different ways. We can cut a slice from the neck and send you while we are going on dissection. Or we can send the specimen after resection is complete. Is there any difference from pathological perspective?
No.
Cutting that slice earlier for the sake of time?
No, there's no difference. Provided that pathologists can identify, when you send the Whipple, they can identify the neck. One thing you may want to do, it depends on how your communication with your pathologist is. They may prefer not to look for it and you to send it. It makes it a little bit easier for pathologists. I personally would prefer to see the Whipple and take it myself. So you need to communicate with your pathologist to do that. But in reality, it shouldn't have any difference. Now, the biggest question, again, with Mark's group, Besseling's group, we're discussing this. Why don't we take perpendiculars from this guy too, right? To take the bread loaf and then lie it perpendicularly so we can distance. Now, in frozen section, frozen is a horrible technique to begin with. Then having 6 blocks from every neck margin, because it will be multiple blocks, and interpretation of it is very difficult. So nobody is doing it. There's no pathology group who I know will agree to do it or is doing it. So unfortunately, that's our reality. Now, that becomes a problem because Marcus Bühler is pushing for 0.1 centimeter, right? Yeah, that's fine. I think for uncinate, we should be looking for 0.1. I really agree with that. But when you come to neck and common bile duct, we are putting it on fuzz. There's no way we can give you distance. Is it? I don't know. This is a complicated thing. I don't know if I explained it well. Yeah. So, I mean, once you send us frozens from the neck, CBD, those margins are no longer evaluatable for distance. All we can tell you is there's margin at the very surface or not. Okay. And this slide actually emphasizes that frozen sections are obtained as shave en face, and then the margin distance cannot be documented. Oh, one thing about this, perhaps this slide. Again, this very main surface we look at, we don't see carcinoma cell. What happens is later on, next day, of course, the technician goes into it and makes a permanent cut, and there can be carcinoma cell in that very block, right? Because again, what we did is, we have carcinoma going to the surface. We took the surface, we looked at it, we didn't see carcinoma cell. But as you cut even a few microns into it, you may bump into a cancer. Now, the way we report that is, the main surface did not have cancer. So your margin was clear, but we are very close. Now, how close? Don't ask me that because it's gone. We cannot tell you how close anymore. Did this make sense? I actually, my conversations with the Amsterdam group, they're fantastic, by the way. I love those guys. They're so good and so organized. But the conversation with them made me realize actually this shave on face and perpendicular is not well appreciated in the surgery field. Frozen sections, this is actually reflecting our reality about frozen section versus a conventional section. Look at this, we can tell eyelids. Most of you who looked at some pictures, I'm sure can tell this is an eyelids of Langerhans. These are acinar cells, these are ducts, beautiful. That's what a pancreas looks like. That's what a frozen section of the pancreas looks like. All blue, purple. I don't know which one is a duct. I don't know which one is an acinus. I have no clue which one is an eyelid. It's all crushed, frozen, burned. And of course, you do a little bit cautery there, gets even worse. So yes, unfortunately, false positives and false negatives is one of the highest in entire body in frozen sections in the pancreas.
Can I ask you a question?
Yes.
So should we emphasize on the technique that we use during the transection of the pancreas? If someone uses electrocautery during the transection and sends you a slice for frozen section analysis, does it make a difference?
It does. I mean, for neck margin, by the way, you shouldn't be even frozen. I'll show you why I say that. I'm happy to do it. I love looking at pancreas. I'm not complaining about it, but reality is you shouldn't be doing frozen sections, and why will come out in a few minutes. But for other organs, for liver, for instance, cautery, and that there you need that frozen section. And cautery changes makes it sometimes impossible to tell what is what. So the less you thermocoagulate during the operation, if you're focusing, let's say there's a certain area that you really want to know whether it's margin positive or not, try to avoid, at least in that area, burning it too much, because a frozen section is going to cook it. We call it cook it, make it terrible anyways. If you add to it by thermocoagulating, it becomes very mistake prone. Yeah, frozen section is like looking at these, CTs from in a bad machine 20 years ago versus a very good MRI. It really destroys the tissue. Quality is low. Chances for more organized diagnosis is lost, like for the distance and all those things. So this brings me to this, again, Besseling group organized analysis. They did a phenomenal job in organizing, and this is actually their early summary that I'm quoting. By the way, this is confidential because it's going to become a paper, but some of this thing I already knew and contributed to anyways. I was a co-author in these two papers. Now, this shows for frozen section purposes, two things. I know the numbers are small, and I hope you can see some of them, but there are 2 points here. One is false negative rate of frozen section is about 2 to 5%. Okay. Yeah, there's 0.9 in some studies, but in reality, it's about 3-4% in any institution you go to. Now, one thing important to appreciate, this includes all Whipples and every margin is frozen. Actually, when you're dealing, if you take the cases that were really close to the neck anyways, and evaluate that data, probably this 2 to 5% is going to be even higher, because again, pancreas adenocarcinoma is very subtle, very difficult to diagnose. So yes, false positivity rate, unfortunately, and false negativity rate are quite high for our taste. Now, this part here, I'll just summarize to you. When frozen section is positive, additional surgery achieved R0 in 2/3 of the cases, still leaving 1/3 as R1. So because you expand your surgery, you think there is no tumor there, but actually microscopically you find tumor. So yes, 60%, but leaving about a 30%, even with additional surgery. But now the most important thing, and again, our study also was one of them, most of the studies doing the additional surgery, achieving R0. So you did the frozen section and it was R1, that was positivity. You said, okay, I'm gonna extend the surgery. You did it and you converted it to R0. You would think survival improved. Actually, it's the opposite. Survival still doesn't improve. And in some cases, it was worse because probably operation extended, maybe the fistula chance extended. I don't know what it is. They are investigating it. But one thing for sure is a fact that conversion from R1 to R0 by frozen section and additional sections does not help the patient, actually maybe making things worse. So the conclusion of this, I think eventually where this is being discussed, is neck margin frozen sections are not justified. Again, I'm not saying this because, by the way, I love doing frozens. I love looking at frozens. It gives me material to present in courses. Thankfully, very few, if any, mistakes. But this is extremely difficult for pathologists. So really, I have to be defending the pathology field and emphasizing the challenges. And this brings us to the R0, R1, R0 rate. Look at this, please. So this group was fantastic, huh? 17%. This group is terrible, 85% margin positivity, right? What are the factors that lead to R0, R1 rate? So at the same time, look at this. These are papers from surgery team. I just selected, by the way. There are many others, very similar results. 3 major studies. Their rates are 17 to 40, 45%. These are all pathologists. The rate is 75 to 85%. Okay? Why is that? Because, of course, the criteria used, 1 millimeter criterion. If you use 1 millimeter criterion, suddenly everything is much higher. If you use surfaces as margins, both anterior and posterior, like this Verbeek study, both anterior and posterior was used as positive. Sure, there are going to be a lot more cases positive. And then also sampling. I cannot overemphasize this. You know, the more sections you take, the more things you'll find. And especially PDAC, which is very subtle, going everywhere. If you take one section, you may hit the negative area and say, perfect, R0. If you take a different angle section, so the more sections, of course, you'll have higher R1 rates. And we need to kind of standardize this, but it's not easy. What's our approach? First of all, we try to provide the parameters for every aspect, margins, every surface separately, such that, like, for instance, we report vascular bed, we take it separately, and just a vascular bed involved by carcinoma on its surface. So 5 years down the line, one of our residents want to do a study, they can go back and we decide that that's actually a margin, they can go back and include that in R1. We document everything for at least academic purposes. For the uncinate, like I said, that's the margin, in my opinion, the most important. We bread loaf and give the distance because it's a perpendicular margin. We call it tumor is at the margin, or margin is negative, but it is within so and so millimeters for that particular margin. Again, I cannot do that. Nobody can do that unless they are doing perpendicular for those as well. For the neck and CBD margins, because those are obtained en face, all of it is just positive, negative, period. Now we come to the surfaces. Here's how we deal with the surfaces. Not what everybody does. I think I like it a lot because it's very informative. We call it the orange peeling. We essentially peel the surfaces of the pancreas to obtain the lymph nodes. I'm going to show you what I mean by that. This is the posterior surface again. In the next picture, you'll see this part orange peeled out, meaning the fat will be dissected. We just, very crudely take out the fat there with the scissors, sometimes with the knife. And in this one, we did also posterior surface. This is posterior pancreatodudinal. And we end up putting these into 8 groups, not an official grouping, but it's actually good for research purposes. And we take the lymph nodes from these. The purpose of this, by the way, is to find all the lymph nodes. We have time for a story. So the way, of course, the fields grow is quite fascinating. So there was a Tomlinson article some 15 years ago. It came out as a surgery article that says the separation curves of PDAC for survival lymph nodes is 15. If it is 15, 0 of 15, much better prognosis than positive of 15. But for lesser lymph nodes, you don't get that kind of survival curve difference, okay? So then I start to get phone calls from all the pathologists. They looked at their data and they're not finding 15 lymph nodes, right? It's like, they're asking me to find 15 lymph nodes because surgeons immediately picked up those and then went to their pathologist and said, I want 15 lymph nodes in every pancreas, okay? So, and they looked at their data and they're finding 7, 8, they're never 15. So the fascinating thing is I should have put that article. When you read that article, actually they say they're analyzing the SEER database. By the way, SEER database is a terrible database. The lymph node average was 7. It's just that when there was 15, 0, 15 versus, they found the survival curve. They weren't saying you have to find 15 in every case. But of course, now the surgeons say 15 is the number. Why can't you find 15 lymph nodes in my pancreas? But the reality is then we start to look more carefully. I did this orange peeling study, and indeed, the numbers went up significantly. That's why we evaluated 12 to be the bottom number. So our protocol is if we identify less than 12 lymph nodes, we go back to the specimen and take a lot more sections to find more lymph nodes. That's our protocol. Now, actually, we don't have issues. We really look carefully and find more than 20 in most of our cases. Yeah, so and we published this orange peeling. The orange peeling helps us to find the lymph nodes before we even chop the specimen. We take out these soft tissues where the lymph nodes are normally so that we can deal with them later. Then we cut the specimen, because once you look for the lymph nodes after cutting the pancreatic head in the growth room, it becomes harder to find the lymph nodes. That's why probably these numbers were very low. Another thing this soft tissue helped us understand, which was a little bit of a surprise, is when we looked at them, and this is random section, you have to understand. So we take these soft tissues in 6 different areas, and we look at it microscopically. Let's see what is there in addition to the lymph node. And we found renegade PDAC foci, little far away from the main tumor in 89% of these. That's why, that's why I'm trying to say with PDAC is so disseminated by the time of diagnosis. And actually the remaining 11% did not have. One thing I said, did I show that picture? I think coming up maybe. Yeah. So one thing the field needs to decide, surgeons from different continents need to come together and tell us which one is a margin, posterior or anterior. Are they also to be included in the margin? My approach, we call this surfaces for now, coming from the rectum perspective, right? When there is a radial margin involvement, radiotherapy, when it is the free serosal surface, it's believed that the access is to the abdominal cavity. So chemotherapy is indicated, right? I mean, the margin is something. I did 2 years of ENT residency. So I come to these things from surgeon's perspective in some ways. So, I mean, if this is not something you cut personally as a surgeon, we shouldn't be calling it margin, is my opinion. That's why free surfaces, I report as free surfaces. But you all come together and tell me from now on, you report it as margin, we'll do that. We identify it and we section it. Another question is how many sections? It's important to note that some of the studies from German groups, they do total sampling. Well, nobody can afford that. In the US, nobody's going to do that. It's too expensive. But that's what they're doing. Again, paternal government pays for it. We could probably do it. Not we as coach, but in Turkey, state hospitals can do it. But it's too expensive. And then, of course, 1 millimeter criterion. Now, one thing as a pathologist, I also would like to emphasize to you all is when I moved from surgery, from ENT to pathology, I realized I didn't appreciate this at all, that I thought they were looking at everything. Pathology was examining everything. I don't know why I didn't think. But in reality, if you want to examine every corner of this Whipple specimen, you have to spend $100,000 because you need to take 5 micron suctions, which translates to 6,000 slides, and 12 technicians working only on that specimen for full day, etc., etc. What I'm trying to tell you is there's no way anybody can look at every corner of this. With pathology is art of sampling. We do targeted sampling. That's why uncinate is very important. We examine this a lot more carefully than other parts. Oh, by the way, if anybody gets grant and want me to do this, I'll be happy to look at 5,400 slides of pancreases. It's a lot of expense. I cannot do it here because I cannot lock my technicians for that. But I'm actually very curious to do these things with 3-dimensional and stuff. It'll be interesting. The neoadjuvant challenge is the last. Do I have a few more minutes?
We are running out of time. Just
quickly, just one quick message. There's a lot of hype about the neoadjuvant grading and classification. Of course, it doesn't work that well, except for if there is no carcinoma, right? I find the MD Anderson, Hua-Min Wang's approach the easiest and the best. No residual carcinoma, we all can agree. They call it less than 5 residual carcinoma, less than 5%. Now, this 5%, these percentages, and every one of these use that. I don't know how you can calculate a percentage. I wasn't there when the primary was there. You gave neoadjuvant therapy. I don't know what 100% was. How can I give you a percent of the denominator I've not seen? So actually what we are saying is we are estimating very minimal tumor versus a lot more tumor. 5% is a funny number, but what I use this as, many slides, I look at it and I'm having a hard time finding the cancer cells. That's for me grade 1. And if I see cancer cells very commonly and comfortably, it's either grade 2 or grade 3. So this is important for the message for the pathologist. Our protocol in order to call something no residual disease after neoadjuvant is quite harsh. First of all, this is extremely uncommon. I've seen, I think, either 3 or 4 cases over the years, extremely uncommon. Our approach, obtain and examine the diagnostic biopsy, it probably was a pseudotumoral pancreatitis or something else. And then we submit the entire pancreas, and then we select a few blocks to take more sections, and actually we melt the block, turn it upside down, and look at it again just to make sure there is no cancer in it. And that's, I think, the measuring of these tumors are also tricky. And that's, I think, all I prepared to tell you. Thank you very much for your patience and attention.
Thank you, Professor Atsai. It's a great honor and great joy to be able to work together with you, because you changed a lot of things in our minds, being able to understand actually what we are dealing with. For those who survived this first initial presentations, there are much more fun parts of the presentation. We are going to present you cases and discuss all these basic findings. Now, any questions for Professor Atsai?
Questions or comments? Dr. Alper, yes, sir.
%10.9, birinde 0.9. En son sundu. Yani niye bu kadar rate'ler farklı? 2 ayrı klinik. Niye birinde sınırda böyle çıkmış, birinde çıkmış? Bu bir
frozen section positivity.
Aynen. Yani bizim çalışmalarda da böyle. Birinde %36 çıkıyor çalışma, birinde %4 çıkıyor. Yani ve bu çalışmayı dahil ediyoruz. Bilimsel alanda kullanıyoruz. Bu birinci soru. Görüşün. 2. Neden bu hastalar genelde SMA kökünde nüksediyor? Yani bu Gürkan'a da sordum, Orhan Hoca'ya da sordum, o onkologlara da soruyorum. Yani benim gördüğüm nüks vakaların çoğu, çok güzel çıkartmışsınız, R0 çıkmış vaka. 8. ay sonunda, bir yıl sonunda SMA kökü bölgesinde genelde bir doku kalınlaşması şeklinde ama. Böyle damarı saran sinir invazyonu şeklinde giden bir yapıyla geliyor. Sen R0 çıkarmışsın, lenf nodun neredeyse 2-3 tane de pozitif, gerisi boş. Ama böyle neden? Düşüncen.
Evet. Önce ilk soruya abi, Emre Hoca ile çok yakın çalışıyoruz. Gerçekten benim için inanılmaz bir eğitim şeyi oldu. Böyle brainstorming'de devamlı yapıyoruz her konuda. Ama endoskopi konusunda ondan öğrendiklerim benim için gerçekten çok kıymetli. Sağ olsun. Şimdi şöyle abi, o %17, %85 gördün o Arda. Orada definition var, işte 1 milimetre kullanmak var. Yani kriterin definition'ın ne olduğu çok önemli. Oradaki sıkıntı o. Bir sürü çalışmada o. Mesela o frozen section'da false negatif 0.7 demiş biri, öbürü demiş 6.5. O 0.7'ler muhtemelen mesela ya kriterleri farklı. Örneğin hepsi ampulleri kanser şeyi olursa NEC tabii ki 0 olursun. Margin pozitiften rate'in 0. Yani bütün senin praktiğin hastaların ampula kanseri ise, onun için population faktörleri var, tanım faktörleri var, R0'ı nasıl tanımladığının faktörleri var. Onların hepsi maalesef rol oynuyor bu işlerde. İkinci sorunu söyleme. SMA kökü abi o yüzden uncinate margin'e ben önemli bakılmasını çok önemsiyorum. Çünkü pankreatektomilere baktıkça görüyorum ki gerçekten path of least resistance. Kanser başka bir bölgedeyse bile oraya doğru böyle gitme şeyi var. Muhtemelen yağın akışın vesairenin etkisiyle orada muhtemelen o damarların da ve perineural invazyon, biliyorsun teorilerin içinde orada perineural invazyonun oraya spread'i de konuşulan bir şey. O yüzden Bühler ne diyor ona? Triangle first. Ha. Triangle operation, artery first, triangle operation diyor. Önce oraya bir giriyor. Orayı iyicene bir soyuyor. Çünkü o da inanıyor ki o da sinirlerle, damarlarla oraya yayılım çok fazla. O bölgeye ana tümörün uzakta olsa bile o bölgeye çok ciddi yayılım olduğu gerçeği var. Muhtemelen faktörlerden biri o. Bir de yani de var tabii, yani Whipple çıktıktan sonra orada yeri büyüyecek yeri de çok anatomi falan da değiştiği için muhtemelen zaten onu SMA kökü gibi düşündüğümüz aslında belki başka bir noktadan gelip orada büyüyor. Bir sürü faktör var yani. Bunların hepsini araştırmak lazım. Büyükler mesela o triangle only o dokuyu ayrı gönderiyor. Şimdi bizim bir dostumuz Pelin orada çalışıyor. Ona bakıyoruz. O triangle only'de ne tür şeyler var, sinirler falan. Bir çalışma yapılıyor onunla ilgili. Var mı vaktimiz hocam?
Var. Bir soru daha alabiliriz.
Gerçi crush'tan bahsedildi ama crush artefaklı alanı net nasıl değerlendiriyorsun? Soru işareti ve yorumsuz da bıraktığınız oluyor mu cerrahi sınır olarak?
Kesinlikle. Şöyle, şimdi cerrah dostlar bu çok önemli mesaj bu. Benim patoloji kurslarında söylediğim şey atipi, I don't know teşhisi çok geçerli bir teşhistir. Hele böyle crash varsa. Orada şüphe derecenizi komünike etmek çünkü tabii cerrah için bizim için gri zon. Cerrah için bir tane şey var. Ya kesiyor ya kesmiyor. Hani onkolog için bir tane şey var. Yani yarım doz vereyim, az doz vereyim diye şöyle gelip verecek onkolog. O yüzden bizim gri zonlarımız tabii ki gerçeğimiz ama öte yandan da bir yönlendirme de yapmamız lazım. Ben atipi teşhisinin rahatlıkla kullanılması gerektiğini düşünüyorum. Atipin teşhisinin bir risk seviyesi vererek atipi görüyorum. Kanser çıkması ihtimalini yüksek görüyorum. Atipi görüyorum, tahmin ediyorum benim çıkacak şeklinde komünike edilmesi gerektiğini düşünüyorum. Ama atipi yani bugün kanser derseniz yarın yani orada dururlar. Yarın bu sefer ameliyat etmek çok daha zor vesaire. Atipi bence biliyorum cerrahları zorlayacak bir şey ama gerçeğimiz.
Sorry, there are some
Şey-
questions from the Zoom.
Yeah.
All those.
Hocam İzmir'den geldi. Hocamın sorusuna sonra şey yapalım.
It's okay to go for your question, but they are telling we don't understand Turkish.
Okay.
Would you please ask in English or we can translate?
I can translate things.
çevirir
Yeah, I was going to do
misin?
that earlier too. Sorry. Yeah.
Gövde ve kuyruk tümörlerindeki cerrahi sınır değerlendirmelerinizdeki farkları soracaktım.
Okay, so the margin evaluation for corpus and tail, that's actually a little bit easier in the sense that we are looking only to the resection parenchymal margin, and we take it just like we do with other things as ANFAS. So it's positive, negative. We cannot give distance, shave ANFAS. One thing that's not clear in the literature is a problem is anterior, posterior free surfaces. In frozen sections, I don't think anybody evaluates them. What to do in permanent sections for anterior, posterior, for tail is a little bit more complicated. We typically ink the two surfaces in different colors and we report surface involvement if there's surface, which many cases do show that. So for the earlier question that was asked by our gastroenterologist for the Zoom audience, we discussed that retroperitoneal margin. That's why uncinate margin sampling is important because that's the path of least resistance and many cancers grow in that area. That's why the recurrences are often in the SMA area. That's what we discussed. And the other thing is the wide differences of numbers in the literature for false positive rates in frozen sections or R0, R1 rates. Again, my comment on that was that's mostly definitional and have different criteria. One example I gave is if you are all operating only on as an exaggeration, of course, if you are operating only on ampullary cancers, you will never have neck margin positivity. You'll have uncinate positivity, but you'll never have neck margin positivity. Sorry for reverting to Turkish in the answers.
Last question from Zoom. Should tumoral extracapsular extensions in lymph nodes be reported routinely by pathology department?
Excellent question. We do that. We report it. And radiation oncologists occasionally use that as additional reason to the radiotherapy. In any cancer, that's my approach, in my opinion, the size of the largest metastatic lymph node and whether there's external nodal extension is there or not should be reported. We don't do that in colon as routinely. I did a lot of head and neck. For instance, head and neck is a very critical finding. And we do that in pancreas as well. We report the external nodal extensions. Mustafa Hocam had a question.
Okay. We have encountered some different kind of pathologic reports and they make us as a surgeon confused us because there is no standardization report. As a pathologist, I ask a question. Important for us, the pancreatic surgeon, for survival all patients, and also needed the standardization on pancreatic pathology. What do you think about this?
Yeah, absolutely. Standardization is key, and College of American Pathologists, which has a lot of issues, at the same time has been great in creating synoptic reporting. I really think all pathologists should use the synoptic reporting. And if it were to me, I would actually do it always like perineal invasion is line 5, so that when you look at that report, I know you guys don't have time. So line 5 is your perineal if that's what you're looking for. I think it should be that much standardized, in my opinion. Everybody should do it in a very similar way. The problem again comes, what is a margin? So currently every institution calls pancreas margin different, serosa different. We report all the surfaces individually and how close and whether there is tumor. At least, you know, if you want to see it, it is there. But you're right. But part of its standardization is going to come from surgical consensus. Actually, that's why Mark Besseling's efforts are extremely important.
Thank you very much. It was very inspiring for us. Now,
Thank
for
you.
a short period, we have a coffee break, and then we're going to go for the cytology, FNA, FMB, and the case discussions.
Yeah, we have great cases lined up, so I'm sure it will be very interesting.
Hangisi? Ha. Emre kapalı. Ha,
Başlayalım.
hocam,
Dear colleagues, we continue with the second session of today. Where and how does it help, and when does it, where does it fail? The first speech of this session is cytopathologist perspective, and Dr. Çisel Aydın Meriçöz, the stage is yours.
tam ekranda yapalım. Tam ekran yapacağım. Okay. First of all, thank you for this kind invitation. And after this marvelous presentation, I want to share our perspective. And mostly I'm going to talk about the on-site evaluation during the fine needle aspiration. Of course, pancreatic fine needle aspiration has many advantages within the high sensitivity and specificity for malignancy, which reduces the need for more invasive procedures. And additionally, allowing rapid on-site evaluation enhances adequacy and further improving specificity and sensitivity. Moreover, it's facilitating the ancillary studies such as molecular testing for inoperable patients. But of course, it has challenges and limitations, which Dr. Asay already mentioned about the cystic lesions. And actually, cystic lesions are particularly the most challenging area for us. For example, if we see the mucinous epithelium and the endoscopist needle passes from the stomach, those cells may represent the gastric epithelium. And if the cyst does not have any solid area, rapid on-site evaluation may not be informative too. And second entity is chronic pancreatitis versus neoplastic processes. What we observed in the chronic pancreatitis is often non-specific, and however, in the peritumoral area, peritumoral fibrosis can present as similar as we can see in the chronic pancreatitis. And those are our most challenging areas. Of course, material adequacy is one of them. If you have an on-site assessment, even the benign acinar cells may be considered sufficient, but if you cannot have rapid on-site evaluations and malignancy is suspected, those acinar cells may be deemed inadequate. And the last thing is clinical information. Of course, if you have an on-site assessment, you can able to learn where the needle passes, the prior malignancy of the patients, and those are the critical diagnostic clues. So therefore, I'm mainly talking about rapid on-site evaluations. Actually, the most important task during the rapid on-site evaluation is the specimen adequacy. And of course, if in the challenging cases with unclear clinical presentation, defining adequacy is more challenging. But if the cancer diagnostications in the rapid on-site evaluation, we can require further tumor classification, or we want more passes for performing molecular or biomarker testings. And not in our country, but on-site adequacy assessments can be performed by certified cytotechnologists. But in our country and in our institute, this is performed by the pathologist. So how to perform? I think this is the most important area. Actually, direct smear preparation is the primary method for preparing this. And generally, we are aspirate the samples typically on a glass slides. And even the distribution or patterns of the cells in the smear can provide many information about the characteristic of the lesion. For example, epithelial tumor cells tend to clusters, whereas hematopoietic tumors or melanoma exhibit a single cell distribution. And even the artifacts, smear artifacts, can be useful diagnosing lymphoproliferative diseases like large cell B lymphoma. So how to prepare? I think this is important because sometimes we don't have enough experienced technician. You know, one of them is the one single slide smear technique. We just put the aspirate in the center of the slides, and we are using a second slide for a spreader. We call the spreader slides. And we hold the sample slide and pull the spreader slide towards the end of the sample slides. And this techniques enable to produce just one slice, and the spreader slice usually contains little or no cellular material. And the other one is two slide smear techniques, which we have a large amount of sample. And now in here, we use the two slides and we aspirate the slab below the center and align a second slide on the top of the sample. And we gently pull the sample slide and the second slide. And with these techniques, we can able to obtain a two slides containing similar amount. One can we use for the diff quick rapid on-site evaluation, and we can use the second slide immediately fixed in the alcohol and then later use for pulp staining. And actually timing is very important because if the aspirate is thick, you may need to wait a while before the smear process to allow, but the aspirate is fluid. Excessive tension between the slides may prevent you moving them properly. Therefore, timing is important, and no additional force should be applied because I already mentioned about the smear artifacts. We can using those artifacts for diagnosing, and the tension between the two slides should be sufficient to help separate the aspirate. So what about those cells? Actually, so how we should separate the sample? For example, in this example, if you directly smear this example, probably you will see only the blood. The key point, there are tiny little fragments in the blood clot, and we should spread those little clots in here, which I round them in here. And as you can see in this blood sample, we have transparent, cream-colored, tiny little fragments. Actually, we perform a study about that because we have a very experienced technician, which is also a cytotechnologist. He first looked the slides. He examined the transparent cream-colored particles and the others, like the presence of necrosis and color and consistency. And with this technique, especially, there is a name, macroscopic on-site evaluation. And actually, if you do not have a rapid on-site evaluation, with this macroscopic on-site evaluation, you can able to obtain enough material for diagnosis. But for example, in the last example in here, we see a lot of fragments in here. Of course, we have enough tissue for diagnosis, but mostly the tissue fragment contain of fibrosis. So it cannot is enough for diagnosis, but it's insufficient for molecular tests. So I already mentioned that this is a time-sensitive process, and we should complete the staining quickly. Therefore, when selecting the appropriate staining protocol, you should decide the laboratory experience, personal preferences, and available resources. And what we are using in our lab is we are using diff quick staining. You can see that there is three regions here. One of them is fixative region containing methanol. Second is eosinophilic solution, and third is basophilic solution. And before we stain we prepare our smear slides. First, we dip the smears in the fixative solution for 10 times. Then we use dip the 30 seconds in the second solution, eosinophilic solution, and for 45 seconds the basophilic solution. Those are not routinely. Generally, you should look and if the staining is completed, because it can vary on the material. Then we evaluate this slides. So how to fix, and actually fixation is really important. Generally, we are using formalin solution, and for achieve an optimal diagnostic efficiency, a portion of the aspirate should be preserved for the cell block preparation. And if the rose is not available in your institute, you can store your aspirates in formalin or ethanol, methanol-based fixatives. And if you are suspicious for any hematopoietic neoplasia, you can use RPM medium because they preserve the cells better, and you can able to send your material to flow cytometry analysis. So what about our experience during the third and a half year, our experience, 600 AUS patients we have performed with the rapid on-site evaluation, and the average pass number is 4, and just the 5% of them is non-diagnostics. And when we looked if the 20% of those cases had more than 6 passes, so when we evaluate why we perform 6 passes, more than 6 passes, half of them diagnosed with malignancy. It doesn't mean that we don't have enough diagnostic material, but in our institute, we have been widely using molecular tests. Then, therefore, if the patient is inoperable, we want more passes for performing additional molecular tests. And just the 10 of them diagnosed with APSA, acute pancreatitis or chronic pancreatitis, and 8 of them were non-diagnostics, and 24 of them were benign. And before I'm going to finish my presentation, I want to show you some cases. For example, in here, there are numerous cells in the background, and the sample appears helicellular. And when we look to the higher magnification, most of those cells showing the monotone, similar looking. And in this cases, adequacy was given in the second pass. And when we look to the microscopic appearance of this lesion, you can see this round, cream, well-circumscribed lesion in here. And the microscopic appearance of these lesions, you can see that this is a well-defined border. There isn't any fibrosis present. It's entirely composed of neoplastic cells. Therefore, it's easy to obtain more cells during the AUS. And what about this case? There are few cells in the background, and nearly all of those cells are benign. Let's zoom to the red circle area. And in the vicinity of the benign pancreatic tissue, which we are seeing in here, benign pancreatic tissue, we have those 2 highly atypical cells, and we call this malignant. And even we obtain those cells in the 15th pass in these patients. And when we look to the macroscopic evaluation, even in the resection specimen, the lesion boundaries are not clear, indistinguishable. And within such a large tumor tissue area, we have only just few adenocarcinoma clusters across the nerve, around the nerve. Therefore, the likelihood of the needle capture these is very low. So we have a big mass with cream-shaped, ill-defined borders, and we have a lot of numerous tumor cells forming these clusters, and therefore likelihood of the needle capturing this area is higher. So what about the ancillary studies? We can perform immunohistochemistry, biochemical analysis, especially for the cyst fluids, which we do not perform in our institute, flow cytometry for the patients suspected with lymphoma, and molecular analysis, which we can able to detect mutation, fusions, and other genetic alterations. As you can see in this table, there are a lot of genes, and this table is especially for the cystic lesions. Those are not specific. We can see the KRAS mutation even in the MCM, IPMN, and TP53 in the IPMN with neoplasia or MCM with neoplasia, but we can able to get enough knowledge from those alterations. But what we are doing in our institute is performing molecular tests, especially for the single cell nucleotides or the fusions, for the finding it's finding a treatment options. We can widely using smeared slides for this purpose. And I'm going to show you, this is my last slides. You can see this is beautiful adenocarcinoma in the smear slides. And when we look to the cell block, even you can see in here, we have a big, large pores in here, like probably this belongs to a fine needle biopsy. And when we look closer, you can see the malignant cells in the fibrotic tissue core. If you ask me, are you going to use this for molecular tests? Probably. I will say that, okay, we have enough cells, but the fibrosis can inhibit the molecular studies. But when we look to the background, we have those detached adenocarcinoma cells. Probably those cells giving us more quality nucleic acid, and we can able to perform molecular tests. Therefore, we have to perform more studies about which is better for the molecular test, FNA or FNB. And thank you for listening to me.
Thank you for your excellent presentation, Dr. Merichos. Is there any question from audience? No? Okay, thank you. Now we go on with the endoscopist perspective and surgeon's perspective. And I invite Dr. Telleoğlu and Dr. Emre Halper to the stage for making their presentation.
Mustafa Hocam, şimdi siz İngilizce dediniz ama ben o heyecanla anlatamam İngilizce. Onun için ben özellikle hem Gürkan'a da söyledim.
Ben çevireceğim.
O çevirir çevirmez bilmem. Benim anlatmam için biraz heyecanlanmam lazım. O da ancak Türkçe anlatırım size. Onun için özür diliyorum şimdi.
Pointer'ı alacağız. Bir saniye. Okay, now we are going to try to show you the setup, actually. I will leave the floor to Professor Emrah. He's going to tell the process of a US biopsy, and then I'd like to thank Chisel. She has a meeting in Ankara, but she did her best to be here. After the meeting, she's going to go to Ankara, thanks to her efforts making this meeting better. And now this is the setup, Professor Alper helping us. And now I leave the floor to Professor Alper.
Şimdi bu hastayı biz Gürkan'la yaptığımız sonradan da sunacağımız bir vaka aslında bu. Bu vakanın en önemli özelliği çok küçük bir IPMN olması ve operable çıkması. Bu hastada biz çok heyecanlı bir şekilde yine böyle Gürkan'la beraber bakarken bu hasta Gürkan'a başvurmuş. GGT yüksekliği 1000 civarında bir rakam. Başka bir şey yok hastanın. Dilate pankreas kanalı, dilate kolodok.
Can we do it like short translations? This is a patient will be discussed in the detail in the afternoon session. The only finding was GGT elevation. We will discuss in detail. And now the patient was referred to our outpatient clinic, and we were planning to perform an EUS biopsy. Now Professor Alper is evaluating the patient.
Bu hastada heyecanlanmamızın sebebi gördüğünüz gibi aslında çok küçük bir alanda pankreas kanalının içinde bir şeyler vardı. Ve bu şöyle hayal edin. Bunu ampulleyi kestiğinizi farz edin. Daha sonra Volkan hocalar da gösterir. Ortak kanal içinde bir sorun var. Ortak kanaldan da pankreas kanalına gidiyor ve bu boyut 5 milimetre. 5 milimetre ama görüntü, EUS görüntüsünde biz o papiller yapıları görebiliyorduk bu hastada. Yani papiller yapının şu anda görüyorsunuz pankreas kanalındaki papiller yapılar şunlar. O kadar küçük bir alanda çalışıyorsunuz ve bir tek şansınız var bu hasta için çünkü çok küçük. Hollywood'daki delip geçiyorsunuz, ampule de deliyorsunuz. Onun için tek bir şansımız vardı. Bu hastayı opera edelim mi etmeyelim mi diye. Başka hiç invazyon yok. EUS'ta nadir görürüz ama bakın şuradaki pankreas kanalının ekojentesini bile görebiliyorsunuz. Fibrotik ekojentesini. Yani hiç kanalın dışına da çıkmamış bir lezyon. Böyle tanımladık biz. Daha sonra biyopsimizi aldık. Bunun devamında patolog sağ olsun hocalarımız geldiler. FNB iğne kullandık. FNB iğne kullandık. Çünkü doku elde etmek istiyorduk bu hastada. FNA'yı de kullanabilirdik ama sadece hücre elde etmek daha istemediğimiz bir dokuydu. IPMN düşünmüştüm ben bu hastada. Pankreas kanalı kökenli bir IPMN düşünmüştüm. Görüntü olarak da çok erken evre diye düşünmüştüm.
Now this patient was a patient with elevated GGT, and Professor Alpo was thinking that this might be a case of IPMN, and there was a papillary lesion in the ampullary area which goes on in the pancreatic duct, and it was quite difficult to get a biopsy sample because the lesion was so soft. That's why he used FNB needle, and in these cases, what Professor Alpel tells us that you have only one chance to get enough sample. Most of the time, as Chisel told, we pass many times to have enough samples, especially in those cases who are not operable. We are trying to get more samples as more as possible for molecular studies as well. In this case, we had one chance. He used FMB needle.
Takiben bu hastada biz FMB needle'ın devamında göreceksiniz zaten. Hareketlendirebilirsek. Tekrar lezyonu görüyorsunuz. Artık ekranda daha ayrıntılı görebilmek için diğer kesitsel IPMN'deki o villöz yapıların görüntüsü bu. Tabii çok büyüttüğümüz bir lezyon. Örnek yine biraz daha ilerletebilir miyiz? İkincisi olabilir. Bunun devamı var mı? Evet, burada FMB iğnenin içinde aldığımız örnek hafif sıvı geldi, pankreas sıvısı geldi içine bunu doğal olarak. Şurası gördüğünüz üstteki koleodok. Şurası ampulle aslında. Şu koleodok, şu pankreas kanalı işte IPMN diye düşündüğümüz bu yapıda o ortak kanalın içinde. Ampulün içinde. Takiben o hazırlıklarımız başladı. Patolog hocalarımız geldiler. On-site biz çok şanslıyız ki bize çok yardım ediyorlar. Artı çok da deneyimli bir stopatoloğumuz var. Stopatoloji teknisyenimiz var. O kadar ki bize camları yayarken bunda malin hücre var, bunda yok, burası iyidir falan diye yayıyorlar. Bu bizim için mükemmel bir şey. Hani hatta iddiaya giriyoruz hocam işte hatta iddiaya giriyoruz işte hamburgerinizi alırım falan hocam. Bu adeno, bu nöroendokrin falan gibi o kadar iddialı konuşabiliyorlar artık. Gerçekten dokuya bakarak.
Now, this is the part that we want to share you the technique. After finishing the biopsy procedure, we get the samples out. We have a cytotechnician. He's very experienced, really. I have seen it many times. He, just a second. Okay. He's checking the sample before our pathologist comes to the endoscopy suite. The cytotechnician always says it seems enough. And now, after getting the sample out of the needle, they start for the process.
Tıp fakültesindeyken böyle cama bakardık da öyle söylerdik 3. sınıftayken. Makroları ona göre şey yapardık. Sınava. Aynen öyle oluyor. Kaldırıyor hocam burada var falan böyle yapıyorlar. Evet.
May I add something about that? I already mentioned about macroscopic on-site evaluation. Actually, it has been widely using around the world, and they have published cases about that. How can we obtain enough material with just macroscopic on-site evaluation? And it's just for the FNB, by the way. It's not good for the FNA samples. But of course, the most important thing in this video is he is dissecting the particles. This is the most important thing. And Dr. Prat?
Oh, that's okay. I mean, of course, we have a judgment when we look at the particles, and it is a macroscopic evaluation as we do on the gross specimens. So we can understand if it's white, we can think about something. If it's mucoid, we can think about that. It's non-diagnostic. It's okay. However, the main thing, as Chisel says, just to take out the particles on that side, leave the blood on that side, and just squash one of those particles to see the morphology and keep the others for the cell block. And of course, in time, you get an experience to judge whether this tissue is enough or not.
Evet.
But I mean, it's not that easy. I mean,
Şu anda işte ekranda görüyorsunuz. Biraz önce Çisel Hoca'nın size bahsettiği gibi. Orada bu konuşma olsaydı duyacaktınız ekranda. İşte şöyle küçük küçük ayrıldı. Şudur budur diye şey yaptık. Ondan sonra bu aldığımız sıvı, işte pankreas sıvısı da geliyor doğal olarak o kanalın içerisinden o sırada. Sıvıyı da yaydık. Takiben boyama aşamasına geçeceğiz. Bunu biraz hızlandırabiliriz burada. Burada bir ayrımı gösterebiliriz. Çok küçük ince şeyleri. Vakit kaybetmemek adına. Evet, şöyle doku ayrıldıktan sonra içinde şu şekilde en küçük partikülleri görmeye çalışılıyor. Ondan sonra gerçekten işte telefon lambasını falan tutuyoruz. Bir şeyler yapıyoruz orada. Orada hani beyaza yakın doku neymiş diye ayırmak için. Ondan sonra sitotoksikolog arkadaşlarımız onu ayırıyorlar. Hocalarımız ön hazırlıklar yapıyorlar. Biraz önce Çisel'in bahsettiği gibi. Daha sonra bir kısmı boyama için ayrılıyor. Burada gördüğünüz işte 3 boya artı bir tane de solüsyonumuz var temizlik için. Fiksasyon solüsyonumuz var, boyamalarımız var. Şu biraz önce gördüğünüz şey, bu tabii cerrah anlatmak bunu çok böyle mantıklı değil. Ben bunu kongrede anlatsam bizim kongrede çok daha efektif olur. Çünkü en büyük sorunumuz bu. Biz size biyopsi alıyoruz ama sonuç veremiyoruz. Bunun bir anlamı yok aslında. Rapid on-site sitolojinin bize en büyük avantajı bu. Gastroenterologlar aslında biz mikroskopi bilmiyoruz doğal olarak. Yaymayı da eğer yapamıyorsak o giden materyal patolojiye gidiyor. Ve patolojiden de genelde sonuç non-diagnostik geliyor. Bu iki sebepten bir, biz kötüye göndermiş olabiliriz ya da almışızdır. İki, patolog bilmiyordur. O da olabilir. Türkiye'de pek çok merkezde stopatolog olmadığı için özellikle FNA alıyorsanız aldığınız FNA'den sonuç elde etme oranınız düşük. FNB biraz daha doku parçaları falan getiriyor. Daha tanıdık geliyor patologlara, stopatoloji çok hakim olmayanlara. Bazı üniversitelerde çok da sevdiğimiz dostlarımızın yaptığı, abi ben 10 defa biyopsi alıyorum bir sonuç gelmiyor falan gibi böyle ifadeler var. Burada 10 kere de yanlış sonuç almak bir eğitim için kolay değil. Mutlaka arada bir şey tutturursunuz yani. Ama muhtemelen patolog dostlarımız çok hakim olmadıkları için yeterli sonuç vermiyor olabilirler. Bu da size geri dönük olarak cerrahiye ya da bize hastadan geri dönüşler hoş olmuyor. Özellikle bunu özel bir hastanede yapıyorsanız bu çok daha kötü bir şey. Çünkü hasta bir kere bir ücret alınmış oluyor. Sonra hasta olmadı bir daha gelin bir daha falan, böyle bu gerçekten hoş olmayan bir durum. Maddi anlamda, öbür türlü hastaya zaten yük. Normalde devlette de çalışsanız bir yük. Daha sonra burada bir...
Just a brief, actually, Professor Alper says this major issue in any center who performs EUS without on-site pathology, the way you, as the Chisel has previously shown, the optimal technique to get an optimal view of this sample and saying that it is okay, enough sample we have retrieved, is the major issue in EUS biopsy. Because if you don't have on-site pathology, you finish the procedure and then after a couple of days the report comes back, we cannot say anything, non-diagnostic sample. That is the major problem in this process.
Bizim çalışmalar ve guideline'ler diyor ki 3 defa gelin bırakın. Ya ben 3 defa değil, işte Çisel burada. Evet, 15.de.
And but because of this is the even in the resection specimen, it's the tumor is highly how can I it's invisible.
Yeah.
Therefore
Yani pankreas kanserleri fibrotik. Biz girdiğimizde bir hattı kullanıyoruz. Bir hayal edin. Şöyle bir top var. Elinizde 5 santim ve bir iğne var. Bu iğne incecik bir şey. Bu iğneyle şu topa biz şuradan bir vuruş yaptık. Sen daha iyi biliyorsun pankreas kanserinin sertliğini falan. Buradan aldık boş 1. Buradan aldık boş 2. Buradan aldık boş 3. Arada bir sürü doku var. Bir portakal olacak. Çok küçük bir alanda bir örnekleyebiliyoruz baktığımızda. Ve bizim gayettenler diyor ki 3 defa al. Ya bu 3 defada o hücreyi yakalamak gerçekten bazen olmuyor. 15'inizde yakaladığımız var. Ortalama 8-9'lara gidiyoruz bazen. Hadi bir de bu değişti. Şimdi bizim inoperable hastalarınız var. Çok. En şanslı grup pankreatobiliyerciler. Çok hep inop hastanız var sizin. Kolorektal gibi değilsiniz yani. Ondan, oradan aldığımız doku da sizin artık moleküler çalışmamız gerekiyor. Onkolog istiyor ki ben moleküler istiyorum. Ya ben kardeşim zaten şu kadarcık bir şey almışım. Sana nasıl vereceğim? Benim derdim bu. Nasıl vereceğim ben bu dokuyu? Onun için sayıyı arttırıyoruz. Sayıyı arttırdık, bu sefer başımıza başka işler çıkıyor. kanıyor hasta. Yani ben her iğneye soktuğumda bir yere aslında dürtüyorum. Özellikle nöroendokrin ise tam baş belası. Bir hastamız var. Hastayı 12 hemoglobinle soktuk, 3'le ölümden döndürdük zar zor Barbaros sayesinde. O kadar kanıyor. Neden? Patologlar sağ olsun yetmedi abi, yetmedi abi. Yani o öyle bir şey.
We have a question from the audience.
Well, we have a patient, cystic lesion, possibly IPMN 5 millimeter, and we have only finding upper level of GGT. So, what's the main indication for EUS biopsy?
The only finding is GGT elevation and pancreatic head cystic lesion.
It's 5 millimeter, possibly
Yes.
it's IPMN. So, why are we taking biopsy?
Well, do you have any other imaging?
Well, why don't we follow the patient?
Bu hastanın pankreas kanalı da dilateydi, koledok da dilateydi. MRCP de diyordu ki
If I miss, that's my bad.
Sorry, you were asking about this. This patient, GGT was 1000 and
Only GGT.
GGT,
Yes,
alkaline phosphatase, cholestatic enzymes were elevated, plus dilation, plus MRI findings clearly demonstrated a problem in the distal bile duct. And there was something we have detected in the MRI, which
Consistent with IPMN?
No, not IPMN. There was a lesion. We had to clearly identify what that lesion was. There was obstruction. That was the issue. I think about the setup of the pathologic evaluation, endoscopic ultrasound biopsy is clear. Maybe proceed for the. We would like to discuss two brief cases. A 62 years old female. She had an abdominal pain, and ultrasound detected a pancreatic head cystic lesion. And now I would like to, this patient was referred to our center for EUS. So Professor Alper have taken the patient to endoscopy suite, and I would like to listen him about his finding.
bu hastanın aslında sadece ultrasonu yoktu. Tomografisi de vardı. Ama yani ultrasonda MR'ı vardı ilk başlangıçta.
Yok, senin EUS'undan sonra MR çekilemez.
Şimdi bu hastanın biz girdiğimizde şu kist için girdik aslında. Oradan da örnek aldık. Bu gördüğünüz kistin bizim EUS'taki görüntümüz nasıl? Bakın standart bir kistten biraz daha farklı. Bir duvarı var. Yani bir duvar kalınlaşması görüyorsunuz. Normalde kistlerde şöyle bir kalınlaşma genelde görmeyiz. Yani burada bir stroma var gibi duruyor görüntü olarak. Tek bir kist, anekoik, normalde septasyonları da yok, çapı da yaklaşık 2 santim falan. Normalde bunu gördüğümüz için biz biyopsi örneği aldık. Buradan sıvı gönderdik. Bunun sıvısında CA'sı 19.000, CA'sı 12, 1200, 1500 falan gibi şeyler geldi. Ama ondan önemlisi, biz bu hastada o işlemi yaparken şöyle bir lezyon da gördük. Kuyrukta. Bir o baştaydı. Hani biz buraya bakarken bunu da gördük. Ben de dedim ki o 4/4'lük seröz kistadenom bu. Bizim kitaplar öyle yazar. İşte böyle süngerimsi bir yapı. Ondan sonra elimizde tabii bir kontrast enhancement yok sonovu gibi. Ama biz öyle ayak yapıyoruz işte aletle biraz damarlandırıyoruz falan burayı. Ya dedim bu tamam. Seröz kistadenom çok da güzel görünüyor. Raporuma da seröz kistadenom diye yazdım. Pankreas başta kistik lezyon, kalın duvarlı, müsinöz neoplez soru işareti diye yazdım. Buna da seröz neoplez diye yazdım. Daha sonra bunun patolojisi geldi.
Now, just a brief of the case, the pancreatic head cystic lesion. Professor Alper had performed a biopsy and the fluid sample retrieval from the pancreatic head lesion, but at the same time, a pancreatic tail lesion, which from the point of endoscopic ultrasound, Professor Alper clearly thought this is a microcystic serous cystadenoma. Everything was compatible with that diagnosis. And after having the biopsy sample, the day he performed EUS, we performed an MRI.
Ben şimdi bu raporu yazayım.
This is the fluid analysis.
Yes. O aldığımız sıvının örneği de buydu. Bunu da kısaca üstten geçeyim. Yani sizi ilgilendiriyor mu bilmiyorum ama bizi ilgilendiriyor. Muhtemelen sizi de ilgilendiriyordur. Böyle bir sıvı aldığımda pankreas sıvısı içerisinde biz mutlaka şu 4 parametreyi gönderiyoruz. Önceden glikoz yoktu. CA19-9 da yoktu. Sadece bu ikisi vardı. Genelde bu ikisi gönderilirdi. Artık biz 4'lü gönderiyoruz panel gibi. Bu yapabilsek KRAS, GNAS da göndermek en uygunudur. Ama genelde o kadar materyal çıkmıyor ve fiyat çok pahalı. Onun için baktığımızda bu hastanın CA'sı 12.709 geldi. CA19.9 10.000'in üzerinde, yani onkosolik mukus salgılayan hücrelerin salgıladığı içerik. Glikoz 4 canlı hücreler var anlamına geliyor. Tüketiyor o sıvıdaki glikozu ve amilazda kanalla ilişkisi yok. Yani şuna baktığımda ben 4 dörtlük büzünöz neoplazi zaten diyorum şu sonuçla. Ve daha sonra bu hastanın patolojisini de Çisel Hoca bahsetsin.
Is it possible to use cursor because online audience cannot follow marks?
Sorry. Can I get the question again? Is this for?
Is it possible to use cursor? Yeah.
Okay. When we look to the, this is from the cyst fluid, and we perform cytospin preparation for this. Even you can see in here, there are some, in the background, there are some necrosis, and there are some highly atypical cells during in here. And you can see in here, we have few cells. When we look here, the nuclear cytoplasmic ratio increased, but we are not able to see the details of those cells. Those can be histiocytes.
No, it's okay.
Okay.
No problem.
And when we look to the other, it's really hard to obtain those images because it's really hard to find those cells. We have this highly hyperchromatic nuclei cells, and especially for the necrosis, you can see those are like the ghost cells, like they can be a necrotic cell debris, or they can be histiocytes. We are not able to show the characterization of those cells, and we diagnose this as like the highly atypical cells with the necrotic debris, but it's those cells are really suspicious for poorly differentiated carcinoma. Do you want to add something?
So for a case like this, there are really very minimal material to move on. So I just want to say that the joke that we have among ourselves in the department is we're walking with a guillotine on our head because we call these things carcinoma based on these cells. One of these days, that guillotine is going to cut our head because there's going to be a false positive. And we try to avoid that false positive, but it's kind of a concern that we always say. Another joke I have is, yes, we call this carcinoma, let's start praying that it is, not of course for the patient, we hope it's not cancer, but let's hope we are right. And in this case, actually, the radiology will be presented.
Burada ben bir devreye gireyim. Bu kisti hayal edin yine yaklaşık 2 santim çapında bir badem gibi bir şey. Bunun içi sıvı dolu ve biz tek bir noktadan bir iğneyi yine bir yere sokuyoruz o bademin içine. İğneyi tek bir hamlede kullanmak durumundayız. İçeriği enfekte etmemek adına ikinci şansımız çok olmaz kistlerde. Sıvıyı çektiniz, tahlile gönderdiniz. O arada duvarı tek bir noktadan şu şekilde hareket ettirerek hasarladınız. Bu hasarladığınız dokuyu da patolojiye mümkünce kanlı şekilde göndermeniz gerekiyor. Tek bir nokta. Şu hale bir alanda ben girdiğimde buradan alıyorum. Bunun geri kalan duvarı hakkında hiçbir yorumum yok aslında baktığınızda. Onun için biraz önce hocanın dediği de o. Yani aslında giyotine verilmesinin sebebi bu şöyle bir şeyde tek bir şu noktadan aldığımız örnek üzerinden bir tanı koyarak siz bu hastanın geleceğini belirlemeye çalışıyorsunuz. Çok zor bir şey aslında. Patologlar için de bizim için de zor bir şey. Evet, bu hasta daha sonra bu arada gireceğim. Ben bunda tomografi çektirdim. Benden sonra MR. Dedim ki ya
önce senin EUS yaptığın gün MR çekildi.
evet, MR. Onu söyleyeceğim, gelecek sonuca. Ben bunu çektirdim çünkü bu kistin arkasındaki seröz kist neydi diye. Baştaki tamam, onu biliyoruz. Ama ben kuyrukta bir şey gördüm. İçim rahat etmedi, radyolojiye gönderdik.
Here you can see the MRI on the next day, I think, after EUS and aspiration. There are two distinct lesions. Well, it's very hard to comment about the lesion at the head portion, unstayed process. This is a bright lesion, so this looks like there's fluid inside. This may be cystic, but it is tubular. So I wouldn't call this a cyst. This looks like a dilated duct, maybe because you aspirated it. So I won't give a differential diagnosis, maybe ductal dilatation or an IPMN, but I cannot see the ductal communication because I cannot even see a cystic structure there. I wish to comment about the lesion at the tail. Normally, you know that pancreas has outer lobulated contours, and at the tail portion, this contour lobulation is lost, and there is a mass lesion, an apparent mass lesion at the tail of the pancreas. This is the arterial phase after contrast administration. So there is arterial hyperenhancement in this lesion. I would go for a neuroendocrine tumor of the pancreas, PNET, but the endoscopist said this could be a microcystic SCN. Sometimes microcystic SCNs in the honeycomb variant also seem to enhance with contrast. So it's hard to differentiate in between, I think, in this case. But this didn't have cystic intensity on T2 weighted image. I didn't see any fluid intensity in this lesion. So I think the first probable diagnosis is a PNET at the tail. I cannot comment about the cystic lesion at the proximal part of the pancreas.
That's the 1 month computer tomography findings.
CT was performed after 1 month after this MRI. Now I can really see a cystic lesion at the unsnake process of the pancreas. When you look at the lesion, it has well-defined borders, somewhat heterogeneous in the center. It looks like there are a few cysts inside, and we didn't see any ductal communication, but it is harder to see with CT. I would prefer to see an MRI. So this looks like a post-locular cystic lesion with no ductal communication. Should I comment about differential diagnosis or? This doesn't look like an IPMN. I don't see the bunch of grape appearance and outer lobulated contour. This could be an MCN, SMC, scope maybe, but in case of scope, they are mostly unilocular. I don't think this is a cystic PNET because there is no contrast enhancement at the wall of the lesion. These are my possible diagnosis. And again, we saw the same enhancing solid lesion at the tail of the pancreas, looking like a cystic PNET. PNET, excuse me.
Okay, now that's the retrospective analysis, of course. But when we have these imagings, and Professor Alper performed this endoscopic ultrasound, he clearly decided about microcystic cystadenoma. So because of this atypia found in the head of the pancreatic cystic lesion, we go for treatment, for the surgical treatment. We decided to go for, can we come back one slide? Now, so we have two problems, one in the tail, which is supposed to be, might be a microcystic cystadenoma, and plus we have an pancreatic head cystic lesion with significant atypia. And during the operation, I called Professor Barbaros. He came and we made a biopsy for the pancreatic tail lesion. It came out neuroendocrine tumor. And we aspirated the cystic lesion because then the strategy changed. Aisha was with us. She's here now. And she said, this seems completely benign, but there was a significant atypia preoperative EUS biopsy. So we called Professor Atsai. We made a huge discussion. And at the end, we decided to go for a total pancreatectomy after discussing with the relatives of the patient. And now floor is Professor Atsai's.
Yeah. Professor Tellolu is making it a little bit softened and nicened now. During the operation, the conversation was going like this. You called this carcinoma. I'm going to do total pancreatectomy. Are you sure? Now you're calling it benign intraoperatively. What am I supposed to do? It was, we were sweating, all of us. But joking aside, yes, there was a neuroendocrine tumor. And this is the cyst. This cyst has actually some interesting academic angles. It is a cyst with mucinous lining for sure. And I will show you the findings here. It is thick-walled. Actually, that's a very important feature of this entity, this thick wall, but it doesn't have ovarian stroma. And without ovarian stroma, this is clearly not mucinous cystic neoplasm, as we discussed earlier. And the thing is, most of the epithelial lining of the cyst is denuded. And that's why, you know, when you aspirate intraoperatively, we won't see anything. But when we move around, we discover these carcinoma in situ. There was no invasive carcinoma, but there are multiple foci of in situ carcinoma lining the cyst. This explains the high CA, 99 CA, and all the other findings we have. And so this is actually probably the most atypical component of this with carcinoma in situ. Yes, indeed, in the tail of the pancreas, a beautiful neuroendocrine tumor with the monotonous cells, nest, chromogranin, synaptophysin are markers, and it's a low-grade one. Ki67 is very low, so it's good. Very quickly, simple mucinous cyst is a new term that we use for a subset of mucinous, cystic mucinous lesions. By definition, they are non-complex, non-papillary cysts. Often they have thick walls. One of the criteria is that they don't show IPMN cytologically, but they also do not show, as Professor Bengi nicely illustrated, they do not have the cyst by cyst and other radiologic features of IPMNs either. There's no ovarian stroma. That's one of the main criteria. We used to call these things, or it was called, mucinous non-neoplastic cyst, which is of course wrong because they often have neoplasia in them. And for some time we called these IPMN, non-papillary IPMNs with low-grade dysplasia, or MCN with atrophic stroma. But finally, it's now in WHO as simple mucinous cyst. Just to cover the differential diagnosis of these mucin-lined cysts, to re-emphasize, if you have ovarian stroma, clearly we have mucinous cystic neoplasm. No ovarian stroma, and if the cyst is larger than 1 centimeter, it has papilla formation, diagnostic of IPMN. And then we have, of course, microscopic incidental forms of mucin-like structures, which we call pannins. So this SMC group they are cysts, they present clinically, they do not have ovarian stroma, they do not have papilla formation, and they do not have classical IPMN intestinal and other cytology. Here's another example of an SMC shown here. They tend to be bilocular, unilocular with thick walls. You see it's not communicating by pushing the main duct here. And as Professor Gurs has nicely illustrated, they have distinctive radiology. Nowadays, actually, she's able to tell, I think this is most likely SMC. Now that we made correlative studies, often they can at least put that in their differential diagnosis. Just to illustrate, many of these were called other things previously, IPMNs, MCNs. It won't be wrong to do that, except that ovarian stroma is required for MCN. And here are some examples. High-grade dysplasia is common. And one thing we're discovering, and this is not yet in the literature, is they are not only precancerous, but they often have cancers they are associated with as well. So they are not as simple. I mean, the term simple is in the name, but they're not actually simple. They are precancerous, and they can even lead to true invasive cancer. Actually, when we looked at our databases, 1.5% of PDACs had SMC type lesion in their background.
Şimdi bu hasta öyle kolay gibi düşünüyor ama ben Cuma günleri İzmir'e gidiyorum. Sabahtan arabada giderken Volkan abi beni aradı. Bu hastanın ismini söyledi. 1 ay önce biyopsi yapmışım. Sen bunları dedi böyle demişsin. Gürkan arıyor dedi. Bu hasta ne diyelim? Ameliyat etsin mi? Etmesin mi? Dedim abi ben nereden bileyim hastayı? 1 ay önce yapmışım zaten, adını bile hatırlamıyorum hastanın. Ne demişim abi dedim. Sen dedim üstüne demişsin de şöyle demişsin böyle demişsin. Muhtemelen sen de o arada düşünüyorsun dedim. Ne diyeyim bu hastaya?
Dediğim gibi o giyotin dedim. What I thought in that case is the guillotine is really on today. I think the head is getting chopped off because we may have made a mistake. Intraoperatively, we are not seeing cancerous cells. Did we overcall? And this is always a concern. Did we overcall the original cytology? Of course, it's really very nerve-wracking because he's going to do total pancreatectomy. I call him. He's not helping at all. He's in the Karacabey area, just driving to Izmir. So That's, it's nice here now after everything, but it was.
There's one more credit to Emre because during the operation, when Ayşe told me it's benign, then I started discussion with your team, and at the end, many ideas were present, but I consulted with Emre. I asked him, I said, there was this significant atypia, and now we have neuroendocrine tumor in the tail. What about the pancreatic head? It says now benign. What are we going to do? Sometimes when you are in the operation, someone outside helps a lot to you to make up your mind. He told me clearly, he said, once there is strong atypia, then there is strong atypia, go for total pancreatectomy, because it was quite difficult, really, making that decision, turning that patient into a diabetic patient. So that credit is also someone outside the operative field who looks briefly and is not compromised by the operation emotions. That's also very important, especially in HPB surgery.
Thank you for sharing this case. We should have all image in MRI or CT before EUS, because EUS and biopsy sometimes make us the difficult to evaluation with radiology, right? Thank you.
Edema and hemorrhage after EUS may also interfere with our results, so this is critical.
Also, we have a comment from Professor Bilge.
Ben Türkçe'yi de konuşacağım ama. Şimdi herkeste bu kadar iyi bir ekip yok. Biz şöyle demeli miyiz acaba? Atipi gördüğümüz kistik lezyonlarda kesin operasyon mu? Yoksa hastaya göre mi karar vermek lazım? İkinci söyleyeceğim de burada hastada kuyrukta bir kitle var ve ne olduğunu bilmiyoruz operasyon öncesi. Ben nöroendokrin tümör kuşkulu başıma 2-3 kez geldi. Sistemik nöroendokrin değerlendirme yapılmasının uygun olacağı kanaatindeyim. Yani hipofizden sürenele kadar bir sürprizle karşılaşmamak için. Teşekkürler.
So two comments. The first one is cyst with ATP. Of course, not every team has all the complete comprehensive approach to these things. Cyst with ATP, should it all be operated or should it be case by case? That's one question. And the second question was, yes, neuroendocrine. If you have a neuroendocrine tumor, should you be screening? Whether preoperatively or postoperatively, we believe in that. In tumor boards, we always mention neuroendocrine tumors can be multifocal, a part of MEN syndrome, and some of them are forwarded to genetic screening. Would you like to answer the atypia thing? I mean, from pathology perspective, since we are the ones who call it, I would say, of course, don't cut everything that we say atypia. But on the other hand, in Europe, unlike in the US, they often, even without, actually, they don't even do EUS in Europe. That's very interesting. They see a cyst, they think it is risky, they just go ahead and resect it. I was shocked to see in recent tumor boards in Europe. We are, I think, closer to US, and I think our way is better to evaluate things. But there will be cases where it will be atypia and nothing, and you're going to have to operate. I don't know the perspective.
Well, we have a very experienced radiology team. They have contact with endoscopic ultrasound. Because Professor Alper clearly thought that this was microcystic cystadenoma, the report came out based on the same day after EUS, MRI came with microcystic cystadenoma. And then after 1 month later, CT performed, and CT repeated by the same radiologist, the similar lesion, nothing changed in the dimensions and characteristics. So we misdiagnosed as tail lesion without any biopsy, focused on this atypia on the pancreatic head lesion. This tells a lot to us. We have to be sure about, because this is a tragedy during the operation. You sit there while you're planning to perform a Whipple procedure, and then you have to convert it to a total pancreatectomy because of a second tumor. So you have to preclude this happening during the, of course, if there is a margin positivity, you can go for total pancreatectomy anytime. But in this case, probably we were having that difficulty because of this unexpected diagnosis of neuroendocrine tumor in the tail. This microcystic cerocystadenoma, however, all discussions can easily tell it's easily diagnosed. I don't think so. It acts like a solid tumor, as Professor Gürses says. It acts like a solid lesion. When radiology gets support from endoscopic ultrasound, because Professor Alper is so experienced, he can sometimes say, this doesn't look like PDAC, it looks like lymphoma, and we make the biopsy, it comes lymphoma. So that can have an interaction. But in pancreas, 70% of neuroendocrine tumors are non-functional. That's why they're bad prognostic, because they are diagnosed late compared to functional tumors. Should we go for systemic evaluation without any carcinoid syndrome symptoms, without any symptomatic issues might be related to neuroendocrine tumor? I don't think so, because if we are dealing with pancreas, 70% of the lesions are non-functional. But you have to be sure, you have to check the blood tension, you have to ask to the patient about the medical history, anamnesis, any doubt, of course, you have to check everything.
Now we
Sorry, I think it was necessary before biopsy from the tail of the pancreas, before surgery, not during surgery. And second, you can protect the total pancreatectomy of the patient. It was not necessary. It's possible to make Whipple plus tail resection. Why total pancreatectomy?
Yeah, that's the difficult part of decision making during the operation. That was not a very small lesion. Then you have resected tail, then you have resected head, you have the risk of the middle part, the corpus part of the pancreas, and sit there with the risk of leakage of the tail plus the soft pancreas. That was the case. That might be also an alternative strategy.
Before go through with the second case, there's questions from Zoom. Two for gastroenterologist perspective. The first question is the technical question that what is the diameter of the needle for FNB and FNA?
I prefer generally 22 FMB needle for the solid lesions without neuroendocrine. Generally, cystic lesion, for the cystic lesion is FNA needle, 22.
Okay, and the second question is, in the near future, the sampling practice will change due to the need for much more tissue sampling for NGS analysis or other analysis.
We have to take a lot of biopsy from the especially solid lesions, suspicion of the PDAC. Probably because oncologists want us a lot of tissue for the general therapy of the new smart technologies.
Okay, and for the surgeon's perspective, they're asking for, can we say that for this case, is that over-treatment for performing total pancreatectomy? Is it over-treatment for you for this case, or?
Well, from my perspective, I was there.
You already explained it. Yeah.
It's just to preclude the morbidity related to both sides of the pancreas. It was also an alternative, but I made that choice based on the general health status of the patient.
And if the question is regarding whether to resect small pen nets, we'll have a session, a little bit talk on that in the afternoon. If the person who asked the question can stick around, we'll have interesting discussions there, I'm sure.
Okay, then the questions are okay, and we can now continue with the case 2.
Okay. Now, this is a 39 years old female patient. This patient visited another hospital before coming to our center. The complaints were dyspepsia for the last 6 months and recent darkening of urine color and jaundice. So the patient went to another hospital and endoscopic ultrasound and ERCP performed. And during EUS, they didn't detect any mass. ERCP performed, and distal common bile duct was narrow biopsy performed, initially evaluated as intraductal neoplasia, a stent placed, and re-evaluation of this biopsy was concluded, no malignancy, no neoplasia. So when the patient referred to our center, we planned to perform an endoscopic ultrasound, and Professor Alper performed endoscopic ultrasound. Because of stent, it was hard to evaluate the distal part of the common bile duct. Stent was taken out and then evaluated. Tumor markers were completely normal. Biopsy performed, multiple biopsies performed, and those biopsies didn't reveal any malignancy, but there was a suspicion. This was a very tough case during the follow-up period. First of all, I just wanted to ask Professor Alper about his findings of endoscopic ultrasound.
Volkan abi İngilizce konuştu da ben yine Türkçe konuşuyorum Boğaziçi üzerinde. Biraz önceki vakada da öyle. Bak biraz önce tartıştınız ya niye böyle yaptınız falan diye. Bu vaka da aynı. Yani bizim çıkardığımız 2 vakada böyle hata mı ettik vakalar aslında bunlar. Bu da öyle bir kadın 38 yaşında. Daha önce başka bir hastanede 2 kez RCP yapılmış. Alınan biyopsilerde de böyle malin de denmemiş, benin de denmemiş. Oradaki gastroenterolog arkadaş da tekrar stent koymuş falan. Sonra bize geldiğinde hastada biz stenti çıkardık. EUS yaptık. Hem koledoktan biyopsi aldık. Hem fırça sitoloji aldık. Hem EUS duvardan FMB biyopsi aldık. Ve bu sonuçta biyopsilerde aslında görüntüsü de 4 sanki bir IgG 4 hastalığı gibiydi. Yaşı uyuyor, genel durumu uyuyor. IgG 4'ü 4 civarında, 3,5-4 civarında. Böyle ortada kalmış bir hasta. Yani kıyamıyorsunuz da cerrahiye verelim falan gibi bir hastayı düşünün. Ve bu hastada biz Volkan abi bize dedi ki ya bunda dedi bir şey görmüyorum ama içimde rahat değil dedi. Zaten bu hastayı onun için çıkarttık bu vakayı. İçimde rahat değil dedi. Biz de ama yine de kendi içgüdülerimize güvenerek hastaya kısa dönem steroid tedavisi, IgG4 gibi kabul ederek başladık. Kısa dönem dediğim normal tedavi 2 yıla kadar uzar. Biz bu hastaya haftalık takip aldık. 30 miligram başladık. Doz azaltarak ilerledik. 3. hafta sonunda hasta da çok iyi hissediyor kendisini. Ağrısı yok, genel durumu iyi, canavar gibiyim falan diyor. Biz 4. haftada bir kontrol tomografi çektirelim dedik. 1 ay içinde oluyor bunların hepsi.
This is the MRI.
These are T2 weighted coronal images showing you. The one on the right side is showing you mildly to moderately dilated pancreatic duct. And at the head portion, there is abrupt discontinuation of the pancreatic duct where there is expansion and heterogeneity at the head of the pancreas, excuse me. And in the first image, you can see dilated, mild to moderately dilated common bile duct. Although I cannot see the pancreatic duct inside the lesion area, I can see the common bile duct penetrating the pancreas. So, maybe there is the duct penetrating sign. If we see the duct inside the lesion, the pancreatic duct, it's probably pancreatitis, chronic pancreatitis. But if we don't see any duct, this is probably malignancy. I can see one of the ducts inside the lesion and the other duct is not seen inside the lesion. So again, I'm in between malignancy and focal pancreatitis.
Emre Hocam, endoskopik ultrason bulgularınızı
endoskopik ultrasonu buraya koyamadık. O dönemki fotoğraflarımız kayıp Medgate'te. Şu aynı bunun gibi görüyoruz. Çok kalın bir duvar. Ampulladan başlayıp yukarıya kadar gidiyor. Şeye kadar, ana kanal düzeyine kadar neredeyse ayrıma kadar. Her duvar sirküler, her yerde kalın. Yaklaşık 4 milimetre kalınlığında bir duvar. Hipoekoik Yani sanki böyle enflamatuar bir duvar gibi görünüyor. IgG4'te de böyle görüyoruz. Ve içinde stent var. Sorunumuz burada zaten. Bu stent yaklaşık 2 aydır içinde. 2 ay stent. Ve bu stent burada enflamasyon mu yaptı? En büyük sorunumuz bu. Yoksa gerçekten bu enflamatuar bir duvar mı? Yani bizim bu hastada çıkarmamızın sebebi aslında yani kesin tanı konmadan bir iş yaptığımızda, özellikle stentleme yaptığımızda bir sonraki stepte sorun yaşamaya başlıyoruz. Enflamasyondan dolayı.
Okay, just a brief endoscopic ultrasound findings. It was a thickened wall because of previous ERCP stent. The wall was ödematous, and not only in the intrapancreatic portion, it was going up almost close to the hilar plate, and there was no irregularity within the bile duct, just 4 millimeter thickened wall, and the stent was removed to perform a biopsy and evaluate in the endoscopic ultrasound. What Professor Alper told was nothing correlated with a significant malignancy. Some typical findings of IgG4.
Actually, Professor Alper called me to the endoscopy suite, and we looked at it together. Of course, I'm not an endoscopist, but he beautifully illustrated to me that this was a very even, a tube-like structure that's going proximally for several centimeters. So you will see this turned out to be cancer. And it's one of those cancers that really constrictively forms a very even tube. And it just goes without any irregularities, without forming nodularities. It was so dramatic, so interesting that, and when I saw that, actually, I became even less convinced that could be carcinoma. That kind of pulled me down from making a carcinoma diagnosis, because it's just so even and almost cholangitis pattern.
There is no diffusion restriction at the head portion of the pancreas, so it is not possible to differentiate between mass lesion and focal pancreatitis. Again, you can see the moderately dilated pancreatic duct and common bile duct and wall thickening. It's like millimetric wall thickening, maybe due to stent or due to some inflammation. It's hard to differentiate. And there's a stent that you can see inside the common bile duct on the MRCP image.
We have a question from the audience.
Diagnosis, you consider through pancreatitis, maybe stent-related pancreatitis.
Well, maybe chronic pancreatitis, pancreatitis or IgG.
We are talking about the novel CT after steroid treatments. After steroid treatments,
I didn't show it yet.
okay,
Yes.
Okay.
Pathology.
Okay, actually, it was two examples. First, belongs to the common bile duct wall aspiration, which is totally benign, and those slides belong to the brush cytology. And which we can see in here is that we have in here benign cells, but in near of them we have a highly atypical cells in here with a very pleomorphic. Those cells are very pleomorphic, and when we look in here, we have the benign cells in here and those highly atypical cells. Because of the patient's history of the stent, and I didn't show you, but there are a lot of neutrophils in here, and the patient has a stent, and the radiological images is not consistent with the malignancy. And here we are seeing those highly atypical cells. Even in my presentation, I told you that even with the two cells we call malignancy, but in this case, because of those inflammatory processes, we are not able to call this directly adenocarcinoma. But we write our report that this is highly suspicious for adenocarcinoma, but those cells are very few, and there are a lot of reactive cells, which, for example, like that. Because of those reactive cells, we are not able to give a permanent adenocarcinoma diagnosis. And at the same time, we have a biopsy, which came from the outside institute.
Yeah, this case really, I mean, is close to our hearts because we really thought this was going to turn out to be adenocarcinoma, but the biopsy findings, cytology findings, they just were not enough for us to pull the trigger. That's the bottom line. I really, at some point, we were almost going to call it straight adenocarcinoma, and we backed out, and we shouldn't have. You see these changes here in the outside biopsy performed. In this outside biopsy, there were also some fairly atypical clusters, but it was so degenerated, crushed, that we were not able to pull the trigger in the end. But we were very close to it. I wish we had called it, then the treatment would have started earlier. But we want to show this case. That's the nature of the business. We cannot, unfortunately, be confidently calling cancers readily in many cases. And a later biopsy showed much more convincing adenocarcinoma, unfortunately. As you see here, we have the normal units. Oops, sorry. We have the normal glandular elements in the amplitudinal mucosa, and then we have clear-cut adenocarcinoma with pleomorphism, infiltrative. When you have something like this, of course, it becomes very straightforward, but we didn't have it in the initial biopsies. I would like to use this case very quickly. Bile duct is very different than pancreas. In the pancreas, because it's a solid organ, because there are not ulceration, usually there's not that kind of inflammatory injury to the epithelium. Pancreas, we have 90-95% accuracy rates nowadays, but bile ducts, everybody, we're still struggling. Sensitivity is 44%, which is very low. And this is our study where we know the cases proved to be cancer, and the bile duct brushings were we couldn't call, and were mostly. And this also illustrates, this is several pathologists, about 20% of the cases, this is United States, 20% of the cases get to the atypical suspicious gray zone diagnosis. This, again, the nature of the business. One thing though, what we did is we took out those real life cases, picked out 60 of them and gave it to the same group of pathologists and asked them to give diagnosis. The sensitivity jumped up to 66% from 44%. That's actually proving the point that when the pathologists have the weight of that diagnosis and causing chemotherapy or a major surgery, they are reluctant to call it adenocarcinoma. They kind of tune it down and call it atypical, suspicious. That's, again, the reality of our business. But when you take out that real life pressure and put it in the study setting, it's not perfect, but there's significant improvement in sensitivity. We did one other step of a study. We did bile duct brushings ourselves on pancreatectomy specimens. We smeared and we circulated with our colleagues, the same group of colleagues. Of course, this is a static specimen on a Whipple. We are doing it nicely, brushing, and we are looking at the corresponding histology. So that's as good as you get from a real perfect matching, if you will. And then the sensitivity jumps up to 86%, because of course you get more tissue, better specimens, but it's still not perfect. Again, still you can miss that. And we interpreted these results as from 66 to 86% jump is probably something maybe operators, meaning endoscopists, can get better tissue, and we might be able to call it. But there was also this fact that those of us who do pancreatobiliary cytology routinely were actually in the 95% range in this imitation bile duct brushings from Whipples, whereas other pathologists still was in the 80s. So there's room for pathologists to learn. It's not easy to get experience in these things because these are rare specimens too. Something you see every day, you get very good at. Something you see once every 3 months, it's hard for the pathologist to get the expertise. So I just want to illustrate bile duct brushings, and bile duct biopsies in general remain a very problematic specimen for all of us.
Yeah. Final.
Now you see, unfortunately, the new images, CT images. Now there are some faint, subtle lesions, hypodense lesions in the liver. They are hard to differentiate, but they were better seen on our PAC screen. They were new. They didn't exist on the previous MRI. And when you look at their density, they are not like abscesses. So these are metastases. You can again see pancreatic ductal dilatation here, and the stent is seen. On the MRI, the metastases were confirmed. There were a lot of metastases, the largest one being 1 centimeter.
This one is the ERCP stenting, low insertion cystic duct. And on the right side, you see the metallic stent for the medical oncologic treatment period. So this was a sad case. I still remember the day when Professor Alper was performing EUS. I remember the thick distal combile duct wall, and I remember all those discussions with Professor Atsay. Even after this case, we have many discussions because of this lady, Professor Atsay carrying the guillotine on his neck, and many more times saved patient's life. Someone has to say something at some point, but it's so difficult, especially in these cases. The samples are not enough because of all those inflammation. The decision to go for operation is not that easy. For this patient, after 3 weeks, we had this metastasis, which clearly shows us that if we decided to go for operation, probably that would bring us early postoperative extensive disease. But in other patients, for saving them, possibly diagnosing as early as we can, we have to be careful, but experience counts a lot, as Professor Atsay showed us.
One aspect of this case, I think there was also a little bit of response with steroid. We see this because in autoimmune pancreatitis, presumed to be autoimmune pancreatitis cases that are adenocarcinomas with steroid, adenocarcinomas also shrink because, as we illustrated, PDACs have a lot of fibrosis and inflammation, and steroids leads to a little bit of a shrinkage, but that's very long, short lasting. And then actually, I don't know why, but then the patients come back with disseminated disease after that.
I would like to thank you for your excellent discussion. Now we go on with the how I do it session. The endoscopic and cytopathologic techniques video session. Professor Emre Alper and Professor Pınar Fırat.
Well, actually, we can maybe skip this session because we have several cases. Well, life is not always that difficult. Maybe it can be a relief for you because we brought just ordinary cases, which are not terribly difficult to diagnose and terribly difficult to treat. And we're going to talk about only the endoscopy and the cytology of those cases, just ordinary cases. Would you like us to continue or just leave them to the end of the very end of the day?
No, please go on. Yeah.
Okay, so we have very limited time. Okay, you start, please, with they're not difficult, so maybe it's good to talk about that we are managing most of those cases, and I'll try to give, or I'll try to show how cytopathology is approaching those slides. In most of those cases, we're able to go to the diagnosis. But first of all, even though Emrah said that it's not possible not to obtain a material after 15 times, but sometimes it is possible. I mean, the ability of a cytopathologist or a cytopathologic specimen to diagnose a mass starts with the operator. So first, the material should be taken from this lesion, and it's not that easy always. Even if you see your needle within the lesion, it's not so easy to aspirate them. So the technique details is with Professor Alper. So please.
We prepared the cases with Dr. Fırat. The interesting cases for me because, for example, I saw PanNet, or I wrote the report PanNet, but lymph node, etc. and accessory plan.
So I mean, we are as a team so lucky that we are working with a very good endoscopist. I mean, he's really giving us a very nice material. Unless you see enough amount of cells and a high quality smear, it's not possible to be sure about the diagnosis. So if you have in your series a lot of inadequate cases, a lot of atypical cases, a lot of suspicious for malignancy cases, then please start to question your team from the very beginning, the operator, then the preparation, and then the interpretation.
You can see here that the lesion is head of the pancreas. The view of the lesion, I think that it's adenocarcinoma because there isn't no regular margin of the lesion, and tissue darkening is dark the other part of the pancreas. I have taken the biopsy from the FNA biopsy probably from the lesion, and after that.
Okay, let's continue.
Mm-hmm.
Yes, those are not very recent cases. Well, the first case is a clear-cut adenocarcinoma from my pathology colleagues. Well, those are all neoplastic cells, so crowded, and also the nuclear atypia is clearly here. There's some necrosis in the background. No doubt that this is an adenocarcinoma. And we've got, as you see, plenty of cells, and they are nicely smeared. We can see all the nuclear details. Okay, it's done.
It's easy case for
easy case.
us.
So that's for the start.
Yes, endoscopist and
Exactly.
pathologist.
Those are the cases. I mean, they come. How to say? I mean, most of our cases are of that kind. So this is another case. This is a very typical PDAC. Morphologically, I don't want to go into detail, but once we come across those drunken honeycombs with those lacy cytoplasm and with those nuclear pleomorphism, and if we're in the pancreas, even if we are out of the pancreas, we should suspect that the primary is in the pancreas. So this is a typical picture. So the second case.
Yes.
Okay, sorry.
The other case, you can see here the lesion, the margin of is regular. And there are a lot of vascular collaterals near of the lesion. I took a biopsy from, in this area, and after that.
Okay. We, again, has many cells, and you can even think that because the tissue fragment will gonna be so heavy on macroscopic examination, you might think that, well, that could be a tumor, but no, this is only surface epithelium. The needle is passing through the stomach, and stomach is the main mimicker.
Our problem.
Yes, yes. I mean, we should know this. It's better to know it because not the duodenal epithelium. It's rather easy to recognize it because we've got those nice goblet cells within those columnar epithelial cells. So it's easy to recognize the duodenal epithelium. However, stomach may mimic pancreatic adenocarcinoma, and if it's not very nicely smeared, may cause some problems in interpretation. Look at this. This is also a nice monolayer, kind of honeycombing, maybe coming from the pancreas itself. These are not looking really ugly. Still, for me, they are benign cells. We continue. Oh, this is from the pancreatic parenchyma. Nice acinar cells, clearly benign from the pancreas. And okay, now those are the acinar cells. Maybe some benign cells. What about this? This looks very much like stomach epithelium, and I know that we pass through stomach. Well, what about this? It's a little bit more crowded, but maybe atypical. That's the most I can go. But when I come to this area, and if I have the chance to compare with a nice stomach epithelium, those atypical cells, and if I realize that they are completely different cytomorphologically, then I'm on the safe side. But the specimen might be composed of only of those cells. Some, still I don't know from which part is coming this tissue fragment, either from the surface epithelium or the tumor itself. I really don't know, but I know that this patient has a tumor. It's here. Those are all benign cells, and it's clearly pancreatic PDAC. And once more, the nuclear details are there. So it's again a pancreatic ductal adenocarcinoma. However, those cells might be few in between the benign cells. They may cause confusion. The tumor might be well differentiated. So you have to stay in between, and you need a nice material. You need those comparisons. So that's the tissue block. You see that the tumor is here within the pancreatic parenchyma. Again, here, quite close to the pancreas. So our aspiration or our tissue cores have them both. And we can stay in between those if we don't have nice cells.
Easy for the technician,
And
but
the
difficult
third.
for the pathologist. You can see here that the other case, probably a little lesion. There is a diameter of the lesion 6 millimeter.
Very
You can see here
small.
that, very small in your yes. And I take a biopsy from middle of the lesion, and that
Yeah,
6
well,
millimeter.
it's a tiny lesion. It's difficult to obtain cells from this tiny lesion, of course, and that's all we have. Like the previous case, which is discussed in detail. Well, they are clearly abnormal. And you've got many of those cells, I'm going to call it adenocarcinoma for sure, but I'm just staying a bit nervous. I'm not sure it's a tiny lesion. The patient will receive a pancreatectomy, and you know, the number of cells is not even hundreds. So even if they look very much atypical to me, even if they look very malignant to me, the diagnosis of this case was suspicious for malignancy. So we have to stay somewhere. But of course, we called it is highly suspicious, and all those team discussions are done, and finally it is resected. The lesion is here. And it is adenocarcinoma, a very tiny adenocarcinoma. So why I have showed those cases, we have showed those cases because we have to stay somewhere. Most of our cases are directly malignant, and most of them are PDACs or neuroendocrine tumors, the easy part of it. Some are clearly benign and fits with the clinic, it's okay. Some are cystic. For the cystic lesions, we'll look at the cyst fluid if we don't have a solid part of it. Then we call if we have epithelial cells, even if they have high grade or low grade changes. So we talk about them. But for the rest, I mean, it's impossible to delete the atypical cases and suspicious for malignancy cases. As you have seen in our reports, we give our descriptions, our own descriptions, because we are a team, we are able to discuss with each other. So maybe we understand each other nicely. But of course, there are nice standard reporting systems, and this is the recent one done by WHO. So of course, we try to minimize suspicious for malignancy and atypical. Those are original pictures from the document. However, they exist.
The patient was performed Whipple procedure for the malignancy. In the follow-up period,
we are exiting time.
Yeah.
In the follow-up period, it's about 2 years later, the patient had a nux pancreatic adenocarcinoma in remnant pancreas parenchyma, and probably I'm not sure that the patient died with a pancreas adenocarcinoma. Nux pancreas adenocarcinoma or secondary.
Yeah. I apologize for taking some more time.
We should close a leave session and then.
I know, but well, the more interesting cases are the following. That's why I suggested to leave them all to the end. Well, okay, just quickly, even if it looks like a neuroendocrine tumor, this is a common situation. It's a lymph node. It's a nice lymph node, and that's all. It's over. No neuroendocrine cells here. It's totally a lymph node. Another case. At least we should talk about it.
We can divide it to
okay, let's continue later on. It's a good
Yeah,
suggestion.
yeah.
Okay, if you like.
Okay, thank you for your nice
any questions on that adenocarcinoma site? We're going to continue with the neuroendocrine part.
There's a question from Zoom that they're asking for if it changed your practice to put a stent in the bile duct. It changed the quality of the specimen, or
The inflammation it causes might give some extra anxiety to us, at least, because it may cause reactive changes in the epithelium. And of course, as pathologists, we become more worried about whether it's reactive or malignant. It makes it more difficult. We are always one step backwards when we have such a triggering agent. But basically, the cells, if you obtain nice cells and if you prepare them nicely, the cytology details do not change. Okay. Just becomes difficult to interpret.
Thank you. Now I am closing the morning session, and we will go.
Thank you.
We will be online 1 hour later after this session.
Thank you. Excuse me for interrupting, but
no problem,
because our
please.
case series is we couldn't finish it. There are some questions. If you agree, we can continue it at the very end of the meeting.
Is it okay?
Whoever likes to listen, our cases may continue with us.
Okay.
The pathology cases, right?
Well,
okay, thank you very much.
Well, we are going to talk about the cases after this speech at the end of the session. Okay. Okay.
Dear colleagues, you're all welcome. First of all, many thanks to the organizing committee for this kind invitation. I will talk about cystic lesions of the pancreas from a radiologist's perspective. Here you can see the outline of my talk. Let me start with a brief introduction. As we all know, parallel to the advances in imaging technology, now the detection of incidental PCLs has increased significantly. Rate of incidental PCL detection has been reported to be up to 50% when MRI is used. Fortunately, most of these lesions are benign, but unfortunately, there is marked overlap in the imaging findings. It is hard to differentiate between some subtypes. Differential diagnosis is critical because management and prognosis differ significantly among different subtypes. We may use ultrasound, CT, MR, and MRCP for detection and diagnosis of PCLs, but among those, the best modality is MR and MRCP. MRI is superior to CT due to its high soft tissue resolution. What does it stand for? Soft tissue resolution helps us to evaluate the septal and nodular structures inside the cyst. Ductal communication is best shown with MRCP, and lack of X-ray exposure is an important advantage of MRI for patients that are put on follow-up. I won't go into detail, but optimal MRI technique is a must. If MRI cannot be performed for some reason, there may be a contraindication, then radiologists should use curved multiplanar reformat images to find out the presence or absence of ductal communication. What are the expectations from the radiologist that should be included in our report during PCL evaluation? First of all, we need to mention about the size, location of the lesion, and evaluate the morphology. Presence or absence of communication with the pancreatic duct is very critical. Afterwards, we should mention if there are septal structures, nodular structures, or papillary septapapillary structures inside the cyst. If we think the cyst is mucinous subtype, then we have to indicate the presence or absence of worrisome features and high-risk stigmata according to the guidelines, whichever guideline you use. Interval growth should be mentioned. At the end of our reports, we try to make a recommendation like routine follow-up, close follow-up, or histopathological correlation is needed. There are different classifications of PCLs. We are using this one mostly on radiology. Most of them are non-neoplastic, and there are two main subtypes, one with epithelium and one without epithelium. I will start with the non-neoplastic cysts and show you some imaging examples. Lymphoepithelial cysts are very rare non-neoplastic lesions. They are mostly multiloculated. One will see septa inside. There will be no connection with the pancreatic duct, which helps us to differentiate from IPMNs, but they don't have specific imaging features like most other subtypes of cysts, so it is not possible to differentiate them from pseudocysts or MCNs just by imaging. Here, the main pitfall is, normally in radiology, if some lesion is restricting diffusion, it means there is increased cellularity there, and it is mostly on the neoplastic side. But lymphoepithelial cysts will restrict diffusion due to their keratin content. Let me show you a histopathologically confirmed case. There is a cystic lesion with septa in the head of the pancreas. After contrast administration, there is no enhancing nodularity. But please note that there is intense diffusion restriction. It's bright on diffusion, but this is not due to cellularity. This is due to keratin. The other subtype of non-neoplastic cysts are SCOPes, squamous cysts of the pancreatic ducts. They are again rare lesions. Actually, they were defined many, many years ago in pathology literature, but imaging findings still are not very well documented. We are lagging, I think, pathology. It is in the form of case reports and case series. They are mostly unilocular. We don't expect to see septa or nodularity in these cystic lesions, and there will be no ductal communication. Let me show you a couple of cases. In this patient, there are more than one cyst subtype. The first one on the coronal T2 weighted image is a branch duct IPMN with high-risk stigmata because it has nodularity inside. There is main ductal dilatation. Actually, this patient was shown to have mixed type IPMN after surgery. And we have observed a squamous cyst of the pancreas at the body portion. Please note that this is very simple looking, benign lesion, no contrast enhancement, simple fluid inside, and no septa or nodularity. This is again another patient with more than one cyst subtype. These were all detected by on-site pathology radiology correlation from one of our studies. It was a thesis study. This patient has a side branch IPMN in the uncinate process. There was a PDAC, not very well seen here, I know, but there are some cysts around the PDAC. They were retention cysts. There was another side branch IPMN and main duct dilatation because the patient had mixed type IPMN. Plus, there was a very benign looking unilocular cystic lesion at the body portion of the pancreas, which came out to be SCOPE after on-site correlation. Let me mention about simple mucinous cysts. They are defined pathologically as cysts with mucinous epithelium without ovarian stroma, different from the MCN. Again, the imaging findings are not well documented yet. They don't have unique imaging features. Different from SCOPes, they may have septa inside. They are usually solitary, and we won't see any ductal communication. In the differential diagnosis, one should consider MCNs, IPMNs, and SCOPes because they have similar imaging features. Let me show you a case. In an outside center, a cystic lesion in the pancreatic body portion was detected by MRI. You can see it as typical T2 bright cystic intensity. There was no contrast enhancement. There at that center, EUS was performed and FNAB showed atypical cells. So she was referred to our center for distal pancreatectomy. Here you can see the distal pancreatectomy specimen, which revealed SMC with high-grade dysplasia. So as Dr. Atsai mentioned, SMCs don't seem to be that simple. Another patient, CT was performed for this old lady for acute cholecystitis with stones. An incidental cystic lesion was detected at the head of the pancreas. MRI was performed, which revealed no specific imaging finding. This was a cyst with a few septa inside with no ductal communication. So this is not an IPMN. It was removed, which came out to be SMC, again with high-grade dysplasia. Retention cysts are defined as cystic dilatations of the pancreatic duct secondary to an etiology that causes intraluminal obstruction. This could be benign, such as a stone, mucin, or this could be PDAC, actually, pancreatic cancer. I should emphasize at that point that I will show an interesting case. They may be the preceding finding of PDAC, and newly developing retention cysts on imaging studies should be cautiously reviewed and mentioned in the report. So follow-up is needed in this case. The differential diagnosis will be branch duct IPMN. They look alike each other. Let me show you a typical case. There is a PDAC in the neck portion of the pancreas. It is hypovascular on hypoenhancing on post-contrast study. And on the T2 weighted image, please note that around the PDAC lesion, there are cysts adjacent to each other. They look like a pearl necklace. These are typical for retention cysts, which were confirmed by on-site, again, pathology radiology correlation. You can see the islands of PDAC and retention cysts adjacent to the mass. Formerly, I was diagnosing them as branch duct IPMNs, but these are different entities. A very interesting patient. Some pancreatic cysts were detected during imaging of a patient, an old lady. Follow-up was recommended. On the first year of follow-up, radiologists reported that everything is stable. So routine follow-up is enough. But there was something changing there. Please concentrate on the tail portion of the pancreas. There were newly appearing retention cysts, actually, and secondary ductal dilatations. And in the second year follow-up, now these are much more prominent, and now there is a PDAC at the body, distal part of the body of the pancreas. So I believe the PDAC was there, but it was not visible to our eye, to imaging. So it's important to be cautious about retention cysts. Before switching on to neoplastic cysts, I will mention about pseudocysts briefly. They are the most common PCL subtypes. Here, the clinical scenario is important. There will be a history of pancreatitis or trauma. They may be uni or multiloculated. There may be septa inside, but these septa will never enhance with contrast, different from other neoplastic lesions. There may be debris inside looking like nodularities, but they won't enhance with contrast. In the differential diagnosis, we should consider branch duct IPMNs and MCNs. In the CT image, on the axial and coronal reformat images, you can see a typical pseudocyst that has developed after acute pancreatitis. And this is a pseudocyst of another patient. You can see the classical cystic bright signal on T2. There are some debris inside, but they will never enhance with contrast. Sometimes pseudocysts may have ductal communication. The neoplastic cystic lesions are also termed as cystic pancreatic neoplasias. They have two main subtypes, the non-mucinous and mucinous subtypes. I will start with non-mucinous type. SCN, serocystic neoplasias, are typically grandmother lesions, so demographics help us during differential diagnosis of cystic lesions. They are most commonly seen in females and at old age. They may be in any location. There is a well-known growth rate that we should be aware of as radiologists during reporting. I believe the most important distinguishing feature of SCNs are outer lobulated contour. There are three main morphologic subtypes, the most common being microcystic pattern. In the microcystic SCN, one will see a lot of tiny cystic locules with septa in between. And these septa will enhance after contrast administration. In some of the patients, these septa unite towards the center to form the typical T2 dark stellate scar appearance, and it may be calcified in 1/3 of the patients. In the macrocystic variant, please note that the outer contours are lobulated. There are less cystic locules, less number, and larger cystic locules. It will closely mimic MCN. What are the differences? The outer contour of MCN will be smooth. The outer contour of SCN will be lobulated. And also after contrast material administration, one will see contrast enhancement in the wall of the MCN, different from SCN. these minor differences help us in the differential, and there will be no ductal communication. There is also the mixed subtype where one will see macros and micros at the same time. Grandmother lesion, there is a cystic lesion at the tail of the pancreas. Please note the outer contours are very lobulated. There are many septa inside. This looks like a microcystic one, but there are some macros in the periphery, and here you can see the typical T2 dark central stellate scar. And there is no wall enhancement after contrast administration. This is an oligocystic or macrocystic variant where you can see less cystic locules and they are larger, bright on T2. Please note the outer contours are very lobulated, different from MCN. And there is a very, very dark central stellate scar on T2. Dark on T2, very dark on T2 means calcification, which was further confirmed with CT. CT sometimes helps us to confirm calcifications. This is a very interesting case. This is one of the most important imaging pitfalls for SCNs. In case of the honeycomb pattern, there are many septa and the cystic locules are very tiny. In these patients, after intravenous contrast administration, the lesion, although it is cystic, the lesion may mimic a hypervascular pancreatic tumor and may be mistaken for PNET. This is a typical example. On T2 weighted image, you can see a bright cystic-looking lesion with a lot of septa inside. Pre-contrast and post-contrast. On the post-contrast, it looks like this is a hypervascular lesion, like it's PNET. I did this mistake, so I should mention about it, but it came out to be a microcystic SCN. Actually, in this patient, I believe EUS would help a lot to show the cystic nature. SPNs, solid pseudopapillary neoplasias, are typically daughter lesions. They are seen in young age and mostly females. They are mostly solitary. We won't see any ductal communication. Here, the cystic degeneration is due to necrosis or hemorrhage. And if there is hemorrhage inside the lesion, we are lucky because it will have a specific signal on MRI. Normally, cysts are dark on T1 and bright on T2. But if there is hemorrhage, it will be bright on T1 and dark on T2. Now, I will show you an example. Daughter lesion, young female patient, there is a big mass at the pancreatic head. In the central portion, there is a cystic component, and on T1, it is bright, and on T2, it is dark. It's typical for hemorrhage signal. And the solid components that enhance after contrast administration will be mostly located at the periphery in case of SPNs. Before switching on to mucinous subtype, I will mention about cystic PNETs. They are rare subtype of PNETs that are mostly located at the distal part of the pancreas. They have low but well-known malignant potential, so it is important to differentiate them from non-neoplastic cysts. And here, the main clue will be avidly enhancing rather thick wall of the lesion. I will show you a typical case. Middle-aged male patient, there's a cystic lesion at the tail of the pancreas, which is bright on T2 weighted images. Please concentrate on this image. On the post-contrast image, when you compare with the pre-contrast one, there is avid enhancement of the rather thick wall, which came out to be a cystic PNET after resection. Now, lastly, I wish to mention about mucinous cysts. Mucinocystic neoplasias, MCNs, are typically mother lesions. Here, the demographic data helps us a lot because they're almost always seen in females, like my colleagues told you, because they have ovarian stroma. The most common location is the body and tail. They will have multiloculated, mostly they will be with, they will be polylocular, different from microcystic SCNs. There will be few septa inside with larger locules. Contrast enhancing wall and smooth outer wall will help in the differential diagnosis. The clue is middle-aged female cystic mass in the distal part of the pancreas. There are some imaging features that suggest coexisting invasive carcinoma. Of course, we cannot be sure, but if the lesion is larger than 4 centimeter, if it has thick irregular wall and septa or nodularity inside, then these are signs of invasive carcinoma. Mother lesion, middle-aged female, there is a cystic lesion at the tail portion of the pancreas with a few septa inside. And after contrast administration, you can see outer smooth wall and contrast enhancement at the wall. This is not as much as a cystic PNET, but this is more pronounced than SCN. The last subtype I will mention about are the IPMNs. They are mucin-secreting epithelial neoplasms, and due to the secretion, one will see dilatation, mainly in the main pancreatic duct. At the time of diagnosis or during follow-up, they may be associated with hyperplasia, different grades of dysplasia, or even invasive carcinoma. They have 3 main subtypes according to morphology of ductal involvement. These are branch duct with the least risk of high-grade dysplasia and malignancy. And we have the main duct and mixed types. Here, radiologists should be aware of the field defect. If a patient has IPMN, there is increased risk of PDAC development in elsewhere in the pancreas. This is like a diseased pancreatic parenchyma, like HCC development in cirrhosis. So during evaluation and follow-up of IPMNs, we should not only concentrate on the IPMN lesion, we should carefully analyze all parts of the pancreas. During IPMN reporting, what are your expectations from us? First of all, of course, to identify IPMN and to define the morphology because they have different prognosis and management. We need to comment about the risk of malignancy. For this, there are some guidelines. There are 5 major guidelines with minor differences in imaging criteria. In our center, we most commonly use the revised Fukuoka criteria. Branch duct IPMNs are typically seen as cluster of cysts. They look like bunch of grapes, and there will be ductal communication. Here, multiplicity is an important feature to be aware of, which helps us in the differential diagnosis with other subtypes. It has the least risk of malignancy. Let me show you a very typical case. There's a cystic lesion on coronal and axial T2 weighted images with septa inside. And on the MRCP, the ductal communication is very nicely shown. So this is a very straightforward diagnosis. There are no worrisome features or high-risk stigmata in this patient. Main duct IPMN or the mixed variants are characterized by dilatation of the pancreatic ducts, which may be diffuse or segmental, and one will see nodular structures, may see nodular structures inside the dilated duct, which may be mucin globes or mural nodules. How to differentiate? If these lesions enhance with contrast, they will be mural nodules, different from mucin globes, which won't enhance. Risk of malignancy is higher. Here, it is not difficult to put the diagnosis of IPMN, main duct mixed type. Here, the main challenge is to differentiate this entity from chronic pancreatitis, because they will both have parenchymal atrophy, they will have ductal dilatation. Of course, we need clinical correlation like alcohol consumption. Presence of calcifications or intraductal stones will favor the diagnosis of chronic pancreatitis. And also in chronic pancreatitis, when you compare with IPMN, the dilated duct will be more irregular, but this is not a rule. And we also know that both entities may coexist at the same time. So this makes things more complicated from radiologist's perspective. Here you can see a patient with mixed type IPMN. There is main ductal dilatation. It is more than 1 centimeter. So this is our first high-risk stigmata. There is a side branch IPMN, branch duct IPMN at the body portion. If we concentrate on this, on T2 weighted image, there are some papillary structures inside the side branch IPMN. And this is the pre and this is the post-contrast image. They are enhancing with contrast. And they are more than 5 millimeters. So this is the second high-risk stigmata. Patient had total pancreatectomy, which revealed mixed type IPMN with high-grade dysplasia and also papillary nodule. These are the revised Fukuoka criteria that we use in our center. I won't go into detail, you know better than me. Although not included in the guidelines, if there is dilatation at the dominant uncinate duct, we try to mention this in our reports because recent data have shown that this is an independent risk factor for coexisting high-grade dysplasia or invasive carcinoma. Before I conclude, I would like to briefly share with you preliminary results of our study. It was a thesis study. Patient cohort was 101 patients with pancreatic tumors. More than 90% of them were PDAC that were resected. I and one of my radiologist colleagues reviewed the CT and MRI images of all these patients in our PAC system. We map all the cysts we saw that is included in the pancreatic resection. Then, thanks to our pathologist colleagues, we have performed on-site radiology pathology correlation, and a total of 130 cysts in 101 patients were evaluated together. The rate of cyst detection was more than 50% in this series. Well, it is not surprising because these were patients with pancreatic tumors. The most common cyst subtype, as expected, was retention cysts and secondary ductal dilatations. Second was IPMNs. Rarely we saw SMC, simple mucinous cysts, scopes, pseudocysts, and cystic peanuts. The diagnostic accuracy of MRI was better than CT. The highest mean age was seen in IPMNs. On the other hand, the lowest mean age was in cystic peanuts. Among all the cysts, CT MRI, whatever is available, some of them were not optimal. We had 80% correct diagnosis and 11% wrong diagnosis when we compared with pathology. IPMNs and SMCs were larger, retention cysts were smaller. Multiplicity was most common in IPMNs and retention cysts as expected. On the other hand, scopes, SMCs, and cystic peanuts were all solitary in all cases. An important percentage of patients were shown to have more than one cyst subtype with different pathologic diagnoses. Most common correct diagnoses were retention cysts and cystic peanut. On the other hand, due to the lack of unique imaging features, the most common wrong diagnoses were scopes, squamous cyst of the pancreas, and simple mucinous cysts. I think this point is very important. Cysts that tend to be associated, I mean, adjacent or very close, with the primary tumor were, as expected, retention cysts all the times, but in 90% of cases, they related with SMCs. We tried to further investigate the imaging features of SMCs and scopes. The mean diameter was larger in SMCs. They rarely had septa, but scopes never had septa. SMCs were mostly in relation with the primary mass. Scopes had no contact with the primary mass. What changed after this thesis in my routine practice? Now, I more often diagnose retention cysts around the primary lesion, pancreatic lesion. I thought some of them were branch duct IPMNs. And these are termed as pseudo-IPMNs by Dr. Atsai et al. In one of the papers. Radiologists tend to misdiagnose retention cysts as branch duct IPMNs. Now I am more aware about the non-neoplastic cyst subtypes. And again, I'm more aware about the possible paradigm shift in the SMC. It doesn't look like a simple cyst because in our series, in 33% of the patients, high-grade dysplasia was found in the SMC. I am now more alert about the newly appearing retention cysts because they may be preceding PDAC. I don't know the incidence, possibility, risk, but I know that I should be alert about it. An important percentage of patients had coexisting cysts with different pathologic diagnosis. So during evaluation of PCLs as radiologists, I believe it's important to map the lesions separately. And I believe, thanks to our pathologist colleagues, this was too much work. On-site radiology pathology correlation was the best feedback for us, for a diagnostic radiologist. But still, we have a lot of way to go. There's still so much progress to make because some of the cyst subtypes have only very minor differentiating features. We should investigate further. Thank you very much.
Thank you, Dr. Gürses. It was very informative and nice presentation.
Thank you.
Is there any question or comments regarding issue from audience? Thank you, Dan. I would like to introduce our next speaker of this session, Professor Atsay. His speak is going to be pen nets, benign or malign. Thank you.
Thank you. For pen nets, we wanted to tackle an issue that's fairly problematic. Is what is a malignant pen net, or how do we define malignancy in a pen net? Because this has been a controversial topic for forever, actually. And I wanted to provide you some perspectives from pathology and otherwise, and hopefully we'll have better appreciation of malignant nature of neuroendocrine neoplasia. So currently, WHO classifies or recognizes two very different groups. One is neuroendocrine tumor, which we still call well-differentiated neuroendocrine tumor, although we do not really need to specify the well-differentiated word because tumor, by definition, refers to well-differentiated in the neuroendocrine neoplasia setting. And the other one is neuroendocrine carcinoma, which refers to those poorly differentiated malignancies with neuroendocrine differentiation. Again, we do not need to see the word poorly differentiated, but I like re-emphasizing when I'm rendering a diagnosis, I still put poorly differentiated just to emphasize we're dealing with this high-grade malignancy. Now, what I will try to tackle today is the well-differentiated ones, what we used to call islet cell tumors, because they really resemble islet cells. They try to be islets. They have the vascularity that islet cell. Remember, islets, they produce hormones and they secrete the hormones immediately there. They're endocrine. They don't secrete it to the duct, so they need the vessels. And they do that when they are neoplastic as well, so they are very highly capillarized neoplasms. Again, we used to call them islet cell tumor or islet cell carcinoma. At some point, we used to call them pancreatic endocrine neoplasia. Now we call them neuroendocrine to distinguish those from adrenal gland and thyroid gland, which are the true endocrine organs. One thing you have to remember, though, if you're reviewing the literature on pen nets, you have to enter the word endocrine as a combination. It's actually, this happened to me. I was looking for one of our papers. I go to the literature and I cannot find it. I said, what happened? Did they delete this paper? Then I realized we had written this before the change to neuroendocrine. It was called endocrine neoplasm. So it's important to, when you're doing a analysis of the literature, recognize that they were reported under different names previously. So well-differentiated neuroendocrine tumors are essentially neoplastic versions of islets of Langerhans, as we mentioned. So they form the nest, what we call trabeculae, festoons. There are different descriptive terms we use, but this architecture often and almost always present, and it's the way we recognize these tumors and distinguish them from other neoplasia. Again, capillarization or this delicate vascular network is also an important feature. When we come to poorly differentiated neuroendocrine carcinomas, they are very high-grade malignancies. They're essentially small cell cancers of, as they are described in the lung, very rapidly progressive, very malignant, very aggressive neoplasms. In essence, we think of them as cancers of immature cells. I kind of view them as stem cell cancers because they can have different differentiation lineages too at times. And for us pathologists, it is poorly differentiated means it's hard to recognize, meaning it's not doing something normal. So we often have the differential diagnosis with these tumors of melanomas, lymphomas, and all kinds of high-grade malignancies that do not show their face to us are in the differential. And as such, they are very proliferative tumors as well. Ki67, by definition, is about 50-60%, and invariably it's about 80%. If you have a Ki67 lower than that, you should be wondering if you're overdiagnosing something. Now, let's go back again to well-differentiated neuroendocrine tumors, or what we mean by PANNETs, pancreatic neuroendocrine tumors. Now, these are low-grade malignancies, and I cannot overemphasize this concept. They are all low-grade malignancies. It is a spectrum. It's a spectrum in the sense that if we catch them very early, very low proliferative, yes, of course, they behave benign if we resect them. The behavior is perhaps similar to GIST. GIST are like that too. We see GIST now, morbid obesity operation. There's a small, stomach tumor on the wall, 1 centimeter, 0.5 centimeters. Nobody pays attention to them. Yes, we catch neuroendocrine tumors extremely small. They are more benevolent. But on the other end of the spectrum, especially when they have Ki67 going over 10, they're infiltrative. They are true malignancies that can be aggressive. Now, this is important to recognize. 10-year survival of all comers of neuroendocrine tumors is 50-60%. Okay? When you compare this with all comers of breast cancer, it's 85%. Prostate cancer, it's 95%. So we are dealing with a malignancy that's actually more aggressive than breast and prostate. So it's important to remember. A lot of the prostate, most men are going to get prostate cancer if they live long enough, right? Over the age of 100 in autopsy series, 100%. Over the age of 70, it's about 60% prostate cancer. Most of them are indolent, just sitting there. They're not going to do anything. Yes. Neuroendocrine tumors are not quite like that. 10-year survival is 50-60%. I'll show you more data on that. Now, there's one exception that needs to be kept in mind, which actually a very puzzling situation in terms of management are those neuroendocrine tumors that arise in the context of syndromes like MEN syndrome, VHL syndrome, Mahvash, like glucagonomatosis, insulinomatosis cases, in which the term dysplasia is not used, but probably we should use them. You see in this pancreas numerous tiny little islet proliferations when they're resected. So they are not normal. I mean, I look at this islet, it's large. Can I have said that this is really abnormal? Maybe, maybe not. But then you see a spectrum, larger ones, and eventually some of these become more clonal appearing, unihormonal, and have a capsule and form a well-differentiated, true well-differentiated neuroendocrine tumor. This is similar to those of you if you are doing gastric cancer work, we see neuroendocrine proliferations called enterochromaffin-like proliferations in the stomach due to atrophic gastritis, and same kind of proliferation moving to tumor concept. Now, these become very difficult in terms of management because we don't know as yet whether they are as aggressive as conventional neuroendocrine tumors or not. Now, with the exception of all these precursor or what I call baby neuroendocrine tumors, we regard all PANNETs as malignant. And then comes the question, which is a big problem, pathologically, is there a reliably definable, recognizable adenoma, meaning I can tell you this adenoma, don't worry about it. Is there such a thing for neuroendocrine tumors? And let me tell you from the get-go, no, there isn't. And I'll come back to that by showing you the data for it. So the story of PANNET has gone through a lot of reiterations and goes to show you from where we started. In 1996, FIP vesicle neuroendocrine tumors that were less than 3 centimeters were all called macroadenoma. Perfect, benign, no problem. Of course, immediately data start to come with longer follow-up that they ain't no adenomas. They kill, they're especially 3 centimeters. Then WHO realized, okay, we have to do something. There's no adenoma. How can we define the more benevolent ones, benign behaving ones? If they are less than 2 centimeters, it's less than Ki67 is very low, no lymph node metastasis and no vascular invasion, then it's benign behavior. Now, this concept I always found to be very awkward, very, it's not good, if you will, because, of course, if the tumor is not metastatic, if it is showing it's very small, low grade, low stage, And if you operated on it, of course, it's going to have benign behavior. That's true also for breast cancers. Breast cancers that are 1 centimeter, 99% 10-year survival, right? But we interfered. So nobody now says, let's watch breast cancers that are smaller than 1 centimeter because they survive for 10 years. So this is a very controversial and problematic concept. So of course, more data accumulated, more follow-up, and then we came down to saying, yes, these are malignant. They are T1 malignancy, small, but mostly curable. Now, one thing that got omitted from this statement, mostly curable if resected. So unfortunately, the follow-up starting in 2010 in the US and later on Europe, let's watch these things if they are smaller than 2 centimeters. Now, let's tackle that data and the controversy on that topic. This is a beautiful paper from Carlos's group in MGH Mass General. They followed numerous patients and they found those incidentally discovered pen nets resected. Of the 39, 2 that were smaller than 2 centimeters were metastatic in 7.7%. So you may say 7.7% is not much. Or you may say, wait a minute, 7.7 is a significant, especially considering the follow-up time and especially considering these are resected. And that's actually what this letter to the editor for the same paper is saying. Charles Walmer, I'm sure many of you know, has a very good sense of humor too. He titled this paper, Incidentally, It's Still Cancer, because it was referring to the incidentalomas. Incidentally, it is still cancer. So what he's saying is, yes, they may be benevolent if you resect them, but in follow-up, many of them prove to be malignant. So these are still cancers and should be classified as cancers. And more data on these. If you look at lymph node positivity rate in resected pen nets, about 10% of the doses that are smaller than 2 centimeters in our database is 10%, in some databases up to 15%. So this is a pen net, smaller than 2 centimeters. For whatever reason, resection has been performed. About 1 in 10, 1 in 6 will have lymph node metastasis, even right there and then. So it's already proven its malignant nature. And we know that average size of resected pen nets is 3.5 centimeters. So actually, we're not saying, it's not like these tumors are usually 15, 20, and 2 is the very small version. I mean, actually, about 30% of them are smaller than 2 centimeters. So we're not dealing with a very small subset here. It's a significant issue. And one concern I have from surgery literature is this is what oncologists and us pathologists see. We see a liver biopsy. There's a metastatic neuroendocrine tumor, DOTA PET is done, or whatever mechanism. Oh, whoops, there's a pancreas tumor that is 1.5 centimeters. See, those patients don't come to surgery as much, but oncology literature and pathology literature experiences these things. And that's not captured in some of these papers that advocate watchful waiting. Also, there are some more, by the way, in the SADOT data, I don't think I may have deleted those. Oh, yeah. Sorry, the paper that led to all these things, the SADOT paper, their follow-up is 44 months. So they're concluding on the behavior based on less than 4 years, which of course, these tumors is very inadequate because most of the mortality comes after 5-6 years. And they also selected the patients as low stage to begin with, so they eliminated. So there's a very select group, short duration follow-up, that watchful waiting is based on really very incomplete data is the concern. Here are some things that are coming up in the last few years. Analysis of these databases, NCD database, National Cancer Database. This is one of the American College of Surgeons has this database. And every comprehensive cancer center needs to put their data into this database. And it uses mostly comprehensive cancer centers data, meaning not just primary institutions, smaller places, but really accomplished cancer centers data. So this is probably one of the more reliable databases, especially in the US. There's also a SEER database, which is not good at all. It collects data from everywhere, and it's very contaminated, very inaccurate. It gives some good ideas, but not as good as the NCDB. When you're reviewing your papers, if it says SEER database, you should sit back and say, there may be a lot of issues here. If it is NCDB, still, it's a database, inaccuracies, but more reliable. And this database shows us that the resected ones versus unresected ones, the survival difference is very striking, obviously, not surprisingly. But more important is when you look at the 5 years of the unresected ones, it's 60%. It's these are all less than 2 centimeters. So 5-year survival, unresected PanNet, if we look at this database, is 60% survival, 40% dead. That's quite significant. By the way, I borrowed some of these slides from a colleague in Champalimaud, Anajao, who gave a very nice presentation together with me on this topic. And I asked him to borrow these slides because they're quite nicely illustrating the issue. Same also for when the tumor, when the size is broken down is 1 to 2 versus less than 1 centimeter. Again, 1 to 2, you have 5-year survival illustrated here, actually even lower than 60%. So this shows that they are really malignant. Similarly, between 1 and 2, so this is the group, less than 1, I think data shows you might be able to watch. And if this, by chance, a patient that's not going to grow her tumor or his tumor may be okay. Once it becomes more than 1, then a resection may be indicated. But what I see in this data, at least personally, if it is 1 to 2 centimeters, it really warrants resection. Again, of course, I'm a pathologist. It's easy for me to say. Whipple still has 2 to 10% mortality when we look at carefully. And we're saying it's less than 2, less than 1. But if we are honest, I was reviewing some papers from Europe, some data from Europe there. Oops, I did something. Bir şey yaptım abi da. Şu kablodan olabilir. So in European, in Europe, their databases are showing 5 to 10% mortality of people. So I understand that resecting a tumor that is more slow growing is easy for pathologists to say, not easy for surgeons to do. But at the same time, if we're going to do watchful waiting from pathology perspective, I can tell you, we should do it by understanding that these are malignant and some of them are going to die. So it should be very selective and very carefully employed is the point. And this also shows a very similar result from the SEER database. This is the database I'm referring to that as being unreliable. Surveillance, epidemiology, and results. Some states are having this database. All institutions send their data, but this shows even more striking and worrisome results. But like I said, I suspect some of these are PDACs and other cancers that were misdiagnosed. That happens in SEER much more often than NCDB. I mean, I wouldn't rely, because this is even worse. Look at this, is almost like 45% 5 years. But probably NCDB is much more realistic in this regard. So, yeah, so then I don't, if you ask me, is this a benign PanNet? My answer is there's no such thing, except for those little proliferations in syndromic patients like MEN, etc. Can pathology help? And this part is probably more for pathologists. Can pathology help in establishing which patients are more likely to progress? We have been tackling this question. This is one of the studies we've done with the collaboration, and Orhun was the first author here. In many endocrine organs, a capsulated, demarcated tumor is very good news, such that in thyroid, if a tumor is capsulated, we call it an adenoma. I mean, we call it benign. So, I mean, we know most endocrine organs, this holds true. So we analyzed this concept also on PanNet, and we found that indeed those that are very demarcated and partially capsulated do much, much better than those that are highly infiltrative. Not a surprise. It's just that I don't know where we were all these years. I mean, we should have been doing it all this time, but we don't. We weren't. We will. Because the progression risk of highly infiltrative, by the way, these highly infiltrative ones, all morning I told you, demarcated, fleshy, etc., being non-ductals. Here we see the more aggressive examples. If I look at this, which I did actually, when I saw this case in the growth room, I said, this is probably going to be PDAC. I mean, it's so infiltrative. so curious that I thought it was more likely to be PDAC. Now, this one I know is PanNet just by looking at the gross. So that is kind of the classification too. If it is resembling PDAC in radiology or gross, if it's not demarcated. So actually, I think our colleagues in gastroenterology and radiology might be able to help determine the behavior of these tumors more effectively in the future by paying attention to these parameters. When we looked at our database, those cases that were smaller than 2 centimeters, it was only one case out of 28 that was demarcated that had aggressive behavior. Our follow-up is about 4 years, so it's not extremely reliable, but it just shows at least the trends, because we see that the numbers go really high for cases that are more infiltrative. When you come to the most infiltrative cases that are less than 2 centimeters, half of the 4 of 8 patients had metastatic behavior, liver metastasis in the follow-up. So this is something, you know, if you happen to catch it, these probably grow very fast, so we may not be able to catch them less than 2 centimeters, but some of them present that way. I think these really should be resected. Another thing is, again, if you have a tumor that's less than 2 centimeter, invasiveness capsulation may be one parameter you can use. The other one is the Ki-67. Ki-67, we used to say, notoriously unreliable in the sense that it doesn't really correlate that perfectly with outcome. It doesn't stand the multivariate analysis. However, when you break it down a little bit differently, and we proposed this 2A and 2B, and now WHO, it looks like, is gonna advocate that and put it in the classification. If it is, and this 10%, by the way, was being used by oncologists in metastatic liver cases and extensively. They actually use that 10% more than anything else. So if Ki-67 is less than 10%, we call it G2A. If it is 10 to 20%, 2B, and the metastatic rate is strikingly higher, again, not surprisingly, but when we start to use 10%, it sounds like Ki-67 is going to be a lot more predictive and useful in our daily life. And when we looked at our PanNets that are less than 2 centimeters, 3 of the 6 cases with G2B, meaning more than 10, less than 20 Ki-67, had liver metastasis. Other things we are working on to hopefully help in predicting the PanNet behavior are the cytologic, morphologic features. This has become quite well established now. We propose to call metabolic cell or more oncocytic examples do a lot more aggressively. And we have seen cases with pathology as well. When they're oncocytic, they're often metastatic. So when we see these, we notate so that they can be followed more closely. So going back to our main question that I wanted to tackle, is there a reliably definable, recognizable adenoma, neuroendocrine adenoma in the pancreas? The answer is not really. They're all malignant, but you know, if they're really small, especially less than 1, fully capsulated, very low Ki, non-aggressive, the patient is 70, more comorbidities, etc., with close follow-up, I guess will be the approach. Again, I know this is easier for me to say, it's hard to follow, but at least if you ask me the biology of these tumors, this is what I will have to tell you. The reason I tackled this question is, you know, patients find me, as you can imagine, and they ask me this question. So what should we do now? And I, of course, tell them, go and talk to your surgeons and clinicians, but they want to know from what and I honestly have to tell them, look, this is the data. These things are malignant. You know, there are watchful waiting approaches, but it needs to be done very cautiously and carefully. And this summarizes of the things that I said. I know this is a controversial topic. I hope there will be some discussions on this, and this is all I wanted to present to you. Thank you very much for your attention.
Thank you, Professor. It was an excellent presentation. Indeed, it's a complicated issue, I think. As far as I see, we can clearly say watchful waiting isn't justifiable. It just justifiable for PanNets.
Yes. So okay, yeah. There is European groups that are doing randomized trials on this, and a lot of institutions in the US are in Europe, and also some in the US are using watchful waiting right now. So it became a protocol. It's being extensively used. What I'm trying to tell you is, sure, if that is the decision, go ahead and do that, but don't do it thinking that because these are benign. they're not.
Okay. Well, is there any question or comment? Please.
En son Özgür Mete gelmişti. Nöroendokrin tümörler konuşuldu. Pankreasa da değinmişti o gün. Der ki grade 3'ü A ve B'ye ayırmak istiyoruz. Çünkü bazıları karsinom gibi davranıyor ki 67'den bağımsız. Bazıları da nöroendokrin tümör gibi davranıyor. O nedenle orayı açmayı, nöroendokrin karsinomu da 4'te ayrı tutmayı istiyoruz diye bir deklarasyonu oldu. Bunu da gerçekleştirecek gibi duruyor. Pankreas da bunu söyledi. Siz bu konuda ne düşünüyorsunuz? Daha önce de sanırım Olcan'ın bir çalışması vardı ki 67'leri acaba %50'nin üzerine de ayırsak mı ayırmasak mı diye hatırladım. Teşekkürler.
Yeah, thank you. So the question is for the audience, if there's anyone on the Zoom, G3 cases also as a whole spectrum. So cases that had more than 20% Ki67 in the two previous WHO in 2010 were collected under one group. So what we call G3 well-differentiated neuroendocrine tumor and what we call poorly differentiated neuroendocrine carcinoma were all in the same category. This was due to Italian groups. And of course, there's big difference. There's big heterogeneity. So in 2019, I was involved and we separated out G3 nets. So if I can maybe show, beni X slide'ıma götürebilir misiniz? So currently net versus neck is based only on morphology. We don't care about what the Ki67 or anything shows. If the morphology is well differentiated, this kind of tumor on the left, this is net. Even if you show me Ki67 90%, which will not happen, if you show, I'll say, this is not Ki67, this is some other antibody, or your antibody is not working, something else, because this will never be more than 40, 50%, okay? But I wouldn't care. This is morphologically definable as a neuroendocrine tumor. This is a neuroendocrine tumor. And the other one, neuroendocrine carcinoma, again, it looks like a small cell cancer in the lung, very high-grade malignancy. Even if it shows Ki67 of 10, 20%, we will still call it for the differentiated neuroendocrine carcinoma. And again, if you show this to me and say Ki67 is 15, I said, go ahead and do your Ki67 again. If it doesn't work, again, because it will be extremely unlikely that that morphology will have Ki67 of just 10, 20%, okay? So let's establish that. Now, previous WHO, again, combined these G3 nets and PD nets. 2019, those that are more than 20% but have this morphology is now called G3 nets. So if this case shows Ki of 30%, it's still a net. It's G3, it will be more aggressive, but it's not going to kill the patient in 1 year. Okay. Now, the problem is a little bit bigger because as we look more, we realize there's a third group in between, okay? So there's at the end, there's very 80, 90% Ki bad cancers, and these guys with 25. So those transitional cases that kind of combine the features both, I pulled out those slides. You showed the histology to pathologists. Half of them want to call it large cell neuroendocrine carcinoma. Other half wants to call it well-differentiated neuroendocrine tumor. Ki67 is 40%. What do we do with those is the question. And currently what we do with those is we do immunostains, retinoblastoma, P53, DAX, ATRX, and if you have SMAD4 and KRAS. So if it is RB loss, it strongly favors high grade, the bad guy. If it is P53 positive, even if it is this morphology, they are much more likely to start to behave like the other one. That's actually, there's good data that came up in the last 2 years. If I see P53 on this, I put a note saying, this is well-net, grade 3, but it may transform into very high grade neck. Please watch out. And often they actually start metastasizing pretty quickly. So there are, what I'm trying to say is above Ki67 20%, we have this well-differentiated ones, moderate Ki, we have this very bad ones, and a group in between that we need to sort out better. That's what Özgür is talking about.
By the way,
did I confuse you? I'm sorry.
So sorry. By the way, we have a question from Zoom. Dr. Mustafa Saraçoğlu is asking, do you advise resection to all patients for small pan nets?
It's not, again, I hope I didn't give any, it's not my position to advise anything surgical or treatment wise. I'm just a pathologist making diagnosis, but I read the biology of tumors. I look at them all day long. And I try to understand what they mean and what they do. And I can tell you, you can do whatever you want, even 4 centimeter pen net, if you want, you can watch, as long as you understand that's going to metastasize and progress. That's what I tried to show you. The decision is the surgery field to make. If I have a patient, this one patient has been calling me every day now. It's 6 millimeter, 73-year-old, 6 millimeter pen net. Gürkan Hoca or Orhan Hoca is going to have to deal with it within the next 2 weeks. We don't know what to do. I don't know what to tell her. 6 millimeters. Probably, again, as a humble pathologist, my suggestion is for her to wait 73, wait, and if it is growing, once it becomes more than 1 centimeter, the problem is then she'll probably be 75, or surgery is going to be harder, but that's probably the time to operate. It's a very difficult discussion.
Any comments, questions? Please.
Thank you very much for this great talk and wonderful studies. My question is, I'm so much impressed with the borders of invasiveness of the neuroendocrine tumors. I mean, it is something really that could be detected by radiology preoperatively. Are there any more data on that?
Or endoscopically.
Or endoscopically, right. So after FNA
there are some studies.
Italians,
yeah. Italians are working on it. There's some preliminary data.
How often it is highly infiltrative? I mean, how many of the cases?
It is about 15 to 20% of the cases falls into towards that end of the spectrum.
Okay, that's great.
Yeah.
Okay, thank you.
Actually, I think.
And the other question actually was, you said that we can divide G2 into 2 as A and B, which is another nice study, but also it was correlated, the high Chi-67 score is correlated with the size. Is that correct?
Yeah, no, this is okay. Let me tell you this.
Okay.
This is actually independent of size and stage. The correlation of this with clinical outcome. That's why WHO is going to pick it up. And again, oncologists has been using it. Again, this is one of those things. Where have we been all these years is the question. It's not, wow, this is great. You know, why didn't we use it for decades?
We are done, I think. Thank you, Professor. I would like to announce our last speaker, Dr. Emre Bozkurt. His talk is about patient selection for surgical treatment in pancreatic pathology. Good afternoon. I would like to thank my seniors to give me a chance for making this presentation. Today I'm going to present patient selection for surgical treatment in pancreas pathology, when it is too early, when it is too late. Before defining when it is too early and when it is too late, first we should talk about the importance of appropriate timing in pancreatic surgery and balancing curative intent versus unnecessary morbidity. The pancreatic surgery, particularly for malignancies, is a high-risk procedure requiring precise patient selection. And determining the right time for intervention is crucial to maximizing survival benefit while minimizing unnecessary complications. The goal is to operate when it is necessary for survival benefit while avoiding surgery in patients who wouldn't benefit or could be managed otherwise. A tailored, multidisciplinary, team-driven approach ensures the best outcome.
If we operate a patient and we get the pathology result of small cyst adenomas, small branch duct IPMNs, mucinous cystic neoplasms without high-risk stigmata, and small non-functional incidentally found neuroendocrine tumors, we may think that it's too early to treat surgically. And let's have a look at the characteristics of these pathologies. To avoid unnecessary surgeries, we should be familiar with the clinico-pathological characteristics of these lesions. For small cyst adenomas, it has a lobulated external contour, internal septation, central scar with or without calcification, and honeycomb appearance. While main pancreatic duct dilatation, communication with the pancreatic duct, and pancreatic atrophy and other aggressive behaviors generally considered atypical radiological presentations and mostly encountered in macrocysts and solid cysts. Also, cystadenomas has fine external lobulations. Here in the first photo, you can see that fine external lobulations and multiple thin enhancing internal septations, and fibrous central scar with calcification is a classic feature of seroscystadenoma. And the characteristic central satellite scar with calcifications and thin internal enhancing septations is also seen in the second photo. And within the third photo, the honeycomb pattern of microcysts and central fibrous scar is seen. Within the fourth one, despite their physical proximity of the cyst and the pancreatic duct, there is no communication between these in a recent publication from the Journal of the Pancreas, cystadenomas mostly encountered in middle-aged women with a median diameter of 29.7 millimeters in size and mostly located in the head. But in this series, there is no obstructive jaundice and there is low risk of pancreatitis. So further support the non-invasive nature of cystadenomas, suggesting that attributing clinical symptoms to the cystadenomas should be done with caution. And so when there is no jaundice, recurrent pancreatitis, or cholangitis, we can say that it's early for surgery in that patient group. Also, when we look at the other lesions like small branch duct IPMNs, for small branch duct IPMNs, surveillance discontinuation recommended for branch duct IPMN with less than 2 cm for 5 years period, and stable cyst for 5 years in patient with older than 75-year-old with a cyst smaller than 3 cm or older than 65-year-old with a cyst smaller than 1.5 cm. However, in a recent published series, 22 of 732 patients with branch duct IPMN developed PDAC and IPMN-derived carcinoma with the cumulative incidence of 7.4% within 15 years follow-up. So the question is it early to operate patients with branch duct IPMN? When we look at the multifocal branch duct IPMNs, the multifocality, we know that the multifocality does not increase the risk of high-grade dysplasia or invasive carcinoma of the IPMNs. Management of multifocal IPMNs will be determined by the lesions having the highest risk. And if a lesion is considered to have indication for surgery, then resection only the high-risk lesion should be attempted and others should be left untreated to avoid prophylactic total pancreatectomy. In this situation, for prophylactic total pancreatectomy, we can say that it's too early. And when there is a multifocal branch duct IPMNs and there is no indication for surgery, surveillance should be performed according to the lesions that has the highest risk. And for mucinous cystic neoplasms with no high-risk stigmata, 10% of all pancreatic cyst diagnoses are mucinous cystic neoplasms, and these cysts up to 39% had high-grade dysplasia or invasive carcinoma in resected mucinous cystic neoplasms. And we know that malignancy increases with mural nodules, with cyst size bigger than 4 centimeter, and with the abnormal serum CA19-9 levels. And also the literature support that if resected before the no-invasive carcinoma, we had the excellent prognosis. So we should answer when it's too early. And when we look at that scenario, 2 centimeter mucinous cystic neoplasm with no high-risk features, after surgery, most probably we will deal with the decreased quality of life and also the increased cost with surgery compared to surveillance with routine MRI or endoscopic ultrasound. So can we say surgery is too early for that scenario? Actually, yes, but the current recommendations include resection of mucinous cystic neoplasms in all surgically fit patients due to the need for prolonged surveillance. However, consensus guidelines should take into consideration the long-term implications of postoperative diabetes, especially for pre-diabetic patients after left-sided pancreatic resections. And when we come to the neuroendocrine tumors, small, non-functional, and incidentally, they are small, non-functional, and incidentally found tumors. Professor Atsay talked about it excellently, that 1 to 2 cm is actually in the gray zone. And we know that between 1 to 2 cm, there is 8% of recurrence or distant metastasis. And within this zone, the lesions should also be resected due to this metastatic behavior. And but on the other hand, there is high postoperative risks, and this can be prevented actually with surveillance. So we should be careful for the patients that has a lesion 1 to 2 centimeter in size. And for we can say too early for the lesions less than 1 centimeter for non-functional pancreatic neuroendocrine tumors. When we come to the locally advanced or borderline resectable pancreatic adenocarcinoma, there is 3 randomized controlled trials reported improved outcomes with neoadjuvant chemotherapy or chemoradiotherapy compared with upfront surgery in patients with borderline resectable pancreatic carcinoma. But these trials didn't show any survival advantages for purely resectable PDAC. So if it is locally advanced pancreatic cancer or borderline resectable pancreatic cancer, we can say we might say upfront surgery may be too early. And we also know that when we look at when it is too late, we also know that delaying surgery results in disease progression, loss of operability, and missed opportunities for cure. And also, when we look at the progression and or metastatic disease, failure to recognize rising CA19-9 levels or new lesions on imaging that will be clue for progression or metastatic disease, these signs leads to avoid us unnecessary laparotomies. And when we look at the extensive local imaging beyond surgical resection limit, actually involvement of SMA, celiac trunk, widespread retroperitoneal encasement, delaying intervention in borderline resectable tumors without proper neoadjuvant therapy, risks tumor progression, and these terms generally precludes resection. And delayed recognition of high-risk IPMNs or pancreatic neuroendocrine tumors, IPMNs with high-risk stigmata, these are enhancing mural nodules, main duct involvement, should not be observed indefinitely. And large functional neuroendocrine tumors should be resected to prevent systemic complications. So there is no exact timing for appropriate surgical intervention. It's actually multifactorial and depends on both patient-related factors like high ASA scores, severe frailty, or significant cardiopulmonary disease may lead to excessive perioperative morbidity, and also the disease state is important. We should consider conservative management for low-risk lesions, high surgical risks, or patients who may benefit from neoadjuvant therapy. And we should avoid delays leading to metastasis, unresectability, or worsening patient condition. And we also know that a surgery before development of invasive carcinoma has survival advantages. And multidisciplinary team approach is crucial in borderline cases to optimize outcomes. Thank you.
Thank you, Dr. Bozkurt. And this is also complicated issue, I think, because it's not easy to take the responsibility of patients who maybe will have progressive disease in the near future.
It's actually multifactorial, that there is no one correct answer if it's too early or too late.
Is there any question from audience or comments? Well, we have an additional question for previous talk, question for Professor Atsay. Dr. Recep Erçin Sönmez is asking, based on your presentation, we understand that prolonged time elapsed increases the risk of carcinoma in NET patients, followed with a watchful waiting strategy. Is there a cutoff time for the transition from adenoma to carcinoma that you have estimated?
I wonder if you're referring to neuroendocrine tumors. So let me assume that's regarding neuroendocrine tumors. One question for all of us is, do we really have neuroendocrine tumors that we followed 5-6 years? They started life as 0.5 centimeters, and 5-6 years later, it was still 6-7 millimeters. And the answer, it looks like from the literature and from our experiences, doesn't quite exist. They grow slowly, but in time they become 1-2 centimeters. And actually, even sometimes before they become 1.5-2 centimeters, they metastasize. So for IPMNs, for instance, IPMNs is a good example of adenocarcinoma sequence. Actually, it is the real adenocarcinoma sequence in the sense that if it acquires more mutations, it can become cancerous. We know many IPMNs just stop. They stay there. We follow them. They may be 2 centimeters, 2.5 centimeters for 10 years. Everybody has those cases, and the literature indicates that. For neuroendocrine tumor, I don't think there's good literature saying that they can be, some are going to be stable and not going to grow. So there's an adenoma. That's why I don't think there's a definable, not I don't think, clearly there's no definable adenoma or benign version of neuroendocrine tumor. It's just a very small version of a malignancy. And as a malignancy, low grade, right? I mean, many of you have cured patients that had liver metastasis. You fried them and you resected them, and primary is resected, and with additional oncology therapy, patient is still alive after 10 years. So there's no question neuroendocrine tumors are extremely slow growing, but at the same time that NCDB and SEER databases show us that 40% of them are dying if we just let them be and don't operate on them.
Well, may I have a question for you?
Yes.
I just want to learn it's the best way. Do you think FNH biopsy is adjustable for distinguish neuroendocrine neoplasia or adenocarcinoma?
Final aspiration biopsies?
Yes.
Yes. Final aspiration biopsies are actually extremely useful in solid pancreatic tumors. The problem is you need, operator, interpreter needs to be seeing a lot of these things. And I don't want to sound arrogant and advocating, but if you're not seeing a lot of these things, it becomes much more difficult. I remember the days that I started and everything looked the same. In time, when you see a lot of them, you start to distinguish. Neuroendocrine tumor versus adenocarcinoma distinction is really not much of an issue if you have seen enough of these cases. Neuroendocrine tumor is the differential with either islet cell hyperplasia proliferation and pancreatitis could be difficult. You sometimes aspirate many neuroendocrine cells. Is this a tumor or just a reactive neuroendocrine proliferation? That's a problem that we encounter. Neuroendocrine, or is this adenocarcinoma, solid pseudopapular? Even experienced cytopathologists may have a hard time distinguishing solid pseudopapular neoplasm from PENNET. We have learned the subtle criteria to distinguish them. Those are more problematic, but confusing an neuroendocrine tumor with adenocarcinoma is really not as much an issue anymore, no. Did I answer your question? Was that your question? I'm sorry.
It was actually endocrine tumor, neoplasia, or carcinoma?
Neuroendocrine carcinoma. Yeah. Oh, yeah, okay. So that's again based on morphology, but of course in cytology, cytologic preparations, morphology can be tricky because things get crushed and they're limited. But we rely on the cytology, we rely whether there's necrosis and mitotic activity, and we do perform Ki67 if there are enough cells. Ki67 is very useful. We advocate performing Ki67 in cytology if there is cell block on all neuroendocrine tumors, not because we want to grade between 3%, 5%, but you want to see that it's actually low. It's not 50%, 60%, because it's 60%, you may be undercalling a neuroendocrine carcinoma. Going back to your correct question, most of the cases, that's not an issue. That's partly because neuroendocrine carcinomas are also very rare. That's why it's not much of an issue. But cases that have more intermediate or neuroendocrine carcinomas, we can recognize them by their necrosis, mitosis, and proliferation index. Now I understand. Now I understand correctly. Right? Sorry. Exactly. Sorry about the earlier motion.
Just a brief comment. I totally agree with Professor Atsay. And from the other side, from the lung side, for example, it's always easier to differentiate neuroendocrine tumors from neuroendocrine carcinomas by cytology instead of small biopsies. Yeah. Because if you have a nice material, the morphology is clear. You see much better details, many details, and always Ki67 is with you. So no doubt. If you've got a nice smear, it's even better than a cell block, and you're going to see an example of this. So maybe if
you have time, I'll put the parentheses here too. I'm a surgical pathologist, so I grew up with looking at tissue, but I learned cytology. I like cytology. In time, when I started doing pancreas cytology, I was looking at the core biopsy or cell block first. Later on, I learned how valuable the smears are. So now I look at smears first. I can tell you in Europe, they are moving entirely to FMBs. They're doing core biopsies. They're not doing FNAs. It's not because FMBs are better. It's because they didn't have anybody to read their FNAs. They don't have cytopathology programs like they do in the US, and they don't have outstanding cytopathologists that we have in Turkey, believe it or not. So that drives people. The pathologists did not want to look at FNAs. They hated looking at pancreas FNAs. They say it too, by the way. They don't hold their voice. So that's why FNA was killed as soon as FMB came. In Europe, FNA is essentially killed, which is unfortunate for the patient, because if you do FNA properly and if pathologists learn it, it can be very informative and even more informative than FMBs, depending on the case.
Thank you.
So we actually our team continues to do both FNA and FMB, and I think we have even, broader view about these things now.
Professor Kerem, do you have a question?
Actually, Ki67, it is not enough for correlation between the tumor behavior. Probably we need the new molecular studies, right? What do you think about this?
I absolutely. So, when we were doing, for instance, that study I showed you about the infiltration pattern, but for the first time, we did very careful analysis of Ki67 grade and whether it was independent, and it was pitiful. It was no good. Ki67 didn't survive. Even in univariate analysis, it wasn't that great in our database. Then I went to the literature and looked at it. And when you critically review the literature, Ki67 with the current cutoffs is not helping much. And that, of course, is not surprising. We treat all PENNETs the same, right? Do you pay attention if it's grade 2? Maybe a little bit more worried, but management algorithms regard G1, G2, pen nets, all the same. But now we are advocating if it is more than 10%, it's an independent prognosticator, so that will be very useful for you. What will we do? If it is a pen net you resected, KI is more than 10%. If it's also infiltrative and stuff, I think that patient should be coming to MR or totoped much more frequently, and the liver should be watched very closely because there's going to be a very high chance of liver metastasis in that patient. Yes, we do need molecular markers. There are some in the pipeline, ATRX, DAX, P53, and others. They correlate with survival, but more more research is needed, and to bring it to daily life will take a little bit time.
As I see, we are going to complete morning cases after the coffee break.
Okay, probably the last session of today. Now we will have a multidisciplinary panel with case discussions, and all the panelists are here for cases. We will have 4 cases to discuss, I think. Now I've got a message for everyone watching us that they will join with their questions to us from Zoom and YouTube. So I'll leave the microphone to Dr. Gürkan, and you may begin.
Thank you, Mr. Chairman. So let's proceed with the first case. This is 62 years old male with abdominal pain and GGT elevation. MRI performed, PET-CT performed in another center, and then referred to us. There was no pathological FDG uptake in the PET-CT. I'm leaving the radiologic images to Professor Gürses.
Well, this is not a very optimal MRI, but I will try to comment. Pardon. Orayla oynayacak. On the axial T2 weighted image, you can see dilatation in the intrahepatic bile ducts. And on the coronal T2 weighted image, there's marked dilatation in the common bile duct. Cystic duct unites the common hepatic duct lower than normal. And there is also moderate dilatation in the pancreatic duct. I don't see any lesion on these images. This is an MRC with a lot of artifacts actually, but there is, again, you can see the dilatation of the biliary system and the pancreatic duct. On the T2 weighted axial images, you can see a small common channel, and there is a nodular lesion, polypoid lesion, which is of intermediate signal intensity, looking like a soft tissue lesion, protruding into the common channel, but it's a very short common channel. And at the ampulla, there is a polypoid lesion in continuity with the one I've shown you. So there's a polypoid lesion at the ampulla protruding into the short common duct. Is it soft tissue or not? How to understand? On the post-contrast CT image, you can see extensive, excuse me, very much, I'm tired. There's extensive contrast enhancement in that polypoid lesion. So there is a polypoid lesion with contrast enhancement at the ampulla causing dilatation. Shall I comment about differential diagnosis?
Yes, please.
As to summarize, there is a low union of the cystic duct, dilatation of the biliary system, and a nodular soft tissue lesion at the ampulla. This is of soft tissue density, so this is not a cholelithiasis, or this is not a lipoma. This is a soft tissue, but doesn't have any PET inside. So this could be an adenoma. I would suggest as differential diagnostic consideration. This could be a carcinoma of the ampullary region. This could be a neuroendocrine tumor because it is hypervascular in the early phase. And this could be an IAPN, of course, a perineoplastic lesion.
Now, Professor Alper, would you please... I've started the ultrasound.
I showed you this patient morning session. You can see here that the pancreatic duct, dilated pancreatic duct and common bile duct, caulosus. And you can see here that the other pancreas parenchyma is normal, a little fibrotic. There is no signs of the pancreatic mass in this area. The pancreatic duct diameter is more than 5 millimeters. It's about. The other part of the pancreas channel is normal. In the ampullary area, you can see here that the ampullary and common bile duct main channel, maybe. The lesion is in there. There isn't any sign of the vascularity, but we don't use any enhancement contrast material because Turkey has not available for the contrast enhancement. Ampullary. We performed the FMB biopsy in this lesion. Endoscopy.
Can I ask a question?
Yes.
What is your diagnosis as an experienced expert endoscopic ultrasound? What would you say for this?
I think that I tell IPMN, probably.
So a papillary process occurred in IPMN, in pancreatic head?
Yes.
Okay.
In pancreatic duct. Endoscopy view. You can see here that the endoscopy view, the ampullary mucosa is normal. Probably the lesion is inside of the ampulla. Therefore, we don't see any lesion on this area. Maybe we can take a biopsy from this area, cut and open and take a biopsy, maybe. But in this lesion, no enough for the diagnosis of the lesion because the lesion is pancreatic duct area.
So you don't recommend biopsying directly from this mucosal site
because
you don't get
this
anything.
Site is common by the coedochal site. Pancreatic ducts lower on the site.
Okay. So do you have any other comments?
Ampullary adenoma.
Okay.
With
okay. So let's proceed with the. We have shown in the morning session, Professor Alper performed an FNB biopsy. An on-site pathologic assessment was done. Now, I would like to let the stage to Pınar Fırat for commenting on.
Okay, thank you very much. It's definitely a very cellular specimen. I try to use the cursor. How can I use the cursor? Okay, here it is. Okay, it's definitely a very cellular specimen. And when we get closer, it is definitely papillary. It's not easy to recognize papillary structures on cytology. Generally, the epithelium comes itself and the fibrovascular cores are not there, and it's not easy to define papillae, but we are lucky in this case. Those are fibrovascular cores, and they are covered by epithelial linings. So it is as it is in the histopathology, just a nice reflection of histopathology. So this is definitely a papillary lesion. It's too much crowded. And when we look at the epithelial linings, there is a lot of overlapping among those clusters. And if we look at the individual cells, they have elongated, kind of dark nuclei, some nuclear size variation. If we ask about atypia or dysplasia, low grade, high grade, it's definitely high grade. It is a high grade, it's a papillary lesion showing high grade dysplasia. And that's the nice cell block or FNB. So I can give the microphone to outside here because it's exactly like.
Yes, this is a beautiful papillary neoplasm, an adematous neoplasm that has high-grade dysplasia. Like I said, in the West by WHO, we're not supposed to use the word carcinoma in situ. but I do not care. We are partly in the east. If you need, I can go to Anatolian site and make my diagnosis there. So I'll be also partly Asian. Joking aside, we call these things carcinoma. I call these high-grade dysplasia / carcinoma in situ. And for practical purposes, a case like this, I call this carcinomatous transformation of a papillary neoplasm. This is a beautiful example of an entity. This is the resection specimen we're looking at right now, perfectly matching to what Professor Alper showed. Now, there are two comments I'd like to make, please. This is a beautiful example of IPMN of ampulla, like he said, what we now call IAPN, so intraampullary papillary tubular neoplasms. They're a little bit different by their rate of cancer formation, by their cytologic profile, some of the molecular aspects, but they're essentially an adenomatous lesion growing within the ampulla inside. So for the term ampullary adenoma, what we want is the adenomatous lesion, just like in colon, to be on the surface of the ampulla, on the duodenal surface. When it is entirely growing within the ampullary channel, we call it intraampullary papillary tubular neoplasm. Just finished the chapter for WHO for this, and this is how it's going to be called, unless they change the editors changed it in the last minute, which they do. So this is intraampullary papillary tubular neoplasm cut section. Now, what we did is to show that section is kind of almost amputated the ampulla. So you're looking at the tangential cross section of the ampulla. The pink band here is the Odi muscles. You see the duodenal surface is perfectly fine, just like you saw in endoscopy. The mucosa is stretched, but otherwise it was unremarkable. What Dr. Gürses showed as soft tissue, indeed, they are soft because they are papillary elements, and you see it in the gross section here. And again, carcinomatous transformation. In a case like this, we need to do complete examination to make sure there is no invasive carcinoma. And this was one of the rare non-invasive examples. So let me go back to this photograph and again say something to the gastroenterologists in the audience. You saw this. I think ampulectomy could be very tempting because it's nicely protruding towards you. Even I feel like I want to go inside and carve it out. The problem is many times invasive cancer is deep in the upper part, inner part. I'll show you. We didn't find invasion in this case, but we often do. So I don't think these should be subjected to ampulectomy. Ampulectomy literature is yet another one where they follow the patient for 2 years and they say how perfect we are. In 2 years, nothing happened. These are slow-growing tumors. We have a lot of these cases. Some of them come back many years later. We have 2 non-invasive examples of IAPN that recurred 8 years later. I don't think ampulectomy is appropriate for them. Here's a deeper section. So this is for the pathologists in the audience. Now we do, instead of bivalving, because in bivalving we have to probe the ducts and it kind of pushes the papillary or polypoid lesions outside. So we don't like that. So we are doing this duct-centric cutting, and you see here a common bile duct. And this is the pancreatic duct. In this case, as it was illustrated earlier, the polypoid lesion extended to the pancreatic side a little bit more than it extended to the common bile duct side. More fascinating here, Dr. Alper tells me that diverticulae are common in this region, but we have a beautiful diverticulum. This is intestinal invagination in this area. I often wonder if these anatomic variations have a role in obstruction, chemical milieu change, and maybe participating in tumorigenesis, but that needs to be proven. In this case, there was no invasion. For pathologists, these can be problematic because the dysplastic adenomatous lesion often extends to branch ducts pagetoidally and shows these kind of invaginations that become very difficult to tell whether it's true invasive carcinoma or not. In this case, we think it is non-invasive, but it can be difficult at times. Here's another example of IAPN, by the way. They all look very much similar to this. The mucosal covered lesion. Often the ampullary orifice is dilated, patulous. In this case, there's double orifice, interestingly. And you see the intra-Odi adenomatous lesion, very striking IPMN-like lesion of the ampulla. They are essentially counterparts of ITPN, IOPN, ICPN, all these things that we mentioned earlier, a lot of abbreviations. Bottom line, there are adenoma carcinoma sequence, but it's important to name it properly because the rate of cancer formation is different. Here's another IAPN. Look at the common bile duct and pancreatic duct. The tumor can show a little bit different growth patterns. In our experience, 80 to 90% of IAPNs prove to have invasive carcinoma. And again, that invasion is small and can be upper in the duct. That's why amplectomy would be very tricky to perform. I would, if I was the patient, I would definitely not want that. If PIPL is feasible, I think that would be the way to go. Often invasive carcinomas in rising, these things are small, but they have budding, LVI, and all the aggressive features we attribute. And lymph node metastasis rate is not also trivial, although they are small cancers. They can have lymph node metastasis. So we thought this was a very nice, striking example of IAPN. And again, the point being, it is recognizable by endoscopy readily with the stretched normal mucosa and the lesion inside the ampulla. There's no conventional cancer that will do this. As Dr. Gürs had mentioned, neuroendocrine tumors can look like this, but this is a little bit too elongated for that. Especially ampullary somatostenomas can form this kind of nodules in the ampulla. But otherwise, this will be, now if I see this, you can readily make the diagnosis that this is IAPN and send the patient to resection.
Well, that was actually, I was planning to ask what about ampulectomy, but Professor Atsai killed that question. So the problem is, as Professor Alper showed beautifully, that tubulovillous structure you see in the ampullary region, partially into the pancreatic duct, then you need a cytologist, as our team told us, go for it. This is minimally, at the minimum, high-grade dysplasia. Because you sit there with the idea, discussing with the patient, you should be getting Whipple. Making a decision for Whipple, performing Whipple procedure, you really need, if in this case, you need some pathologic clues to go for it. And I would like to thank our team because they made many things easier for us. I can imagine lacking this kind of possibilities and sources, it would be quite difficult to make such decisions. So no need to discuss after this pathological evaluation. What about the alternative surgical strategies? No chance for endoscopic ampulectomy, no chance for surgical ampulectomy, transduodenal. Any questions about this case from Zoom or from the floor?
Ampulectomy, polypectomy.
No. we performed 10 years ago ampulectomy in the same lesions, but the result of the ampulectomy is not good for the survey of the patient.
I want to ask a question. Even the surgical margins are clear, still the progress is the same? Still bad? Even the surgical margins are clear.
Yeah. So the data about ampulectomy, you're asking. So surgical, the problem with that is, again, we're making extrapolations, but so there's no data on that. I checked this literature very carefully. There are ampulectomy, especially French group, so on. They advocate ampulectomy a lot. If you look at their data, their median follow-up is about 2.5 years, which is totally inadequate for these tumors. Like I said, we have multiple cases. Even after Whipple, they had a recurrence upper in the bile ducts. So many times invasion, you can take out adenoma is very spread throughout, but invasive carcinoma can be very patchy and it can be underneath what you dissect. So I will tell you, so you do ampulectomy, I will tell you the margin shows only low-grade dysplasia. And you'll be assured that that's not a problem, but invasion will be farther up in the duct. And considering 80 to 90% of these have invasive carcinoma, and when they're invasive, they are nasty. I think amplectomy will be a very tricky proposal for these tumors. Staging TNM. Yeah, TNM of ampulla is very confusing and difficult. One thing, we have a large study coming up on that. I recommend pathologists to definitely measure the invasive carcinoma size and report that. That is the only independent prognostic factor we have been able to find. TNM staging of ampulla, the last edition, they changed it based on our papers. It's improved, T1, T2, 3, but still the survival correlation of those T stages is totally imperfect. But if you rely on the invasion size, then it predicts the behavior much better. So yes, if there's invasion, we give T, but this is TIS in situ. This.
Professor Alper.
Generally speaking, surgical ampulectomy is insufficient for periampullary tumors. But in this, specifically in this case, the tumor is very small, and the stem of the tumor is, according to radiologic findings, very narrow. So for this case, not generally speaking, surgical exploration and ampulectomy may be sufficient. According to frozen section examination, and especially the histologic appearance of the radix of the lesion, we may think that this operation is sufficient. If there is a wide invasion area at the stem of the lesion, we may return to Whipple operation at the same session. Generally speaking, to prevent the misunderstanding, we don't advise ampulectomy for periampullar tumors, but especially for this tumor, I will prefer surgical ampulectomy.
So this tumor proved to be non-invasive. So I appreciate that, and I think it's a very good advice. This tumor proved to be non-invasive, so it would have been beautiful to do surgical ampulectomy to this one. But again, 80–90% of the time, there'll be invasion, and if that invasion is less than 2–3 millimeters, lymph node metastasis rate is about 10–15%, which is not trivial. But when you have more than 0.5 centimeters invasion, which is difficult to detect, lymph node metastasis rate is 42%. So I think the issue here is that these are not as like colonic adenomas. They have higher rate of lymph node metastasis, and amplectomy will not take care of the lymph node metastasis. So that will be the, I mean, I think, again, French groups are advocating it, but their data is not reliable to assure that they are curative procedures.
Okay, thank you for the first case. So we can continue with the second case.
Okay. 74 years old female, and osteoporosis detected during dental treatment. Complain itching after the initiation of osteoporosis treatment, and then medical treatment stopped and CT performed due to this itching complaint.
This is a video contrast enhanced CT examination. Here you can see the dilated pancreatic duct. Please follow the dilated duct to the proximal portion. And there is now abrupt discontinuation in the duct, and at that part of the pancreas, the unsnake process and the head, there is a lesion, relatively demarcated lesion, which is heterogeneous. Oh.
Yayını bir durdur. Diğerlerine bir hızlıca bakacağım.
So there was pancreatic ductal dilatation, there was abrupt discontinuation, and there was a met lesion. Now I will show you the axial and coronal. O bitti. It's finished. Excuse me. And now you can see on the coronal CT image on two different sections, the mass lesion at the proximal part of the pancreas. It has relatively demarcated contour with lobulated borders. You can see pancreatic ductal dilatation and more pronounced common bile duct and intrahepatic biliary ductal dilatation. There was no arterial invasion. If this is a malignant lesion, we have to stage it. There was just less than 90% close contact with the superior mesenteric vein. There were some lymph nodes at the peripancreatic area, less than 1 centimeter. So this looks like a malignant pancreatic lesion. There was no metastasis in the lung.
I performed the US this patient.
This was
there is
solid, right?
Yes. You can see here that the portal vein, supermesenteric artery, splenic vein, and middle. Yes, you can see here that vascularity. Supermesenteric vein, portal vein, splenic vein, inferior mesenteric vein, and the other side is hepatic artery. The upper side of the hepatic artery. Yes. The upper part of you can see here the common bile duct. Yes. Hepatic artery, common bile duct, and pancreatic duct now. Biraz ilerletelim. Now you can see here the lesion in like a tomography. The diameter of the lesion is about 3 centimeters. The margin is not irregular margin. And there is a different part of the lesion in this area. There is, you can see here that the vascularity, capillarity, the capillarity of the lesion is little. The other part of the pancreas.
So before calling out the name of the pathology, what was the indication of endoscopic ultrasonography and biopsy on this patient? Do we have to do that?
I don't know. I don't remember it. Generally, we have to perform.
Refer it with
the
mass.
Okay, I got it. We have got a solid mass and the double duct sign.
The direct surgery.
So yeah.
Yes.
I'm asking for the discussion. What is the reason of biopsy now in this patient?
Now,
use direct surgery in this patient.
Bengi?
It was somewhat demarcated. So it was not very, very typical for an infiltrative hypovascular PDAC. Maybe that was the reason.
But then question is, even that should be resected.
Yes, of course.
Even that should be resected,
yes.
Right? That's what you're saying.
Yeah.
We have 3 different patients. The endoscopic view, tomography and MRI view, it's about pancreatic PDAC, but biopsy results, lymphoma. Okay. 3, yes.
I was going to mention the same thing.
We perform generally US biopsy from the surgery, before the surgery.
Yeah, opening the mind for discussion. Okay.
Yes. There's a different area in the middle of the lesion, and I performed the FMB biopsy to the different area, center of the lesion. FMB needle. Generally, I use FMB needle for the solid pancreatic duct adenocarcinoma for the diagnosis. The tough lesion, and yes, I prepare the needle for the exact target area. And now, yes, my target is in this area.
Okay. Now, after the biopsy,
okay, we've got a wonderful specimen again. That's number one, as I said before, and we need good material, and it's perfect. It's full of cells, as you can see here. Again, maybe a little bit similar to the previous image that we have clusters. However, this time they do not have those fibrovascular cores, but this clustering and kind of monolayering, even though it's not so regular, is a sign of adenoid grouping. So when we, oops, what happened? Sorry. There should have been some other, may I go backwards? Okay, probably we don't have another image, but you can easily see those clustering cells plus some dispersed cells in the background. We can see them at higher magnification, so I'm not commenting on their cellular features, individual cellular features, but let's move to the other one. Oops. Sorry. Yes. Okay, that's the FNB. FNB clearly shows two different morphology. I mean, in between those adenoid malignant cells, I mean, adenocarcinomas, this is so clear, a very complex glandular structures, and the cellular details are definitely in favor of malignancy. This is the adenocarcinoma part, but those are the cells which were singly distributed in the background of the slides. And if we go for, they look a little bit monotonous, but still they look high grade. And when we do some immunostains, those adenoid structures are not staining. However, the kind of monotonous or solid areas are positive with a neuroendocrine marker and much nicer with CD56, even though endocrine pathologists do not like CD56 much. It's a very nice neuroendocrine marker for high grades. As a lung pathologist, I love it. And again, the adenoid structures are negative, but the other component is clearly positive with neuroendocrine marker. And this is in contrast with pancytokeratin, the glandular malignancy. Adenocarcinoma is densely positive with cytokeratin. However, a very weak staining for the second component. So it seems that this is a combined tumor, and the Ki-67 is definitely high in the neuroendocrine part. So it's a high-grade neuroendocrine tumor, means neuroendocrine carcinoma, high-grade, plus adenocarcinoma, which we more commonly give that diagnosis again in the lung. However, it does exist also in the pancreas.
By the way, that 56%, we really did sit and count carefully because there's literature from Sorbia, the Swedish group, on neuroendocrine neoplasms. They found that 55% is where we were discussing earlier in the morning. 55% is where cisplatinum starts to work. And under that, you shouldn't give cisplatinum, was their conclusion. So when Giselle counted this, she came as 55%. I said, no. It's either 54 or 56, one or the other. You cannot give me 50, 54, 55. So it was 56, and then actually in the resection it proved to be 80%. So yes, this is a large cell neuroendocrine. It's extremely rare. I don't want anybody to think that we see these things. This is the first example of true adenocarcinoma admixed with neuroendocrine carcinoma of this kind, convincingly like this in the pancreas that I have seen. There are examples like this, but not quite as good. Now, the thing is, of course, EMRA is, hits the bullseye and it becomes a problem for us sometimes. And this is one of those cases. If he just stayed in the periphery of the tumor, we would have given the adenocarcinoma diagnosis and it would have been much easier. But he went to that exactly that area that he showed, that other nodule, that's actually where all the neuroendocrine cell clusters are. The carcinoma, neuroendocrine carcinoma component is, and that's actually looks like a polypoid lesion in the duct. This is one fascinating thing. A lot of these peculiar tumors like osteoclastic one that I showed earlier, adenosquamous, and these things, they start as a polypoid lesion in the main duct and then become more aggressive. And you can find that residual intraductal polypoid bizarre lesion. For some reason, they're exposed to peculiar chemicals there and they have this plasticity. Who knows? So our diagnosis was this is a PDAC, and there was a mixed neck component, again, very rare. In resection, Ki67 was 80%. Now, one thing is, for this is mostly for pathologists, WHO uses MINAN and MANEC, and I'm on those chapters. I think these are all terms for conceptual purposes. A diagnosis should not be MINAN or MANEC. Instead, we give the diagnosis, this pancreatic ductal adenocarcinoma, 3 centimeters, and there's a neuroendocrine carcinoma component that is so and so. Now, one thing about these mixed neuroendocrine carcinomas in the GI tract, there's evidence that they need to be treated like neuroendocrine carcinoma, even if it is a small component, 3, 4, 5 millimeters, because eventually that's the part that explodes and take over and kills the patient rapidly. When they biopsy these metastatic things, that's what we see. But in the pancreas, this is extremely rare, and PDAC is already a bad cancer. So when the question came up whether this should be treated with FOLFIRINOX or a neuroendocrine protocol, we don't have any data. There are no control studies. These are extremely rare, but it makes sense to me that this will be FOLFIRINOX at least at the beginning, and then later on, if it starts to behave like neuroendocrine carcinoma, then perhaps treating it neuroendocrine, because it's a very small component, polypoid, and may not be that significant. Only time will tell. Any questions?
Thank you. Are there any questions for this case?
Mustafa John?
I want to start some debate, especially the resectable pancreatic tumors like these. A perioperative biopsy is needed or not? Our practice, if we have high suspicion about the lymphoma or autoimmune pancreatitis, we prefer the biopsy. Otherwise, we choose the surgery first. No need biopsy. Especially surgeon members of need it or not.
For this case, not biopsy before surgery, not needed, I think.
I can tell you, I don't know, John first.
We wouldn't request biopsy for this type of cases. And I couldn't understand why you did the biopsy.
Yeah. So maybe I can, if I can just say one thing on that. In Europe, and this was discussed just recently in Lisbon. In Europe, this is exactly the approach. They don't do biopsies. Büchler, none of those guys. It's immediately they go to surgery. In the United States, nobody will operate on anybody without a biopsy. So there are totally different cultures, and in most places in the US, they will do FNA, or because that's kind of the standard protocol for them to continue, and their payment protocols is also linked to it. There are groups, of course, are much more surgery prone, but typically they will have to request the biopsy first. That's why actually we were seeing that where I worked, I was seeing FNAs and bile duct brushings even more so than here from every case. Yes, sir.
Yeah, as far as I know, it depends on the neoadjuvant protocol of the institution. if they send all of the pancreatic tumors to the neoadjuvant treatment, they need diagnosis. So they take biopsy. But
even in the US, even if it's not a neoadjuvant resectable, they do the biopsy for medical legal purposes.
Yeah.
I mean, there was one time actually, despite biopsy, my best friend surgeon there did an operation, proved to be autoimmune pancreatitis. And then he said after that, and he was sued. And he said after that, I'm not going to do any operation from now on unless there are at least 2 biopsies performed. So this is a common practice in the US. I can assure you, they do biopsies virtually on every patient before they get doing a Whipple.
The reason they're doing biopsy in every case,
medical legal.
From legally, they may need not to go to court.
Yeah, exactly.
The other one, if you send to this type of patients to, let's say, endoscopy department, this is a kind of
extra work for
yes.
different groups. Correct.
I don't want to say, but
okay.
you understood.
Yes. Yeah, that's understood.
Some kind of insurance.
But also the paternal medicine concept too. You know, if it turns out to be a negative tumor as pseudotumoral pancreatitis, it's not as big an issue in Europe, clearly, because I asked these questions to European surgeons. They just tell the patient that's how it is. You know, some cases prove to be like that. That you cannot do in the US. That's not a good answer. But so it happens. So it happens, but you give $1 million in return.
So 10 to 15% of the pancreatic masses are benign. So I think it is acceptable to see some kind of patients.
Yes, of course. And even in the best hands with biopsies, you still have 4 to 10%. Yes, no question.
Yes, but we are not in Europe. We are not in the United States. So most of the people should draw some conclusions from this meeting. So we have a message to, for instance, to Turkey. So it shouldn't mean that every pancreatic mass who comes in with itching, with bile duct dilatation, with pancreatic duct dilatation, and again, an operable mass in the head of the pancreas should undergo endoscopic ultrasonography, a biopsy. We, as old school or some new school, we always do surgery in those cases.
Yeah. Can I give you 3 different patients, example patients? One of them, the patients of the Gürkan Tellioğlu, 45 years old female. The patient referred to the surgery, pancreatic adenocarcinoma. The biopsy result is lymphoma B cell. And the other part of the patient for my patient for the surgery, T cell lymphoma.
Ama lenfomanın radyolojisi farklıdır biraz.
Radiology.
No,
tell the doctor.
I have chosen this debatable cases on purpose because this patient came to our center for second opinion. Another surgeon suggested direct operation, no need for biopsy. And because of some atypical findings on imaging and 75 years of, 4 years of age, I tried to get more biopsies. I accepted. Probably quite feel like I'm living in the United States. I just, on the medical legal perspective, I'm trying to, that lymphoma patient came from Yugoslavia and diagnosed with cancer.
Yes,
she had the biopsies, everything. But what happened was I was for a meeting outside of Turkey. They let me know that the patient is going to be in Turkey on Monday. I said, I'll be there Friday. The resident, I don't know for what reason, resident asked for blood tests repeatedly. The patient came with 5, total bilirubin level 5. And 1 day later, it went to 4. 1 day later, it went to 2.5. And the day of operation, when I came, I asked, why did you repeat all these tests? And it's going down. What is wrong with it? Check this again. when we repeat the blood test, it came 1.2. And I said to Emrah, just take to the endoscopy suite. And when he checked, he said, this is not typical pancreatic ductal cancer. We made the biopsy, and then it came out that it was B-cell lymphoma. You're right. There are some differences in radiologic imaging, which lets us force the biopsy. But sometimes, as in this case, mixed type of tumor, maybe the neuroendocrine carcinoma component would have let us start neoadjuvant before operation because of this type of histology. I try to use more biopsy. I know this is going to be operated, but just to be on the safe side.
Yeah,
I
I think
understand.
safer zone for the surgery.
Ama öyle ya da böyle alınan o ince iğne, EUS eşliğindeki ince iğneyle tedaviye gitmemiştir. İlla ki bir lenf nodu yine de çıkarılmıştır o vakada herhalde.
Yok. Çok sayıda lenfoma vakamız var sadece FNA. So we
Öyle
have,
mi?
Tabii tabii.
we have FNA diagnosed
Doğru,
lymphomas
güzel,
that go to treatment based on that.
Yeah.
Common bile ducting.
Repeated biopsy for flow cytometry. I convinced the patient. I asked her to do the second endoscopic ultrasound, and then we treated without operation.
Yes, but one important thing is, of course, the logistics, as Corey just said. The logistics is also important. So, here we are very spoiled in the sense that, like in the US, where we discuss the patient at 7:30 meeting, and Emrah who just question often is the patient hungry? MPO, so I can do the US right now. So when we have that kind of luxury, of course, I mean, US is done very quickly, and the result comes, we do immediate evaluations. So we do not delay the operation more than a day or two. The only thing is, and the complication rate is very low too. Is it adding a lot? I don't know, but is it deleting or harming? Most of the time, we don't see any harm in doing it either. So, but I know in other practices, it's not as easy to get a US FNA biopsy. It takes time. The interpretation of FNAs takes much longer. Our logistics is a little bit different in this institution in that regard.
Lymphoma is very exceptional result for these patients. And for your patient, it's very typical suspicion for adenoid cancer. Very, very typical. But this result supports our theory. If you have a suspicion, no biopsy, direct resection.
We love biopsies. At least we learn.
Ben Volkan hocama bir şey daha soracağım. Biz GIST'te maneklerde %30'un üzerine çıkarsa komponent tanıya taşıyoruz.
Evet.
Burada
çok yanlış. Çok yanlış. Çok yanlış. Yeah,
yani
the question is in Manek,
bu genel
WHO recognizes, yes, I'm part of that chapter and we discussed this at nauseum. In GI, they recognize Manek if the neuroendocrine carcinoma component is 30%, the patient is going to die in 6 months. There is overwhelming evidence in the literature, and we're just doing yet another study with Cleveland Clinic. Even a small neuroendocrine carcinoma component, it behaves like neuroendocrine carcinoma. It does widely metastatic disease. It responds to cisplatinum. Response meaning it goes away, of course, comes back in 3-4 months, but it shows all the behaviors of neuroendocrine carcinoma. They do biopsies on those patients. The biopsy often shows neuroendocrine carcinoma, not then like lung metastasis, bone metastasis. It shows neuroendocrine carcinoma. Although the primary tumor was just 3-4 millimeters neuroendocrine. Big adenocarcinoma, small neuroendocrine. So there's overwhelming evidence that even a small neuroendocrine carcinoma component should be reported. How they treat it is not our business, but there's no question if you see even a small component, you should report it. Management can be discussed separately. No, I know. I mean, when we read the Bible, right, or Quran, whatever you want to call it, it says 30%.
Okay, nice discussion, but let's carry on with the third case.
Yayındayız değil mi? Mhm. Okay, this is the third case. 67 years old male, abdominal pain was a complaint. He had an history of pancreatic cancer in his brother, uncle, breast cancer in his aunt, and endometrial cancer in another aunt. So with the computer tomography,
You can see on the left side the arterial face and on the right side venous face images. There is a really demarcated lesion at the proximal body part of the pancreas. It is around 3.5 centimeters. You can see the ductal dilatation distal to the lesion, and there seems to be some parenchymal atrophy. The lesion is adjacent to the celiac bifurcation, but there is no objective sign of invasion. There is peripheral rim-like enhancement, and the central part of the lesion doesn't enhance with contrast. It's hypovascular, maybe necrotic. On the venous portal face image, you can see that the lesion is very close to the SMV and portal confluence. On the coronal image, you can again see it's adjacent, but there was no objective sign of macroscopic invasion. And these are the outside MRI images. On the axial T2 and coronal T2 weighted image, you can see pancreatic ductal dilatation and the demarcated mass lesion, which is not typical for classical PDAC. After contrast administration, again, MRI showed peripheral rim-like progressive enhancement in the lesion. And there was no thoracic metastasis.
What are the most atypical part in this imaging that you especially mentioned?
The demarcated feature of the lesion. It doesn't look like classical infiltrative PDAC. It looks like some subtypes of PDAC, like metaplastic, I think, adenosquamous. We also call them centrally necrotic type, or like neuroendocrine, but it doesn't look like a low grade. This was the main abnormality, and I didn't see involved lymph nodes around the lesion.
And then we performed.
And really, the lesion was necrotic. After several aspirations, still few cells. Here you see, sorry. Here you see those clearly hyperchromatic nuclei and binucleation and differences in their shape and size. So they are very abnormal cells looking malignant, and they've got a cytoplasm. And you can even say that those cytoplasms are eccentric, so looking very much like an adenoid cell, actually, looking very much like an epithelial cell. And you're in the pancreas, and somebody's telling you that has a family history and some malignant mass, and you're dealing with pancreas, just few cells. The question for us in this case might be whether I should call this case malignant or not, or should I stay a little backward and just say suspicious for malignancy, but we call it malignant. And of course, they look very epithelial. So, and looks like adenoid cells. So, okay, consistent with a high-grade adenocarcinoma, maybe. So they look like carcinoma cells and malignant. And that's all I could say. I'll come back again.
So yeah, like Fran said, the cytology is clearly malignant and it looks very epithelial. So it looks like a bad carcinoma, bad cancer. We see some of the more cytologic preparations here of the cells. And in gross examination, this tumor was very hemorrhagic, indeed demarcated and with central necrosis, as illustrated in these sections. It's the photographs are not that great, but this is viable tumor here. And on the lower left, you're seeing all necrotic material. The center here is all necrosis, and there's some viable tumor in the periphery. So indeed, it's a central necrotic demarcated malignant mass. So it looks like those metaplastic carcinomas. But when we looked at the cytology of this, with this peculiar serpentine
nucleolar formations and abundant vascularity. We thought this could be epithelioid angiosarcoma, and indeed, the spatial stains confirmed with this is ERG, and it's a good endothelial marker. This is CD31. The positivity of these two endothelial markers nailed this as epithelioid angiosarcoma. This is extremely rare, very, very rare. We have a handful of examples of these, and some of them are clearly arising in the background of adenocarcinoma. And that's a very peculiar thing, you know, adenocarcinoma, angiosarcoma, totally independent tumor types in theory, but in thyroid, this is a well-known phenomenon. Anaplastic thyroid cancers can have angiosarcomatous differentiation very prominently. It's actually not uncommon in mountainous regions, in Peri-Italy and also in Turkey. And we see the same phenomenon in angiosarcomas. Most of the ones I've seen, again, handful examples, had some carcinoma in the background. In this case, we couldn't find an adenocarcinoma component. It was all epithelioid angiosarcoma. PET. I don't know if you had PET. I don't remember, to be honest with you.
Okay, we don't have PET CT for this case, but why we wanted to share with you, this is a very extraordinary case that operated and received this angiosarcoma definitive histopathology. This is the second month after operation. It's just like the patient didn't get any operation. All the mass came back immediately, and the survival of this patient was almost 2 months. At the end of the second month, we lost the patient. So this is a bizarre pathology that we see some extraordinary cases, but this was the most severe one, and just wanted to share you. Might be a biopsy operatively, but the definitive biopsy can change everything. If we had known it before, of course, we wouldn't prefer to operate this patient. Any question about this?
May I comment on the cytologic diagnosis of angiosarcoma? It's nearly impossible if you come across this tumor in an unusual site, because it clearly looks like carcinoma. It's quite difficult, like a simple twist of fate. I mean, it's the nature of the lesions, so always a problematic issue, unless you have a clinical clue, or unless you think about angiosarcoma. It's definitely difficult pre-operatively.
Thank you. Any questions about this case? So should we perform PET CT to all patients with, is that the question?
What would it change? Maybe we're going to show the distal metastasis, or what?
The issue was local recurrence, not systemic recurrence. Well, in this case, yeah, in that case, if there is a distant metastasis, we always check. These patients have thorax computed tomography routinely. So we didn't suspect any distant metastasis. And we have the abdominal imaging.
Epithelioid angiosarcomas behave this way. This one behaved very aggressively. They are not all like this. So,
yeah, should have been treated. Actually, yeah. Any BRCA mutation in the family? I wondered.
Well, I remember we have asked actually the family to go for molecular kinetic investigations, but we didn't get.
It's a black box. It's very problematic. We send the patients to genetic analysis. We would like to know what the results are, and we never know what the results are. I know it's patient privacy thing, but it doesn't have the patient. The patient comes back to the tumor board. We still don't know if the patient has BRCA. That could change the treatment. Only the genetic department knows the results of these tests, because they are not part of the patient record in the hospitals by regulation, apparently. And it's a problem for management. As HPB, maybe we can advocate. I know. It's just a joke.
This patient preoperative CT showed that the tumor nearby to the celiac axis and SMA.
Yes.
Maybe could think to neoadjuvant chemotherapy. Probably after neoadjuvant chemotherapy, they show that they like this because the surgery maybe no need this case because just 2 months and local recurrences. What do you think about this case, the neoadjuvant chemotherapy?
In this case, the preoperative imaging was not locally advanced. It was borderline, but surgically operable borderline. So we didn't have any biological borderline issues, no idea about this kind of histopathology. We are increasingly using neoadjuvant treatment in pancreas masses. We have now more than 110 patients who have been operated after completing neoadjuvant, but in this case, prefer to go for operation. But you are right. If we have chosen the neoadjuvant treatment in this case, then the patient could have been saved from an unnecessary operation. That's why the main focus for this group of patients, we are trying to understand the biology of the tumor. The selection of the patients to go for neoadjuvant, starting point resectable, but biologically unfavorable, like CA99 level 1000. We send those patients to chemotherapy to be able to understand what's going to happen within 1-2 months. You're right about that.
I'm talking about adenocarcinoma.
During this operation, tumor rupture, because this looks like an intraoperative dissemination a little bit.
Well, actually, nothing special that I know about this operation that we retrospectively accuse the situation due to the technical issues. It's a total pancreatectomy without any event. And after this pathology came based on the specimen, that was the period, like 2 months ended.
The specimen looked intact, but it was, of course, protruding like many masses, soft tissues, but totally intact.
So may I proceed?
So your previous answer was about adenocarcinoma, right? Not for the angiosarcoma.
No, yeah, adenocarcinoma, of course.
Okay, because if we prefer to give neoadjuvant chemotherapy to this patient, the result will be the same. I think the surgery will be was the only shot for this patient, the resectable angiosarcoma. So why did you think?
If you start with a treatment in 2 months, seeing like a picture like this, you would say that.
Sure, but before surgery, we know that this patient is angiosarcoma, right?
Adenocarcinoma, right? Not the
Sorry, the preoperative biopsy was adenocarcinoma. Now I get it. Okay, now I get it. Okay, now I get it. Okay.
We wanted to show cases here that, life is not always perfect, so
yeah.
Sometimes we don't exactly know what we were dealing with. Yeah.
Okay, may I proceed? Please. This is the last case. It is not proceeding. Okay, this is the last case. 44 years old man, abdominal pain, pancreatic mass, EUS biopsy, invasive carcinoma reported in a center. The patient went to another center, and in that center, imaging based on that biopsy, invasive cancer, liver metastasis, FOLFIRINOX treatment started. After 2 cycles of FOLFIRINOX, the patient came to our outpatient clinic for second opinion, just to ask. And it's twisted, but this will be the biopsy. Let's not lose time, and
this is the outside FNA actually, but unfortunately we do not have cytologic slides. Maybe the previous pathology department also didn't have a cytologic slide, just have the cell block, because that occurs. I see this in our consultation cases. Sometimes smears are not done, or they are very poorly cellular, just cell blocks are existing. So this is a cell block section. It's not an FMB. So the cells are just within the blood. If you look, they look a little bit monotonous, but I stop here. I don't continue. It's going to be a spoiler.
Okay, now I just want to.
Well, this is called an adenocarcinoma. Yeah, because it's, well, why it is interpreted as an adenocarcinoma, I think, because they look a little bit pleomorphic and the mind is so much looking for adenocarcinoma and they don't see the real architecture because they don't have the cytologic smears. Yeah. If we had the smears, probably they wouldn't do this mistake. So this is so monotonous. Yes, yeah. I agree.
Everything started with the imaging. When I saw the imagings, it simply told me what I've learned from my expert radiologists. It didn't look like a PDAC liver metastasis. It was completely different. That's why I requested the samples of biopsy to make a consultation with our pathology department. And I asked to my radiology department what would be their comment. These are the cytologic, so I'm, okay. So anyways, the previous sample was evaluated as neuroendocrine tumor. And because of this technical issues, we didn't want to have any trouble. So we also performed liver through-cut biopsy, which came out also neuroendocrine tumor.
I think this was before neuroendocrine diagnosis was concluded by our pathology department. Here on the CT image, the first thing you see is a lobulated nodular structure, soft tissue, hypervascular nodular structure in the mesenteric plate. You can also see it on the coronal image. It looks discrete from any other organ. There was another mass, similar in density, both had millimetric calcifications inside, but this mass was different. It was adjacent to the pancreatic uncinate process. It was like giving the impression of a pancreatic tumor, hypervascular tumor with an exophytic growth. But with careful analysis, I will show now the hypervascular liver metastasis. So this was different from adenocarcinoma. We had hypervascular metastasis in the liver. So we had to now try to find a hypervascular primary. And with careful examination, we found a hypervascular lesion in the duodenum. As you can see, it's a submucosal intramural hypervascular lesion seen on axial and coronal images. This was the primary, and this is very typical for small bowel neuroendocrine tumors. The tumor deposit and the hepatic metastases are mostly more prominent. You first see those lesions because they are bigger, but we have to know this entity as radiologists and try to find the primary lesion in the small bowel. And we need arterial face imaging for this because they enhance contrast maximally at the arterial face. Do you have any questions?
You have. Now, the reason why we wanted to discuss this case was this is such a teamwork. Now, another center making a biopsy, giving a report, the patient going to another center, oncologist, without checking the imagings by herself, just reading the report, because it is reported a pancreatic mass, liver met. So biopsy shows invasive carcinoma. So you can think it's a PDAC liver metastasis. We all wanted to emphasize that this is a multidisciplinary teamwork. Sometimes even there's a biopsy, it might be checked. As a clinician, we have to check the imagings if there is something wrong, because only reading the reports, don't forget in this many hospitals, the radiology imagings are being reported by someone who doesn't have anything to do with the patient, sitting at home from the computer, fastly recording the report, sending to the center, nothing to do with the patient. So we need to work in close cooperation with radiology, pathology, endoscopic ultrasonography, and MDT boards to decide best for the patient. That was the reason why we wanted to. This was a duodenal neuroendocrine tumor with liver metastasis, now 3 years of follow-up and alive without any recurrence. I just wanted to share this. For all the cases we have chosen, we just wanted to discuss. There is no perfect story in this area. We are trying to get as close as we can to the perfect site. I'm really feeling myself blessed regarding all the disciplines that I'm lucky to have the chance to work with: pathology, radiology, gastroenterology, our surgical team. Yes, I feel blessed, and I would like to thank all of them for giving us the chance to build up all these successful programs as much as we can. We want to go further. I would like to thank the director of the Turkish HPB Association, Mustafa Kerem, for convincing us to take more part in HPB surgery in the nationwide. Thank all of the disciplines, especially Volkan Atsay and his team, Emre, our mentors, Aydın Alper, Orhan Bilge, and I'm so happy to have Koray Jarlı here today as well. I would like to thank all of you to help us to discuss all these things, and I would like to thank everyone who followed us from Zoom and YouTube. While we are finalizing these discussions with the case, any questions, any final comments about today's meeting or for further future discussions, I would like to give chance to finalize our meeting. For the last patient? Yeah. Yeah. Re-evaluation of the primary biopsy and check for the Volkan Atsay, I just want you to, you have lots of efforts today's meeting and our practice. I just want you finalize today's evaluation because it's pathology courses for HPB surgeons. I would love to have you finalize the meeting.
Perfect. Thank you very much for the great opportunity. Always great to see pathology to be appreciated, and if you can really contribute to what you do as surgeons, gastroenterologists, to your daily life, to your practice, if you can have more, of course, it's more the better. I thought this was a great conference. Like I said, we tried to select cases, not always perfect. Life is not always perfect. There are things we can really do successfully, and there are things we don't. We just look back and say, oh my God. So I'm hoping we illustrated the spectrum of things. I hate to say this, but I really feel so blessed that I'm working with a fantastic team. I can tell you, I think it's important perhaps to mention, I really think the medicine in Turkey and HPB teams in Turkey are really outstanding. I don't think we announce ourselves and present ourselves as strongly as we could because of the politics. I've worked in multiple institutions in the US. I know their results. I know their skills. I think as HPB, we really stand as good as any HPB in the US. And I'm beginning to appreciate the European groups. So I work with them. So I think we stand as HPB community in Turkey, stand in a great ground, outstanding surgeons, outstanding teams. At Koç, we are really blessed with having really every angle from gastroenterology to cytology to be all experts. It was put together that way. So for me, that's an extra blessing.
HPB organization is doing great meetings every 2 weeks. I love joining them as much as I can. I learn so much from those meetings. I hope it continues, the school, etc. And anyone on the Zoom, if they are from other countries, I hope they enjoyed this meeting. Again, we try to present as possible complicated and problematic cases so that it will be educational to everyone. I don't know what else to say, and I guess we're closing then. All right. Thank you very much. All right.
Thank you very much. Yes. Thank you very much. I also really thank to the organizers and all HPB team. Well, we dealt with the difficult cases, but I have a suggestion. I had clear-cut cases, which we can present another meeting if you like, and we could even increase the number of those cases. So if you agree, society, you can make a slide seminar or something, starting with the really cases which really helped, cytology helped, radiology helped, you know, just clear cut, and we managed it. I mean, we did it, not always the problems. So let's do my cases in another meeting of that
We
kind.
can share it.
No,
We can share it in the national meeting every 2 weeks. We can make a short,
perfect.
if Professor Kerem says okay, because there we discuss our cases.
Perfect.
We consult our cases.
Okay.
We can announce there for a short presentation of typical cases. That would be lovely, but we will decide and let you know.
I mean, that's not a caprice thing. It's not a caprice. Just I want to give a message that it is possible. We don't talk about always the most difficult cases. I mean, most are solved and most are clear-cut. So we can show those pitfalls, how to make it better. Thank you very much. It's a great society. Thank you for this meeting.
Peki, bana diyecek bir şey kalmadı. Herkes kapanışı yaptı. Çok güzel bir toplantıydı Yalın Hocam. Başta Mustafa Kerem Hocam, Gürkan Hocam. Emeklerinize sağlık Volkan Hocam. Eğer müsaade ederseniz 2 haftalık toplantıları, video toplantısı hep aynı kapatıyorum. Eğer müsaade ederseniz oturma son vermek istiyorum. Herkese iyi akşamlar.